السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على رسول الله، وكل عام وأنتم بخير. أهنيكم بعيد الفطر المبارك، أعاده الله علينا وعلى بلادنا باليمن والأمان والاستقرار بإذن الله. I'm Dr. Hiba Osman. I'm a subspecialized breast radiologist, and I'm glad to be your moderator for the morning session today. And I have co-moderator Dr. Hiba and Dr. Haifa in the afternoon and later sessions. We are grateful to have you with us today to experience the power of connecting with professionals who share a similar dedication to fostering improvement and providing quality care to the patients. Today's program aims to enhance your expert in delivering exceptional breast imaging services to your patient and to our community. I will start with introducing Dr. Medina for the opening remark. Dr. Medina is a breast imager, and she is the president of Sudanese Society of Breast Imaging and Women Health. The floor is yours, Dr. Medina.
Thank you, Dr. Hiba. Ladies and gentlemen, esteemed guests and dear friends, on behalf of the Sudanese Society of Breast Imaging and Women Health, it's my honor to welcome you all to our annual Pinkish March Multidisciplinary Symposium. The Sudanese Society of Breast Imaging is Ssbiwh, an awareness in the field of breast imaging across Sudan. Over the years, the Society has conducted training courses, led nationwide awareness campaign, and supported free breast cancer screening clinics. Later, the Ssbiwh joined other women health initiatives and professional bodies to form the Sudanese Society of Breast Imaging and Women Health, expanding its mission to include broader aspects of women health while maintaining its strong commitment to the breast cancer awareness and imaging excellence. This year gathering carries a special and unique meaning because we succeed to meet virtually in spite of our beloved country conflict, which continues for the fourth year, and we were compelled to hold our symposium online. Yet, even in the face of these challenges, our determination had not wavered. Definitely, these pictures are always in our minds and hearts. So, before we begin, I want to take a moment to express my heartfelt wish for healing and peace for my country. May brighter days come soon for all of us. In the midst of hardship, our society has continued to serve our people with devotion and resilience. Tremendous effort has gone into organizing free breast clinics across the safe states of Sudan. This has only been possible through the collaboration of doctors from different specialties, radiologists, pathologists, surgeons, and oncologists, who joined hands to ensure women still have access to early detection, proper care, and hope. Their collective commitment is a true reflection of the spirits of unity and service in our medical community. We are deeply grateful to our distinguished speakers and colleagues joining us from abroad, Egypt, Oman, and Kuwait. Your generous participation strengthens our mission, widens our perspectives, and reminds us that breast cancer awareness and women's health are causes that unite us beyond borders. As we begin this symposium, let's dedicate our effort not only for the scientific exchange and professional growth, but also to the resilience and well-being of Sudanese women everywhere. We look forward to a future where our nation is safe, our communities are thriving, and the women health sector in Sudan can flourish without barriers. Thank you all for being here, for standing with us, and deciding to continue this beautiful journey with us. Thank you all.
Thank you, Dr. Medina, for the warm welcoming. Now I will introduce Dr. Araba Bella. She is the president of the Sudanese Society of the Breast Imaging and Women Health, and she will be welcoming the speakers. The floor is yours, Dr. Araba.
بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين. بسم الله. السلام عليكم ورحمة الله وكل عام وأنتم بخير. Good morning and hello everyone. Breast cancer remains the most frequently diagnosed malignancy and continues to be one of the leading causes of cancer-related mortality among women worldwide and in Sudan. Breast imaging has evolved into a highly specialized subspecialty within radiology. The field has greatly advanced through rapid developments in imaging technologies, enhancing both diagnosis and the patient care. The theme of this year's Pink October celebration is early breast cancer. We place particular emphasis on the vital importance of early detection, which not only improves outcome and save lives, but also plays a crucial role in reducing false positive results and unnecessary anxiety they bring to the patients. I am truly delighted and excited today to welcome distinguished experts and highly skilled breast radiologists to this symposium. We are honored to have with us our esteemed colleague, Dr. Merit, and we warmly welcome back Dr. Amal Hijazi for a second time. We are equally privileged to have and to join by by our valued guest, Dr. Latifa from Kuwait and Dr. Aziza from Oman. In addition, we extend a warm welcome to the speaker, Prof. Muhammad Al-Mu'tasim, and all speakers from the Sudanese Society of Breast Imaging and Women Health, representing all specialties, radiology, surgery, oncology, and pathology. Their collaboration embodies the true spirit of multidisciplinary care in the fight against breast cancer. It's also our great honor to have Prof. Muhammad Al-Mu'tasim with us in these opening celebrations. And his presence marks a significant recognition of the collective effort being made to raise awareness, promote early detection, and advance patient care. Our aim remains to provide meaningful insight into the complexities of breast diseases and the latest imaging technologies. We hope that all attendees, regardless of their level of prior knowledge, will gain a deeper understanding and benefit from the remarkable advances in this field. Thank you.
Thank you, Dr. Rabab. I'm glad to introduce Professor Mohammed Al-Mu'tasim Abdelbagi. He is a professor of radiology, National University, Khartoum, and he is a fellow of Royal College of Radiologists, UK, and a fellow of Faculty of Radiologists at Royal College of Surgeons in Ireland. Thank you very much for being with us, and thank you for the dedication to the society. The floor is yours, Prof. Mu'tasim.
Bismillahirrahmanirrahim. You have to disable screen sharing. Screen sharing, please, not yet.
Are you able to share now?
Are you getting it now?
Yeah. Are you able to share?
Yes. Can you see the screen now?
No, we cannot.
No.
Is it coming
Yes, we
up?
can. Yes.
طيب بسم الله الرحمن الرحيم. على مدى 11,700 كيلومتر from Calgary in Alberta إلى مسقط in عمان ينتظم هذا الإرخبيل العلمي البازغ على أمل أن يتنزل على جرح بلادنا في صفاء زاهية وبلسما شافيا. ويا بلادي كما قال الخليل كم فيك حازق وأضيف عليه ويا بلادي كم فيك حازقات باسقات. السلام عليكم. هذا جهد عظيم، هذا جهد بشارة لغد أفضل. My presentation today, ladies and oncoming gentlemen, is about the MDT, the importance of MDT, the intricacies of MDT, and the value of MDT. And with great pleasure, I recall that about 4 years ago, we started a major collective MDT meeting in Khartoum in March 2022. I hope we meet there again. And we also recall the good happy times when academic activity was very turbulent in our universities and institutions. So why should we have an MDT meeting? All the international authorities of clinical practice have very strongly recommended holding MDT meetings. You can see that it's the American College of Radiology with the appropriate criteria, the Royal College of Surgeons, the Royal College of Pathologists, the Royal College of Radiologists, and the Royal College of General Practice. See, all these colleges are committed to the concept of MDT meetings. What is the advantage? The advantage is that you will get a coordinated care between different specialties at one single time. Second thing, it improves communication between all stakeholders. It also emphasizes the patient-centered care. It improves the patient's experience. It enhances the outcome, of course. And it's also very important, it solves complicated cases. All practitioners in tertiary care centers who are supposed to be the experts, every day they will face problems which are difficult to solve. So this is important. This is a venue where we would help them to do so. It's also make sure that the practice is evidence-based practice. The meeting should foster innovations, new ideas, new technique, modifications of technique, application of ideas and literature to the local environment in the country or in the specific hospital, because not everything works in all locks. Of course, it's a requirement for total quality management. It's a cost-effective practice. And of course, it will give participants the essentials CPDs for their registrations. Again, will give the institutions the accreditation. When we get an authoritative body at home, it will not allow college units or teaching hospitals to work if they don't have MDT meetings. And moreover, for the personal interest of all participants, it will give the practitioner a legal support. Why did you do that? Because I got the consensus from the MDT meeting college. Now, time has gone where you just find a clever doctor and he will do it all for you. He will make the diagnosis, he will make the treatment. It's now collective work. وَيَدُ اللَّهِ مَعَ الْجَمَاعَةِ. Now, the positive impact of MDT was not assumed. It was studied by very many workers. And they came to many different conclusions according to the population and the sample size, etc., or the review. And like example here, where you find in clinical oncology that the results showed that out of 50 cases, 66% of them had a change in the management plan. The others have found that this MDT has helped to control the disease progression by just modifying the timing of treatment, modifying the time of treatment, you can alter the disease progression. The other research workers, as you can see here, they say that this has prolonged the survival, which is a very important aspect to the patient and his family. Lastly, as an example, MDTs would provide, of course, high quality care by bridging together the wealth of experience of all individuals and participants. My heart goes to our colleagues at home who are doing a hard job and who are trying to present a good service with very limited facilities under dire circumstances. To have them all over. These are the main centers on the map in the country which are practicing sort of care of breast care and breast imaging. And our young colleagues, from ladies and gentlemen, have now gained an immense experience with ultrasound. Although it's operator dependent, but it has come to be very reliable when controlled by other techniques. So we have to hail them and praise them. Now, working under force majeure and wars is another challenge to all of this. So I send my regards to all those included and those who are not included here. Moreover, our patients who were cured are proud, and they like to share with the community their success of treatment. So the topic again for MDT is the early cancer detection. So you detect the cancer by looking for it, by screening, what is called screening. Screening has got certain age because of the cost and the radiation protection restrictions. There is limited ages where you can start screening asymptomatic patients, like in Saudi, 50 to 69, in USA from 40 to 75. Now there is a special group which has now increasing in number, which is the young ladies with breast cancer. Problem is, this is very aggressive. It's usually triple negative and it has late presentation with metastasis. That age group, we still cannot say to be included in the screening, but then you select those who have familial predisposition or genetic predisposition, particularly families which have BRCA1 and 2, and certain groups of Jews and Hispanics. Also note there is familial clustering of the disease, not in direct inheritance, but observable clustering. Whereas if a lady has a breast cancer, breast cancer, if she has a sister or more, it should be screened about 5 or 7 years before the 50 years time limit for screen. Now, there is always the interval cancers problem. You screen today, looks normal, send the patient away, comes back after 6 months with a very frank lump. They say now AI can see on your mammogram what is invisible to the human eye, however clever you are. Now, the main challenge with mammography is the breast density. And as you know, it varies from the fatty breast to the hyperdense breast. And that might mask um, tumors, small tumors, or small calcifications. Whereas the fatty breast, it gives a nice background for you to detect the smallest of microcalcifications or smallest of masses and nodules. And here are examples here on dense breasts. And of course, people use a lot of techniques like compression techniques to spread out the tissues and allow you to see the disease. So when we say early breast cancer, in real life, we try to find what is operable, not only just what is early, because sometimes you see somebody early with metastasis, and that's no good. We want to catch them at the operable timing, stages 0 to 1, 2, and of course some variations of stage 3, whether with neoadjuvant or without. So that's the early type of cancer we want to detect. And so what is detection? How we detect all these things? Detection, by definition, is to make things visible. And according to the laws of physics, detection is to have something measurable. You can measure the density, you can measure the size, you can measure the contrast reaction, etc. It must be something measurable. You call it early detection. Simple thing is the self-exam, which is not very accurate. The clinical exam, again, has got lower sensitivity. Mammogram has taken over as the golden rule for detection of breast cancer. And as we mentioned, if you have a fatty breast, then it's easier to find. But if it's a dense breast, then you have to combine with ultrasound. Ultrasound is very good in dense breasts. The best thing for our setup at home is to combine mammo and ultrasound, because many centers don't have the other facilities like MRI, PET CTs, etc. So please, at home, combine mammography and ultrasound. All. Now, even my practice here, we never do mammography alone. It has to be combined with ultrasound. So there is no point in recalling the patient after he has left your department to clarify things. Now, what is coming is the AI-assisted mammography, which, as we mentioned earlier, the computer might see what our eyes cannot see. And actually, it will not see it only, it will highlight it and exaggerate it for you, so you can't miss it at all. Now, this is particularly for interval cancers. MRI, as you know, is very sensitive. Now, people are promoting now low-dose CT. The same as you do for lung nodules, you can use this for the breast, trying to adjust the dose further, because now you have the low dose and the ultra low dose CTs machines available. Again, people have mentioned the low dose PET CT, like here you can see just a very faint activity, which in retrospect can be seen in CT. But even if I see this again, maybe this is a prominent vein, right? But on the PET CT, there's no problem, no doubt there. Now, again, coming is a molecular imaging as a supplement to mammogram, and you cannot miss such a lesion. The good thing is with all functional activities, they exaggerate. They don't give the actual volume. They give you like 5 times the volume. Now, of special interest is the canine odorology. They say that dogs can smell cancer in the sweat or in the urine. And this has been, we encountered this question in many situations, certain bacterial, TB, you can use the rats, you can use the dogs, which are plenty of them in Khartoum, but please don't come towards them because they are suspicious of serious disease. So apart from using the canine ability to smell, because these animals have got like 6,000 times our sense of smell. The theoretical question is to create an electronic nose which can smell cancer the same way as would the dog. Just like the suitor, you have the fire alarm on your head. You see now in all rooms, that's sensitive to smoke. So maybe one day we will see this happening. Now, with the mammography, you can have the 2D mammography, the conventional T2 mammography. Sometimes you can use, those who have the facilities can use the 3D mammos and the tomosynthesis. Remember, if you have implants in the breast and you're doing mammo, that needs very special meticulous views. You have to get the most experienced technologists to do that. They have to explain the patient. They have to solicit their cooperation before pushing them into the room because it might be a bit uncomfortable. Now, with screening or detection of cancer, it will be very unfortunate if you first encounter metastasis before any signs in the breast. And there are also a lot of cases reported in the literature with advanced metastatic disease before the patient complains of a lump in the breast, and even can come with metastasis in the brain, particularly the triple negative type of cancer. It prefers to go to the brain. And this is a male patient who was reported to have something that looks like a lung cancer, and actually he had an occult cancer, male breast cancer. He had an occult lesion. Now, what's next? If you see the mammogram, first thing your mammogram is shown to you. What will you first do? The first thing is not to diagnose the cancer or not. First thing is to make sure that the technique was appropriate and the examination was complete. If not, you recall the patient immediately. Whether it costs them more money or more trouble, or they come and shout at you, you should recall the patient, make sure that you get the proper examination. And of course, you all know the criteria in all views, and whether you see the pectoralis covering 2/3 of the breast, reaching low down in here. And you must see the nipple in profile. That's very important. And you must see the axilla. Axilla must be shown and included. Otherwise, your staging will be completely out of phase if you don't correct the technical things. Remember to include the inframammary fold must be shown. Don't accept cut off parts, because any tiny place can house a malignancy. And if you are doing ultrasound, we can come to that again. Remember, they must use color. They must apply color, which helps differentiation. So you looked at the mammogram, and you saw there is no need for recall. Now you want to confirm your examination. You're simple, and now at home, you have to add the ultrasound. Then those who have the facilities, if they like or in doubt, they can add MRI. So if these are positive, you've done everything and you made sure this is okay, then the patient is for oncology referral at that time. And certain countries like UK, they have the time limit for the referral for cancer care. course, you will have to arrange the biopsy, and you have to do CT surveillance to see if there are metastases and classify them accordingly. Very important, something I like to express and emphasize is mimickers and masqueraders, where there are certain diseases that look like the tumor. And sometimes the breast tumor would look like something else. It can look like a cyst. So these, we should be very careful when we see them and to make accurate diagnosis. After you've done the surveillance by CT, chest, abdomen, we don't include the brain routinely, but it depends on if it's triple negative, be careful to include the brain if there is a headache or blurring of vision or etc. Now, finally, after that, you take your case to the MTT, listen to all the experts, and enjoy having their opinion and experience. Of course, in the mammogram, the language of the mammogram may be sometimes difficult to people. So you can just have a map like this on your desk if you are a clinician, of course. Radiologists know this by heart. You can just have no harm in having this map. So if they tell you this is at 3 o'clock or this is at 9 o'clock or it's in the middle or retro memory, then you can easily know which quadrant, how far is it from the nipple, which area in the nipple, etc. And that comes from the radiology language in the reports. Now, with ultrasound, because we said ultrasound is very popular in my country, our young colleagues have become expert in doing ultrasound and making a definite diagnosis. You know, there is a difference between benign tumors and malignancy and cysts. Right? Tumors are wider than taller, whereas the tumor may be taller than wider. And whether that's a fibroadenoma or that's a lipoma in the breast, or whether it's a cyst, transonic cyst. But remember, cystic lesions may have solid components. And most important is the pattern of vascularity on Doppler scanning. The other thing is to note is the presence of lymph nodes, because lymph nodes are decisive for the stage, very decisive for the stage. And they can be tiny, very small, only detectable by MRI, whether they're of normal size, enhancing or not enhancing, or they can be very huge, large, filling the axilla. And the level of lymph nodes, whether it's below the pectoralis minor, behind the pectoralis minor, or above the pectoralis minor. And also, if it is supraclav nodes and internal mammary nodes are considered metastases rather than N1, N2, N3 stage. Dr. Hiba, please tell me about the time if I'm exceeding my time.
You have 5 minutes.
Good, thank you very much. Now, when you see the mammogram, you note the size, measured in centimeters or millimeters, and the site. We explain how the site is, and the number of lesions in the breast, and the location of lesions. Okay, because you can have the multifocal lesions in 1/4, and you can have the lesion is spread in more than 1/4. That's important for the surgeon to decide on what sort of surgery he would do if the lesion is operable. And remember, small lesions are not necessarily less harmful than large lesions. This is a small lesion. When I show you the phylloids, that's less harmful, but this is dangerous. You can see metastasis all over the place. The nipple we refer to can be retracted inwards and retromammary tumor. It can be inverted completely, or it can be just infiltrated, but that you can only see with contrast studies on MR or CT or contrast-enhanced mammography. So still for early breast cancer, mammography is the gold standard with the problem of dense breast. Some studies have compared mammography to magnetic resonance imaging, sensitivity and specificity. Mammography, maybe the table is confused, but mammography remains sensitive. Okay. Also MRI sensitive, but mammo is a little more specific compared to other techniques. Now, comparison of AI. This is a journal of artificial intelligence. AI versus radiologists. And I'm glad radiologists are doing very well. I thought this will be knocked down. Okay. But specificity is poor again. Mimickers of the breast, and I hope our colleagues, the pathologists particularly, will show us more of these, because you see a lesion, you tell the patient this is cancer, and then it proves to be not. Patient would have suffered so much during that period till proved otherwise. And here there are a lot of examples where an abscess can look like tumor, okay, or other benign lesions again can look like a tumor. Also, people are afraid always of the inflammatory carcinoma. It takes you again to an advanced stage without biopsy. But remember, granulomatous mastitis can give the same appearance as inflammatory carcinoma, which is a very frightening disease. Mammographic and ultrasound can solve certain things, masses, diabetic mastopathy, etc. Now, on mammogram, you notice whether the lesion is speculated or whether there is associated skin thickening, where there is pores calcification. Okay, but particularly in the breast, sometimes you can have very benign fat necrosis, which can mimic cancer. And remember, now there is a lot of violence at home in my country to women, unfortunately, and the breast may be a target for punching or hitting and these things. So bear that in mind. Very rarely in children you can have huge mass like this. When a huge mass is visible, people always think of sarcoma in any part of the body, but this can be a hamarto, which is benign. So size does not decide whether this is benign or malignant. Remember also, there are certain other rare conditions. In the interest of time, I will not go and tell about this. Fibromatosis lesions sometimes can be very well speculated, mimicking cancer. Granular cell tumors, sometimes our pathologists can pick these things, but our oncologists tend to advise remove them, even if they are small. Masqueraders, tumors masquerading as something else, but look at this. It looked like with nipple Churchill as a papilloma, but this was cancer. Again, the same problem, lymphomas, mixing lymphomas with others. Now, we mentioned large tumors are not necessarily more malignant than others. Remember, you can have the benign phylloides tumor, very huge size. This one technique I not mentioned earlier, which is elastography. It's again, those who have it, they find it very good, particularly to confirm the benign lesions. Other important lesion, which may be, I hope not spreading in my country, is tuberculosis of the breast because of the situations. Never forget tuberculosis in any disease anywhere in the blood. And again, if you look at metastasis and you do the screening, the surveillance, not every lesion in the liver is metastasis. You can have hemangiomas and you can have inostosis or benign bone islands. Should not be confused. One other important aspect to mention is the imaging of the replaced breast tissue, not for cosmetic reasons or for malignancy. So the implants need very careful examination. And of course, MRI is best to show their simple mechanical complications or development of malignancy or lymphoma, like in that case. Of course, the staging will be addressed during this course. And very important is just to find out whether this is operable or not operable, whether in stage 3 would allow you to operate, or you have to go for neoadjuvant therapy. لحضرة جلالك يا وطني يطيب الجلوس من على البعد أو من على القرب ومهذب من أمامك يكون الكلام. شكرا لكم وشكرا لهذا الخبير. شكرا للرائعة هبة في كندا، الباسقة مدينة في شندي، ووصولا إلى الرائد خالد في مسقط. السلام عليكم.
Shukran jazeelan. Thank you very much, Prof. Matasim, for the great talk and the unique cases. Now I will introduce Dr. Rabab Mohammed Ahmed. She is a consultant radiologist, MBBS from University of Khartoum. She is MD Radiology, University of Khartoum and FRCR. She is a consultant radiologist at the Ssbiwh University Hospital and the head of women imaging. She is also the founder of the Sudanese Society of Breast Imaging and Women Health. The floor is yours, Dr. Rabab.
Okay, let me share my screen. Screen share.
Yeah, we can see it now.
You can see
no,
it?
This is Dr. Matasim, is it? Yeah.
إلا
No,
هو
no, we can't.
إلا يعمل يطلع هو عشان أقدر أعمل سكرين شير.
I think you can share, Rabab. Can you try?
I can share. ما عرفت تشير. دخلت. I tried to share. طيب. Screen share. No, I can't. I cannot share. لأنه already في محاضرة البروف مشيرة.
طيب عملت كو-هوست تقدري؟ بروفي can you stop sharing please?
I'm trying. I exited the I thought it will go.
still موجودة يا بروف. محاضرة رائعة ما شاء الله. It's difficult to talk after you.
لا ما شاء الله عليك انت.
It is really difficult يعني the way of your presentation لا يعلى عليه.
ما شاء الله. Why is it still there?
رباب حاولي تاني.
طيب. share.
Is it still there?
لا هسي ما في.
طيب.
Yeah, thank you, Prof.
Is it shared?
Yes.
Yeah.
Yes, we can see it.
You can see it? Now you can see it, huh?
Yes, we can. You can open, yeah, big screen now. Yeah, thank you.
طيب. Shall I start? Okay.
Yes,
بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين. Good morning and welcome everyone again. I'm happy to start this symposium on early breast cancer by talking about stage 0 the in situ carcinoma. My presentation will focus on the evolution of breast imaging and the advancement in the detection and management of DCIS. Here, the points to be highlighted in these presentations. And it is important to start by highlighting TDLUs because it is the smallest functional and histopathological unit of the breast and primary anatomical sites of the most of breast diseases. 75% of breast cancer originate in TDLUs, both ductal and lobular carcinoma. So it is the whole story, or the whole story is related to it. And here we can see it at the end of the ducts, and this is TDLU, which is incredibly small magnified histological image, demonstrates terminal duct, extralobular here, intralobular, surrounded by this small microscopic structure representing acini, this giving the tiny bunch of grapes. And if we compare these, we can see the difference in size and number of TDLUs. And in these thick histopathological sections, we can see here multiple lobules and terminal ducts connected to a major duct. And in this image here, we can see this is the light bulbs appearance representing magnified TDLUs, which are tiny structures filled with contrast due to blush. This is not always occur, but sometimes can be seen. And in this mammogram here, we can see tiny opacities 1 to 2 millimeters, densities representing TDLUs. We can see it because they are surrounded by fat, but not always visible. While in these two here, this is automated ultrasound and this is conventional 2D grayscale ultrasound. The TDLUs are the oval hypoechoic structures which are iso to the fat due to the loose connective tissue, intralobular connective tissue, and surrounded by the reflective hyperechogenicity of fibrous connective tissue or interlobular stroma. And here we can see in the histopathology how it represents or how it is similar to the tree adjacent to it. Here we can see this is Thomas Stafford's image, magnified view of a lobule in transverse and longitudinal sections. Okay, it is magnified. It is usually very microscopic, small structures, unless it is enlarged. And this is a terminal duct, extra lobular terminal duct, and here these are the acini along with intralobular terminal duct. It is obviously visualized in this image because the acini is slightly filled with fluid, distended with fluid. Here this is intralobular and this extralobular terminal duct in the case of mild fibrocystic changes. If we look for this image here, we can see this is a little bit prominent also because it's slightly filled with fluid, but it's smooth and not distorted in a case of fibrocystic, while this lobule here, though it is less in size from this, but it is distorted and it is indistinct, ill-defined in a case of DCIS. These are from literature, while this case it is mine. And here we can see this is a dilated ducts, and we can see how lobules are enlarged. This anterior lobule, and this is a terminal lobule here. It is very enlarged and even distorted in a case of DCIS. While this is normal duct, okay, it is the same like it is hypo or isoechoic to the fat, same because the periductal stroma, it's the loose connective tissue like intralobular stroma appear as low. In background, the reflective connective tissue, interlobular stroma. So here we can see it, but it is not dilated and it is smooth. This is just a magnified view. Compare it to these irregular dots, okay, in a case of DCIS. So what is DCIS? DCIS is a non-invasive breast cancer, and here we can see this is the normal duct, the internal normal epithelial layer and the outer myoepithelial layer, and this is a pink layer representing an intact basal membrane. In the other image, we can see the DCIS, which is clonal proliferation of neoplastic epithelial distending the ducts, but is still contained within the duct lobular system by the myoepithelial membrane. And these illustrations represent the natural stepwise history of ductal carcinoma in situ, starting from normal, passing by hyperplasia, atypical hyperplasia, DCIS, and might go for invasive cancer. But in the other example here, however, DCIS is not considered an obligatory precursor of invasive cancer, and invasive cancer can start from the beginning from a normal cells. And there are either in a monoclonal form, as in this case, or multiclonal reflecting genetic heterogeneity. And definitely the pathologists talk about this in a better way. So what is the incidence of DCIS? Definitely after, due to widespread screen mammogram, the incidence has increased from only 2 to 3 to about 15 to 20%. How to be detected? As Prof. Mu'tasim mentioned earlier, we have we have detections and we have diagnosis. The detections means the identifying potential cancer in asymptomatic individual on imaging, and this is the initial steps. It's focused on discovering cancer and it is on its earliest stage, while the diagnosis is working in screening or symptomatic findings to determine whether these indicate the presence of cancer or not. So this is a comprehensive approach aimed to accurately identify cancers. Regarding the detections, as we mentioned, mammography screening is the first step for detection of DCIS. And because the majority presenting as a calcifications, and this is our patient here, we can see subtle distortion with faint calcifications here. So from detection, we have to proceed to work it out, to do the diagnostic workup to make sure if it is real cancer or not. And this is a spot magnification, demonstrate the asymmetric distortion associated with segmental polymorphic calcifications. How to diagnose? Like other breast diseases, by triple assessment, clinical, radiological, and histopathological. Our talk about the radiological assessment. And since the most DCIS present as mammographically detected clinically occult, this emphasizes the role of imaging. Regarding DCIS diagnosis, as we mentioned, the majority are calcified in 85%, and as in asymptomatic patients detected on mammography, and mammography is the excellent modality for detection of microcalcifications. So it is overweight the non-calcified DCIS, representing 15%, and usually presenting as symptomatic conditions like nipple discharge or palpable lump, and on mammography or on imaging seen as mass, architectural distortion, asymmetry, plus or minus calcification. So we need, because as we mentioned, DCIS is not obligatory precursor of invasive cancer. Not all proceed or upstage to cancer, but some are upstage. So we have to weigh the things, our diagnosis, so as not to over diagnosed and over treat with limited benefit. And on the same time, we don't like to underdiagnose and miss breast cancer to improve the medical outcome. And this can be achieved by multimodality methods, combined radiology, pathology, genetics, and adoption of artificial intelligence and advanced imaging technique. How it grade DCIS? There are three types. There are three grades for the like invasive cancer: low, which is grade 1, slowly growing, less likely to recur; intermediate, grade 2, it grows a little bit faster than the grade 1 and with a little more recurrence. While high grade, this is the most aggressive one, fastest growing and giving most recurrence, having aggressive behavior and high tendency to upstage to invasive cancer. Although this is a pathological classification of DCIS, we have mentioned it because it correlates the imaging findings more even than the pathologic subtypes of DCIS. Okay, so what modalities are used to diagnose DCIS? Usually coming to our mind, the three main modalities, starting by the gold standard mammography, passing through the second-door costera, the high-resolution ultrasound to breast MRI. So as not to biopsy all calcification, we have to always remember the typical benign calcifications. And we have to know also not all microcalcifications are malignant. It can be benign microcalcification, and the difference between the two, the benign one generally a little bit denser and larger, more conspicuous, well-defined, having a homogeneous density, uniform size, uniform shape, and slowly growing. While in contrast, the malignant calcifications a little bit finer, like powderish appearance or a cotton wool, because it is hazy and indistinct with lower density and is irregular in shape, different in size, so it is heterogeneous, pleomorphic, and rapidly growing. Before going further, talking about the classifications, I'd like just to mention the new classification of the breast cancer and the new terminology that based on the anatomic site of origin, and this the acinar adenocarcinoma of breast that originates from TDL or in TDL use, and as we mentioned earlier, represents 75%. And because the invasive the in situ component not arise within the duct, it is arise within the terminal duct lobular unit, they consider DCIS misnomer for that, and they call it as CIS. And this group usually have a good prognosis, especially if detected earlier. While the other more aggressive type of cancer is DAPS, which is ductal adenocarcinoma of the breast, originate from the major lactiferous duct and represent 20% of cancer. And because the ductal the in situ component arise in a duct called DCIS. And here we can see this is the high-grade ductal carcinoma, the aggressive type, and the calcification seen distending the ducts, the tumor within the ducts, and the calcification within the tumor casting the ductal system. That is why appear as ductal linear and linear branching calcifications, okay? And this is DAPS. And usually it is high grade, aggressive, with poor prognosis, and can spread throughout the loop, giving the sick loop syndrome. While in contrast, the acinar or the lobular type that arise the AABs, and the calcifications casting the acini or lobule, and when are small floating within a fluid in this acini, it gives this cotton wool or powderish like of calcification, and usually this is an early stage representing grade 1 the samoma body crystals, as we mentioned, floating in the fluid, giving the grade 1 AABs. When it's getting larger, okay, casting part or more of the acini, giving what is called crushed stone appearance, as we have seen here, and this is usually associated with grade 2 calcification due to the necrosis of the tumor within the acini, and as we mentioned, because it is neoplastic, it will be pleomorphic. Okay. Not all lobular or acinar calcifications are malignant, and as we mentioned, it can be small when it is less than 0.5 millimeter. We call it punctate, and when it is more than that, call it round. But in the new classification or in the new BI-RADS atlas, they omit punctate, and all small and large called only round calcifications. And this is generally the calcifications of within when are within the fluid inside the acini. The same principles are too tiny and indistinct and fluffy, okay? And this is mostly seen in adenosis and fibrocystic changes. And if we can do a lateral view and demonstrate layering, it's going to help us in the diagnosis. But later, this acini might involute, okay, and result in this type of calcifications, okay? If we can see here, this casting the lobules, and this is just called involuted calcifications. It is a benign type of calcification. Rarely this round calcification can represent DCIS or can be associated with DCIS. But we have for suspicious morphology, the linear and linear branching is one entity. It is straightforward, as we mentioned earlier. This is ductal type, casting the ducts, and this is representing aggressive type of DCIS. While the other three morphology, the amorphous, coarse heterogeneous, and fine polymorphic calcification, these represent generally or mostly represent lobular types or acinar type of calcifications, okay? And they considered as the positive predictive value varies between these and can represent benign as well as malignant calcification, increasing the fine polymorphic is more malignant than the coarse heterogeneous, and coarse heterogeneous nowadays. Before they thought that amorphous is more heterogeneous, but the new literature suggests that coarse heterogeneous is more suspicious than amorphic calcification. And at the end, to differentiate benign or to make more characterization of these morphologic suspicious appearance, we have to go for the distribution of these. And on the left here, we have the regional and group classifications representing BIRAT 4B. And on the other hand, we have the highly suspicious linear and segmental, because the distribution reflecting ductal classifications. And that is why representing BIRAT 4C per se. And in between, we have the diffuse classification, which represent benign type of classifications. Regarding the segmental fine polymorphic classification, as we mentioned earlier, the polymorphic classification most of the time represent an acinar type of classification, but it can also associated with ductal type of classification when we look at it on cross-sectional image, reflecting the segmental orientations give us impression that it is related, it is a classification within a duct, and this representing almost half of DCIS. Almost more than 50% of DCIS presenting a segmental polymorphic classification. And the positive predictive value of which, when we see it per se without any other abnormality, it ranged from 30 to 50%. So it is BIRAT for B, or even sometimes can be for C. And it is typically the ductal in origin, representing DAP. Okay, here not all ductal calcifications are malignant, and we have the secretory type of calcifications, as we have seen in this image here. Comparing with the DCIS, definitely the difference between the two, as we mentioned earlier, this is homogeneous throughout the duct and smooth margins, more or less regular shape, but definitely here, this is polymorphic appearance, even are ductal, linear and linear branching, but haphazardly oriented with polymorphic density and shape as well as size. Okay, and this is because this type here, the classification surrounded by normal cells, okay, along the ducts, but in this appearance here, in case of malignancy, as we can see here, this is the necrotic malignant cells within the ducts. Okay, it can be irregularly calcified and even sometimes can get fragmented. As we can see here in the histology image, this is ducts filled with cancers and necrotic material. When it get calcified, giving us this type of appearance, and early on can be like this. And if it is, sometimes it can be faint. If we look here, we might pass this as just a benign calcification, but sometimes we need to do a spot magnification view to further characterize the calcification. And here, definitely, this is a malignant type of calcification. So it can start early as fine like this, fine powderish, okay? And then by time can get larger and can extend into the branches, adjacent branches. So this is early on, but still suspicious ductal calcification, and this is advanced when. So getting coarser, it doesn't mean that it is benign calcification. It still can be malignant type of calcification. Sorry for this. So here in these slides, we can see different, again, we return back to amorphous, polymorphic, and coarse calcifications. And as we mentioned earlier, the most suspicious one and most representing a higher grade of DCIS is the polymorphic type of classification, which is the same as the coarse heterogeneous, which is also polymorphic. The only difference between the two is the size of the calcification particles. In fine polymorphic, less than 0.5, and when it is more than 1.5 but less than 1 millimeter, this we call it coarse heterogeneous. So both are polymorphic type of calcification, with denoting suspicious or malignant calcifications. And as we mentioned, this is a higher grade and potentially associated with a higher type or aggressive type of malignancy like HER2 positive. And the more compact the group of calcification, the higher the grade. While the amorphous calcifications usually associated with lower grade, with less aggressive, like luminal A cancer. And as we mentioned, positive predictive value. Earlier, they mentioned all the three are as BIRAT 4B, but in recent literature, they upgrade the pleomorphic classification to either it can be BIRAT 4C as an isolated classification without other associated findings. So the DCIS has typical fine polymorphic followed by coarse and then amorphous and round classification. This is all already mentioned, sorry. Okay, going to the ductal type classification or the fine linear classifications. This is, it can also be like the coarse heterogeneous classification as we have seen here, when it's getting larger, but it's casting the duct. It is a linear type. When it is less than 0.5, we call it fine linear classification. When it is a bit larger, we can call it as coarse heterogeneous classification. But even the coarse heterogeneous classification, when it is linear, it will be more suspicious with a higher positive predictive value, and usually representing BIRAT 4C, even without any associated abnormality on mammography. And even sometimes, if it is in segmental distribution, we can upgrade it to BIRAT 5 when are compact and very aggressive, and usually indicate high grades, DAPS or the ductal adenocarcinoma of the breast, and it has a strong link with HER2 positive. And we have to be cautious. We can see coarse dystrophic type B9 of calcification associated with suspicious type of calcifications, and we should not say this is early dystrophic calcification, the fine one, and especially if it is new type of calcifications. Here we can see fine and linear microcalcification, especially the linear one. We have to proceed for biopsy, and in this case here, it represents. Here we can see fine polymorphic calcification and linear type of calcification, and this is the coarse dystrophic calcification proven to be high-grade ductal carcinoma in situ. Regarding Hiba, what about my time?
You have 2 minutes.
Only? Okay, I'll go quickly. Okay, regarding the size of calcification, we don't measure the particles, but we measure the extent, and we can correlate the previous one. Here, this is example of DCIS, and this is example of fibrocystic. But the question we have to raise: should calcification stability over a period of 2 years always be considered benign? No. This is my patients here presented with this type of calcification and disappear. And she came after 3 years with still a unifocal type of cancer. Just the calcification become denser and associated with this mass. So the stability of suspicious calcification is an unreliable criteria of benignity. And 24.8 malignant calcification were stable 8 to 63 months according to Litov et al. In Radiology 2005, including 12% with invasive cancers. Regarding ultrasound, we will go quickly through the calcified and uncalcified DCIS. Here we can see ductal type of calcifications. Here, calcification within the parenchyma. Okay, and this usually associated with and highly suspicious associated with DCIS, while calcification in a mass is less likely to represent DCIS, and Doppler can help us to detect calcification in parenchyma, as we can see here, that twinkling artifact. And the microbure is the new technique, also enhances the visualization of breast calcifications. And the non-calcified DCIS usually present as mass in 50%, followed by asymmetry, as we have seen in our patient here. This is the invasive cancer. In contralaterals, there is asymmetry proven to be DCIS, and less likely or less common to be distortion, and commonly non-calcified are low grades. And here we can see DCIS, but associated with radial sclerosis on these tomosynthesis, and on ultrasound it was a low grade, as we mentioned, but they attribute this distortion to the radial sclerosis, while this, it is pure DCIS without associated, also presenting with just a distortion, though it is rare, but it is low grade and it's HER2 negative. The non-calcified calcification, the non-calcified DCIS on ultrasound commonly present as a mass, and it simulates the invasive cancer in the morphology. However, it is usually small and without posterior enhancement, without posterior feature, and increase vascularity on Doppler, as we can see in this example here, though the lesions are small but highly vascular. And high vascularity, it's usually one of the suspicious features seen in 68% of malignant compared to 36% of benign lesion. And also the pattern of calcification, we have to look at it, might give a clue for a suspicion. And non-calcified also can present as non-mass-like breast lesions, and this can be seen in up to 61% of ultrasound abnormalities. And pure DCIS reported in 16% of cases. And non-mass is a discrete textural alterations, lack the 3 dimensions and convex border conforming the shape of the mass, and usually hypoechoic. In DCIS, usually hypoechoic, focal, linear, or segmental, with ductal changes, with calcifications, distortion, and shadowing. This is highly suggestive of malignancy, as we have seen in this example, but can be mixture of not only hypoechoic, can be mixed echogenicity or even hyper-echogenic, but associated with distortion. And definitely this is part of non-mass-like like lesions presenting as a ductal changes, and these ductal changes more suspicious for DCIS than just parenchymal types. And here we can see this is the more deceiving area or deceiving lesions to differentiate microcyst from pseudomicrocyst representing malignancies, while these are fibrocystic representing just microcyst. This example here in all these from literature representing DCIS, which are pseudo microcyst. DCIS on MRI is seen as non-mass like enhancement. It is in up to 80% of the cases, and the most common distribution is segmental, and the most common or more suspicious internal structure is clump enhancement. However, it can be seen as also as heterogeneous or clustered rings regarding internal characteristic, or can be linear or focal regarding, but less common regional regarding the distribution. As we have seen here, this is segmental clump enhancement. This is again clump. This is linear, and this is heterogeneous segmental enhancement. Okay. At the end, I need just volunteer to comment on this. Could it be DCIS, the ultrasound image, and the mammography image? Which one is DCIS? This is the last image. Any volunteer? Does ultrasound or can ultrasound image represent DCIS?
السلام عليكم.
عليكم السلام.
دكتورة، يعطيك العافية دكتورة رباب.
مرحبا.
The calcification in the mammogram definitely suspicious, and it's need to be biopsied, at least by RAD4B.
Excellent.
The ultrasound, there is a subtle area of architectural distortion, and it's also by RAD4, and it need to be biopsy.
Excellent.
Can be
you are right, 100% correct. Both are DCIS. Yes, this is architectural distortion representing DCIS on ultrasound. Although this is non-mass-like lesion, it is hyper-echoic, but it's still representing DCIS. And the calcifications is a segmental linear branching calcification, which is by RAD4C. And with segmental, even we can raise it up, and it needs to be biopsy. Thank you very much. Thank you.
Thank you, Dr. Araba, for the insightful, comprehensive lecture. And now I would like to present our next speaker, Dr. Araba Al-Hassan.
Hello. I will share my screen.
So Dr. Rabab Al-Hassan is a
let me unshare my...
I could not. So Dr. Rabab Al-Hassan is consultant radiologist, breast and gynec consultant, Countess and Chester Hospital, NHS, Foundation Trust, Chester, UK. The floor is for you, Dr. Rabab. Thank you.
Hello, everyone. Happy to be with you this morning, and thank you for having me again. Thank you for the lecture, Dr. Rabab, and of course, the outstanding talk from Prof. Mohammed Al-Muqtasim. I will share my screen now.
Stop sharing now.
So please let me know when you see my screen. Can you see my screen?
Yes, we can.
Okay, this is a topic that I'm passionate about, actually, the dense breast, because everyone who has practiced breast radiology knows the challenges that come with the dense breast. And you can't be addressing the early breast cancer without addressing screening, and you can't be addressing screening without addressing the challenges of the dense breast. The objectives of this talk is to understand the breast density and its classification and how it can affect the risk of breast cancer and the breast cancer detection. And we will be reviewing the modalities for supplemental screenings or supplemental imaging incidence breast, and review the key evidence that we have so far. Please be free stop me anywhere and ask questions. I normally give very short talks. So and sometimes I can be suboptimally brief. So please just feel free to to drop any comments that you have. So basically, breast density is the representation of the amount of the glandular tissue versus the fatty tissue in the breast that we can see on mammography. And it is categorized by the Ssbiwh into 4 categories. A being the fatty breast on the left-hand side, and D being the extremely dense breast on the right-hand side. B and C are in the in-betweens, and which so many radiologists argue about when they are categorizing the breast density. And they are arguing because so far the classification is still subjective classification mainly, and that's why we have a lot of inter-reader variability. And to make things even worse, it is not static. There are genetic factors that affect breast density, but not only genetic factors. There are external factors that would affect the breast density, and the breast density during a woman's life cycle is not static, affected by many things, including aging, menopause, and lifestyle factors like body mass index, breastfeeding, HRTs. On the left-hand side, this is the same woman before and after using HRT, and you can see the significant increase in breast density in between. And on the right-hand side, you can see here, this is the lady who was of a high body mass index, and then she lost weight, became, you can see it's in the fat here, the thickness of the fat on the upper breast here, and then the breast density has increased as a consequence of her fat loss. As I said, the assignment of PIRAS category of breast density is still very subjective. Makes it prone to intra-reader variability, actually. So if you are a radiologist and you are presented with the same woman, especially in the in-betweens, the mixed density breast, you might change your mind with the same mammogram. So there is some research about using automated volumetric tools that can measure the breast density and give us a quantitative information, but it's still not widely used and not very reliable. There is not enough evidence so far to use them. There is a promise with the deep learning methods, AI. To provide more reliable assessments, and as you know, the research in AI is going like crazy. So there are studies going on to try to assign a BIRAS category, BIRAS breast density category to mammograms before even they are presented to the reader, which might in the future carry the more dense breast in a separate pathways or something, but still the research is ongoing and we don't have something that's practically practiced on this matter. So it is still a subjective assessment. Why do we care so much about breast density? 2 things. It is an actual independent factor of breast cancer. So women who have dense breasts have more increased risk of developing breast cancer. And it was estimated that in women with extremely dense breasts, category D, they have 2 to 6 folds increased risk of developing breast cancer compared to women with fatty breasts, and this is significant. So you don't have you don't have only a very dense breast that you can't figure out what's going on in it, but you have a breast that is increased risk of cancer, which makes it more scary to read these mammograms. So whenever you read a mammogram of a dense breast, you should always put this in mind. This lady has actually a more glandular tissue and more risk to develop breast cancer compared to a woman with a fatty breast. The other thing is that it can mask, of course, it can mask the abnormality, which is translated to reduce sensitivity of the mammogram on women with dense breast. So you should always remember to put this statement on your report if you are reporting mammograms, not only reading screening. You should remember to put this in your report that this woman has got extremely dense breast and the mammogram is less sensitive. We know that clinicians do not understand this, so we have to spell it to them. If I miss the breast cancer in this lady, doesn't make me a bad radiologist, doesn't make me, liable medical legally, but because actually this test is less sensitive in this specific lady. And the masking effect will lead to later stages of presentations because these women, despite of a negative screening mammogram, they might present, few months later with breast cancer of a higher stage. And this will consequently lead to increased interval cancers in countries where they have screening mammograms. Interval cancers are the cancers that develop or diagnosed in the interval between screening episodes. What is the impact on screening or detection? I will be focusing on screening programs because this is where all the studies are coming from. But it also applies to countries like ours where there are no screening mammograms, but women will have mammograms for one reason or another. So whenever you are reading a mammogram of a dense breast, the breast density plays a role on what you're doing. So currently in the countries where there are population screening programs, mammography is the only method that is being used as on population-wide level. I work in Saudi Arabia right now, and they are doing very interesting things. They are adding DBT, but it's not the standard really. And the screening program is in very early stages to be considered as as a landmark. So as for now, mammogram, the 2D mammogram is the only population screening method that is adopted for practical purposes. And but women who have dense breast do not benefit equally from this screening. So you are screening thousands of women every year, but you are not giving them an equal opportunity for cancer detection. You can put it like that. And breast density is very common, actually. It's not that something that's rare in minority of population. It's not in 1 to 2%. It's up to 40% of women aged 40 to 74, the screening age, could have dense breast tissue. So you have 40% of the screening subjects of the women that you're screening, in which the sensitivity of the mammogram, your screening tool, drops from up more than 90% down to as low as 30% in the extremely dense breast. Not only the detection rate will drop, but the false positive results will increase. It can increase from up to 24 compared to 11 per 1,000. And why the false positive result increases? Because you have a breast, I imagine, you have a breast that you are not really certain about what you are reading. There are a lot of things going on in this breast, and therefore it makes the reader suspect the stuff. So the detection is low and the false positive is high. So the breast density had a lot of implications, and there was a famous lawsuit in the United States where I think she was a doctor who had her breast cancer missed because of her breast density, and many other cases had led eventually that the U.S. Congress actually in 2019 passed what's called National Dense Breast Reporting Law. basically states that the women who have dense breast, they have to be informed in the letter that they get after their screening. So they do a mammogram, have very dense breast, but a negative mammogram. So they get a letter that saying that you have a dense breast, and the mammogram might not be as sensitive as if you have a fatty breast. And they do that because it's in the US, it's the healthcare system is the insurance based. So if you have a legal letter from your healthcare provider saying that your breast is dense, you can actually get authorization from your insurance provider to cover additional modality. In the EU and many other developed countries, including the UK, there is no obligation whatsoever to notify women about their breast density. So the lady will have her screening and then get a negative result letter, which is omitting totally mentioning her breast density. So women basically don't know. So throughout, there have been many talks, many studies about providing supplemental screening in addition to the mammography in ladies with dense breast. So many studies were done. I will talk very briefly about the outcomes. Basically, these are the four main modalities that were studied. Digital breast tomosynthesis, ultrasound, whether it's handheld or automated, and contrast enhanced spectral mammography, and MRI, whether it was full or abbreviated protocols. Before going into individual modalities, I will just mention briefly the current recommendations about use of supplemental screening. The ACR actually recommends that women with dense breast to be offered supplemental breast screening on the basis of individual risk factors. They didn't specify which modality. They didn't specify the interval of screening, and they didn't specify which women exactly, which individual risk factors. So there is a lot of big, it's a bit of a vague statement, but at the same time, it will allow you, the radiologist, I guess, some freedom in recommending supplementary screening. The European Society of Breast Radiology actually have recommended supplemental screening with breast MRI every 2 to 4 years in women aged 50 to 70 with extremely dense breast. And this is by far, I think, still the strongest recommendation so far we have. And the British Society of Breast Radiology haven't recommended anything. They didn't update their guidance so far. And we'll talk later about the UK trial. The British Society basically are saying that, yeah, supplemental screening will give you more cancer detection rate, but there is still no evidence of reduction in breast cancer mortality. And this is, being as British as possible in this statement, basically saying that there is not enough reduction in mortality that will justify the cost or the workload of supplemental screening. But what I want to say here is that the recommendations of these bodies, whether it's ACR, European Society, or the PSPR, it is a recommendation. Then the local, regulators or local providers are the ones. It's not the recommendations of ACR and European Society were not yet translated into local guidance. It's not obligatory to the screening programs that to provide these things. That will need something legislative. So starting with the TOMO, it does reduce the recall rate and increases the cancer detection rate for invasive breast cancer. Still less effectively in extremely dense breast. It has got increased sensitivity, as anybody who practices TOMO knows that the architecture distortion is better seen on tomosynthesis. and it will reduce the overdiagnosis. And I can see that on my daily practice now, because we have DBT in addition to do D mammograms in screening here. So it does help you a lot when you are reading mammograms of dense breast, really. As supplementary screening method, however, it underperforms when compared to other modalities, when compared to MRI, basically, for extremely dense breast. So it does increase the cancer detection rate slightly over the 2D mammogram, but it still underperforms when compared to MRI, for example. So on your left-hand side, there is an image of a 2D mammogram. You might argue that you can see something, but the DBT actually makes it very obvious that there is distortion in this area. A characteristic that Tomo is famous for. Ultrasound, whether it's handheld or automated, and I will talk a little bit more about ultrasound for a good reason, because it's available. It's really available, especially in our country. People are used to use it. We have many professionals who can perform ultrasound, including radiologists and technicians. So it's widely adopted tool. It's available and affordable. It can be anywhere. It doesn't need like a special equipment or a special room or special preparation like MRI, for example. And it does not involve any radiation. It does not involve any injection of contrast material. The handheld ultrasound has got some advantages over the automated version, because you don't need to purchase any new equipment if you have a linear probe. A final assessment can be made. So you detect something, you make a final judgment about it. You don't need to bring the patient back for a targeted ultrasound or second look ultrasound. It's accessible, especially, as I said, in our country and in rural communities. All you need is your ultrasound machine on and a trained provider. The automated breast ultrasound allows you a larger field of view, maybe standardized a bit. It's multi-planar and can give you scene section display, but you will need additional targeted ultrasound, because you will read the examination, the technician will perform the examination, you will read the examination, and you will need to bring the patient back for targeted ultrasound of the area of abnormality. I think, and everyone can chip in for this one. I think ultrasound is the our greatest chance in countries like Sudan to detect or to provide additional imaging for women with very dense breast, especially if it is provided against the individual risk. So, for example, if I have a patient with a very dense breast and I know that this patient has got a significant family history of breast cancer, I would be much more happier if I can provide her with supplementary screening with ultrasound, even handheld ultrasound, and not depend on mammography alone. And I think this will be the future directions. The risk-tailored screening, everybody speaks about it right now. I think it is the future of screening programs that will separate the average risk women from the increased risk women, and ultrasound can be great for this instance. So we should always encourage women to have ultrasound additional to the mammogram, but at the same time we shouldn't omit the mammograms, because there is some understanding, very distorted understanding in this part of the world that, well, ultrasound is better actually than a mammogram, and MRI is better than a mammogram, but it's not the idea of which is better than which. It is the value of each modality. So adding an ultrasound to mammogram in a lady with increased risk for now, until we have the final evidence on this matter. I question that if you can at all. So if for right now, as a clinician, a clinical radiologist, you can advocate for that women with significant family history of breast cancer and dense breast should have additional ultrasound. Put it as a recommendation on your mammogram report. I think it might benefit cancer detection in many women. Ultrasound has got its disadvantages. It has got some low positive predictive value and high rates of negative biopsies. 8% of cancers are occult still at ultrasound and mammogram. The handheld ultrasound, of course, it's operator dependent and it's less reproducible. And it takes substantial time. All of us know that the whole breast ultrasound is excoriation. It's painful. And it takes a lot of, it requires a lot of musculoskeletal effort from the sonographer as well. The automated ultrasound has got its limitations as well. The assessment of the axilla, which is done, routinely when you are doing handheld ultrasound. There is a possibility of missing peripheral regions, especially if you have got big breast, and it's got longer interpretation times. We in the UK we didn't perform automated breast ultrasound. It was not the standard in any of the units that I have seen. So supplemental screening ultrasound, it has been shown to allow detection of smaller invasive node-negative cancers, which were not seen at screening mammography and were not detected on clinical examination. The handheld and automated breast ultrasound luckily had comparable results. So there isn't a big advantage of automated systems compared to conventional ultrasound machines. There was a study that compared the DBT alone versus DBT plus handheld ultrasound, and there was, of course, increased cancer detection rate. But there was also increased false positive rate and increase in the benign biopsies. This is an example of cancer that was detected by ultrasound in the outer breast here somewhere, which was not seen on the mammogram of this dense breast. And this is a mammogram of a very dense breast, and automated breast ultrasound showed an abnormality, and this is a targeted ultrasound of the area that's showing the cancer. This is again was not seen on the mammogram. The modality I love the most is contrast enhanced mammogram. It incorporates vascular. We are not supposed to say functional anymore. Vascular data into the mammogram, in addition to the morphological data. And it reveals all abnormalities that are difficult to see or interpret on digital mammogram or DBT. And multiple studies have shown already the diagnostic performance of the CSM to be similar to MRI, with very similar sensitivity and actually slightly higher specificity in some studies. So compared to the MRI, the contrast enhanced mammogram is much more affordable and available. It avoids the limitations of the MRI, like claustrophobia and metallic implants and allergy to gadolinium. And it will give you the ability to correlate the areas of enhancement with the mammographic abnormalities directly. While comparing MRI to mammogram sometimes might be a pain still. The challenges include the most problematic one is the contrast and contrast reactions, and that's why you will need a physician present, normally a breast radiologist, present in the department while you are performing the contrast-enhanced mammogram. And this would be an issue if you're adopting this technology as a screening tool. You cannot spare a radiologist to be all the time, or a doctor, for instance, to be present all the time in the department to just be waiting and monitoring for occurrence of contrast reaction in one of your subjects. It increased radiation exposure, of course, and still it's not a 3D, but I expect in the future this will be a thing. Because of the performance of the contrast-enhanced mammogram, I think more units are adopting it, and more research, and the manufacturers themselves are are racing into giving us more options and more advancements in this technology. Versus when compared to digital mammography, this study, for instance, very famous study, Song et al. Performed over 900 contrast-enhanced mammograms. The dense breasts were in 77% of the subjects, and the CSM showed improved cancer detection rate and improved a positive predictive value. The sensitivity was 87% versus 50% for the digital mammogram. We're talking about dense breasts here, and the specificity was up to 93%. The digital mammogram, of course, has got higher specificity because you really see what's cancer. So it is the study concluded that the contrast-enhanced mammogram is a promising technology for screening women with higher than average risk of breast cancer. And this is an important statement: the higher than average risk. Again, the risk tailored screening. So we are not, even the study is not suggesting that to give all women with dense breast contrast-enhanced mammogram, but it's to be tailored to the risk of individual clients. And again, contrast-enhanced mammogram is a modality that can be adopted in countries like ours because it's less expensive than MRI. It does need, more affordable structure and room and everything. And it gives you comparable results to MRI. So I think CSM is also a promising technique for countries like Sudan. So this is a comparison of, this is a 2D mammogram in a very dense breast, obviously, and this is the recombined image from the contrast-enhanced mammogram. This is the post-contrast image showing only the enhancing areas. There is a lot of background enhancement of the glandular tissue, but you still see the enhancing tumor here, and this is the MRI image that shows the same area. Another example of extremely dense breast. You can't see anything within this breast, basically. And this is a contrast-enhanced mammogram showing a very small enhancing cancer. And this is the MLO, and these are the Ssbiwh. Moving to the MRI. How am I with the time?
2 minutes.
Okay. MRI, including full and abbreviated protocols, also have got superior cancer detection rate when combined with mammogram, especially in women with dense breast and increased risk of breast cancer. It is the most sensitive modality still for detecting invasive and DCIS. ACR recommends screening MRI in high-risk women regardless of their breast density, starting age of 25. And then MRI plus mammogram is starting at age 30. In the UK, we did the same. Recent ACR recommendations also to do supplemental MRI for women with personal history of breast cancer and dense breasts, or those who received their cancer diagnosis before the age of 50. In the UK, what we used to do, it was case-by-case basis. So basically, we do surveillance mammograms for women after breast cancer treatment. But in the MDT, you can still argue that, well, the initial cancer wasn't seen on her mammogram, it was seen in another modality. So these women will also have MRI screening, surveillance, I mean. It has got superior sensitivity. It has got ability to show 3D detailed anatomy of the breast, chest wall, axilla. You can see other structures as well. It has got functional vascular information about tissue composition, about the vascularity, about chest wall invasion, and it has got no radiation. So the full MRI protocol also give you additional information to differentiate between benign and malignant lesions. The abbreviated protocol, which is probably, if MRI to be adopted as a screen, it will be an abbreviated protocol. It is a shorter screen examination time. It is less cost, and it will give you similar clinical performance in terms of screening to the full protocol MRI. When it was compared to supplemental ultrasound, the cancer detection rate, positive predictive value, false positive rates are better with for both full protocol and abbreviated protocol in the dense breasts. It has got a lot of limitations. Affordability and accessibility would be, I think, the most for us. But you know, you need an access, vascular access. It's gadolinium based, so the renal function and allergies and on-site physicians will all be a thing. And as I said, accessibility, and there are contraindications if there is pregnancy and you know, pacemaker and so on. And it will not be feasible for patients with high BMI or claustrophobic, or they have difficulty lying prone for some reason. So far, we're still not having the new proposed machines. So it's still prone examination. So patients' spinal problems will not be able to do it. And the full protocol is very, very lengthy and time, cost time, which means cost money for departments. The DENSE trial, which was out in 2019, studied the women with extremely dense breast and negative mammograms, aged 50 to 75. They enrolled more than 40,000, and their primary outcome that with MRI screening, there is fewer interval cancers, 2.5 in 1,000 versus 5 in 1,000 for digital mammography. It had a high false sorry, yeah, just got distracted for a second. So it has false positive rate, but false positives, but it has improved in the second round. Dropped basically to 26 per thousand, and it supports the tailored screening as per European Society recommendations. You can read about this study; it's very interesting. And then the famous UK BRAID trial, which was, the results were out in 2025, which is basically a comparison of supplemental breast cancer imaging techniques to identify the best supplementary imaging tool for women with dense breast and negative mammograms. So they compared the abbreviated MRI with the EPOS, with the CSM, and with all of them with the standard of care, which is full field digital mammography. And the primary outcome was that the cancer detection rate, that is the percentage of women who have got positive results and confirmed by histopathology, has increased. The secondary outcomes were included the recall rates and tumor characteristics. We're still waiting for those. 9,000 women, more than 9,000 women were recruited across UK. 6,000 women have received supplementary imaging, and the cancer detection rates were the highest for abbreviated MRI, 17 to 18 per thousand. For the CSM, very, very similar, 15 to 16 per thousand. For the ultrasound, it actually underperformed. It was 4 to 5 per thousand. These are the cancer detection rates in women who had negative screening mammogram in the first place. So you can say additional cancers that were detected. The baseline mammograms detection rate was 5 to 6 per thousand, but this will include all the subjects. Okay, so supplementary imaging demonstrates significantly higher detection rate than the standard of care, which is digital mammography, with the greatest differences noted in the abbreviated MRI. But everyone was saying that actually the CSM did not underperform, really underperformed compared to the MRI. So the recovery rate following the CSM and MRI was similar, 9.7%, and for significantly higher than the APOS and the mammograms. And the average size of cancers detected by MRI and CSM were smaller than ultrasound, was around 10 to 11 millimeter versus 22 millimeter for APOS. So the conclusion was abbreviated MRI and CSM detect 3 times as many invasive cancers compared to ultrasound, with cancers being half size. And authors estimate that using abbreviated MRI or CSM could detect extra 3,500 cancers per year in the UK, and this is significant. But again, they didn't. The British Society argues that we still don't have real evidence of reduced mortality. So we probably see this in the future. The future directions are, there are so many things where, people are working on right now, AI being the biggest, and the risk-based screening, as I mentioned. Legislation mandates are being discussed as well. As I said, we in UK, we never mentioned whether the lady has got dense breast, and we never recommended any additional imaging. So we need legislation frames for this. The implementation challenges for supplementary screening for dense breast include, as I said, legislative structures, cost, infrastructure, accessibility. But I would love if everybody got the message from today's talk that dense breast tissue is a diagnostic challenge and will affect breast cancer detection, early breast cancer detection, which might negatively affect women treatment journey. All methods of screening reviewed actually proven to have improved cancer detection rate in the dense breast. All methods, ultrasound, DBT, MRI, and CSM, all methods have got higher detection in dense breast. So if you don't have an MRI, don't spare the woman an ultrasound, offer her an ultrasound, and you might get something. We want to improve awareness and accessibility of supplementary screening, and it should be led by radiologists. Radiologists have the duty to educate other clinicians about the importance of supplementary imaging for ladies with dense breast, especially if they have increased risk of breast cancer. Thank you very much.
Thank you, Dr. Rabab, for the informative lecture. Please join me to welcome Dr. Latifa Al-Kandari. She is a consultant radiologist, the head of clinical radiology, Al-Aden Hospital in Kuwait. She is a fellowship-trained breast and body imaging from Tang Hong Singh Hospital in Singapore, and she is fellowship trained in breast screening program at the Memorial Sloan Kettering Cancer Center in New York, USA. The floor is yours, Dr. Latifa.
Assalamu alaikum. Thank you. Special thanks for the organizing committee for the invitation, especially Dr. Rabab. If the presentation is shared?
No, not yet. Yes, we can
Shared,
see
I
it.
think. Shared.
Yes.
Okay. My lecture is role of vacuum-assisted breast biopsy system in breast disease. Definition of the vacuum-assisted biopsy and vacuum-assisted excision is to take a blunt-form. The vacuum-assisted biopsy is to take a blunt-form tissue of the lesion is smaller than 50 millimeter Let me just remove this. Yeah. If the tissue is less than 15 millimeter, then it's likely to excise the lesion, but if it's more than 50 millimeter, it's likely to obtain representative sampling of the area. The aim is to take 4 grams of tissue and aiming to make a diagnosis, and therefore it's not a treatment. Therapeutic vacuum-assisted excision is where the vacuum is being used to replace therapeutic surgical excision. Margin cannot be assessed, therefore it's not used for the treatment of cancer. Advantages of vacuum-assisted biopsy: it's minimally invasive, more practical approach than conventional surgery. One needle insertion with a single incision, safe, takes about 1 hour. Sent outpatient procedure under local anesthesia, quick recovery and return to normal activity. I'm trying to remove this one because this is really goes over the lectures. Okay. Leanne, can you help me? Sorry, I'm asking my daughter to help me. Leanne, can you remove this one, please? هذا شيلي هيك أنا على الكتابة تصير. Okay, thank you. Also, in the advantages, we have a larger sample of tissue removed, reducing the sampling error, which lead to decrease the likelihood of histological underestimation, decrease the imaging histological discordance, decrease the rebiopsy rate, reduce the understaging of the disease, lower upgrade of DCIS to invasive ductal carcinoma, and lower the upgrade rates of P3 lesions. It's also used to diminish the likelihood of subsequent growth on follow-up. This is the history, a table showing the history of biopsy. The fine needle aspiration started in 1990. It was less invasive, cost-effective. The successful biopsy rate was 60 to 70%. Sensitivity 65 to 82. It has high non-diagnostic rate up to 40%. Core biopsy started in 1990, and it was standard intervention for diagnostic breast lesion. It's minimally invasive, lower cost, use 14-gauge sine needle. A successful biopsy rate by 99%, and sensitivity is 80 to 93%. It has quality diagnosis and routinely used method, and was easy to perform. The vacuum-assisted biopsy started in April 95. It was minimally invasive, it's higher cost, successful biopsy rate by 99%, sensitivity is 98%, it's a larger sample, lower false negative rate, lower rebiopsy rate, and lower diagnostic underestimation. The diagnostic upgrade rate is defined by presence of malignancy after surgical excision of the lesion, of a previous biopsy, or during clinical imaging follow-up. You can see here in the table that the ADH after core biopsy, the upgrade rate was 50%, while in vacuum is 20%. And the invasive ductal carcinoma in core biopsy, the upgrade rate was 30%, while in the VAB, it was 10%. So the upgrade is higher in core biopsy than VAB, because the VAB, we have a larger sample of tissue. The indication of vacuum is we have a diagnostic investigation like vacuum-assisted biopsy and therapeutic like vacuum-assisted excision. The indication for vacuum-assisted biopsy: the intracystic lesion, intraductal mass removed with nipple discharge, biopsy from breast microcalcification seen on ultrasound. Lesion is smaller than 5 millimeter and can sometimes be difficult to remove with a standard core biopsy. Solitary complex cystic area in otherwise normal breast tissue, recommended in case of an adequate histological diagnosis to determine whether leaving the nipple is safe in women with requesting nipple conservative mastectomy for invasion or in situ disease, where we put the needle in position beneath the nipple and biopsy specimens are taken 360-degree direction. This is a patient with a mass solid with cystic component. A vacuum was placed under the lesion, and this is marker after biopsy. After the biopsy, it's proved to be papillary lesion with ADH. After excision, it was upgraded to papillary with low-grade DCIS. Vacuum is also used in stereotactic biopsy. where we can see what we can use it in suspicious calcification, not seen on ultrasound, architectural distortion without a mass, very small, subtle, insinuating lesions. And we can see here a patient who have a calcification. These polymorphic calcification were seen in segmental distribution. Stereotactic biopsy done and showed EDH, which was upgraded after surgery to DCIS. Vacuum is also used in MRI, where use the lesion that is not seen under ultrasound or stereotactic biopsy to assess the extension of the disease. Now I will go through the vacuum-assisted excision, which is used to complete excise of the breast lesion using needle larger in diameter than those used, but maintaining its outpatient nature under local anesthesia to avoid surgical excision, which has cost significantly more. The indication for the excision: to excise breast biopsy lesion with histological diagnosis of benign with malignant potential, to replace diagnostic surgical biopsy by removing the entire lesion. Excision of low-risk lesion as papillary lesion with no atypia. The treatment used for intraductal papillary lesion with studies showing resolution of 97% of cases. For excision of benign lesion, when the procedure has been requested by a clinician, a repeated biopsy in case when there is a discordance between radiological and pathological finding. To excise minor gynecomastia, excision of a tumor bed after neoadjuvant chemo in selected cases. Regarding nodules that show growth, such as phylloid tumor, studies demonstrate that vacuum excision has recurrence rate of 5 to 17% when evaluating lesion up to 3.3 cm, with lower recurrence rate in lesion less than 1.5, which makes the procedure an alternative to surgery in benign tumors. We have a recommendation of vacuum-assisted biopsy and excision instead of core biopsy needed in certain situations, like the patient wants to have a complete excision, patient with low probability of regular follow-up, patient who are planning to get pregnant, extremely restless patient, patient with a lesion that increasing in size during follow-up, patient who have subject symptoms or pain with BIRAD category 3 or 4. Valdras et al. Published in 2023 retrospective study evaluating data for 116 patients who underwent vacuum aspiration of BIRAD 4 and 5 breast lesion, or lesion with diagnosis of uncertain malignant potential in a previous core biopsy with anatomical pathological result of in situ invasive breast cancer of the aspirated specimen. These patients subsequently underwent conventional surgery to evaluate the existence of residual disease, and the result of the study was promising, mainly for low or moderate grade tumor, which provide a data to support selection of a criteria for future respective or trial on this subject. With Wad et al. Conducted a retrospective cohort study analyzing the amount of spent on treatment for benign lesion and high-risk lesion treated by vacuum aspirate compared to similar lesion treated surgically. The study showed that the vacuum excision in both scenario of benign lesion and in scenario of high-risk lesion has a cost approximately 60% less, so it showed a good cost effectiveness. In case of a lesion with atypia, carcinoma in situ, invasive carcinoma, or lesion with a clinical, radiological, histological discordance, conventional surgery is mandatory in therapeutic management, since the vacuum aspirate violates the basic principle of oncological surgery with the ability to perform single block of excision of a lesion. In addition, to evaluate the margin of a specimen, which must be free of neoplasia. However, there are studies aimed to provide a rule of excision by vacuum aspirate even in these scenarios. This is a table to show the difference between surgical excision and vacuum-assisted excision. In a surgery, it's performed in an OR environment under general or local anesthesia, may require preoperative localization of non-palpable. A larger recovery time depends on the case, provide excellent margin assessment, and has cosmetic impact vary based on excision type. It has a higher overall cost. while the vacuum excision performed in radiology department under local anesthesia with no need for sedation, is minimally invasive, rapid recovery and return to routine activity, doesn't assess surgical margin, excellent cosmetic outcome with minimum scarring and no sutures, is lower cost in 51%. This is another table to highlight the differentiate between the vacuum-assisted excision and vacuum-assisted biopsy. In excision, the aim to replace the therapeutic surgical excision to excise the lesion, performed after core needle biopsy or vacuum-assisted biopsy, using 7 to 8 needle target lesion thoroughly, excise retrieving 5 grams of tissue of more than 12 rotatory tissue samples, used to replace for surgical excision of B3 lesion. The vacuum-assisted biopsy aimed to replace core needle biopsy to make a diagnosis, upfront biopsy or after core needle biopsy, using 10 to 7 needle to target the lesion and receive larger tissue sample, 4 grams, may lead to partial removal of the lesion if the lesion is less, if it is more than 15 millimeter, or total removal if it is less than 15 millimeter. I will not go through high-risk lesion because there is a lecture supposed to be given, but I want to highlight that the management of B3 lesion traditionally was by surgical diagnostic excision, and currently
Sorry,
it's
Dr. Latifa, for interruption. You can proceed because Dr. Nouras, she has a special social issue. She could not present her lecture. So
but
you
it will
can
take,
present.
my lecture
You can
will take,
talk about you can talk about that.
my lecture will take longer time. This is okay?
Yeah, okay. Because she is not going to present unless it is difficult for you.
لا لا إن شاء الله I have water يعني ما في مشكلة إن شاء الله الله يسهل.
Exactly.
High risk lesions in UK breast screening program have a high risk lesion account for 6.7% of all biopsies, ranging from 3.3 to 12.6%. This is histological diagnosis and couldn't be diagnosed on imaging alone, as need histology to make a diagnosis. We should not confuse B3 lesion with BI-RAD3 lesions. B3 lesions are of uncertain malignant potential on core biopsy, heterogeneous group of lesions that can be associated with atypia or malignancy. So what are the B3 lesions? Flat epithelial atypia, atypical intraductal epithelial proliferation, lobular neoplasia, papillomas, radial scar, complex sclerosing lesion, cellular fibroepithelial lesions, and miscellaneous uncommon lesion as vascular lesion, adenomyoepithelioma, and apocrine adenosis. We can see the upgrade of B3 lesion in this table. For atypical ductal hyperplasia, the upgrade to DCI is 20%, while the upgrade to invasive ductal 5%, and the total upgrade up to 20%. All of these lesions, we have different percentages of upgrade to DCIS and invasive ductal carcinoma, which varies from 22% to less than 10% in intraductal papilloma. The main guidelines for the management of the B3 lesion varies. We have the UK National Health Service Speed Screening Program, working group guidelines on diagnosis management of B3 lesion, published in 2018. We have European guidelines, Ssbiwh, and we have third international consensus guideline in management of B3 lesions, published 2023, and German gynecological oncology group guidelines published in 2023. As I said before, the management of B3 lesion traditionally managed by surgical diagnostic excision, and currently is managed by using vacuum-assisted excision. The management of B3 lesion without atypia is excision by vacuum, and we should remove at least 12/7 gauge cores and approximately 5 grams of tissue equivalent to surgical spacement. If the mammographic abnormality size greater than 3 centimeters, then an abnormality should be taken the main one, and a second sign far distant to the lesion should be taken. This is a table will highlight all the guidelines, but all of them agree that they should take the B3 lesion by vacuum. This is a summary for all the guidelines management for B3 lesion. And follow-up of atibia. In UK, they have the lesion without atibia do not require imaging follow-up and patient return to normal screening. And in the presence of atibia, in the UK guidelines, recommended annual mammographic follow-up for 5 years. And recent data from Sloan National Study UK prospective audit for screen detecting of DCIS and atibia showed that the risk of breast cancer at 1 and 3 and 6 years following diagnosis of atibia. The National Comprehensive Cancer Network showed for the women with ADH or lobular neoplasia and or greater than equal to 20% of residual lifetime risk, annual screening mammogram with TOMO to begin a diagnosis of ADH or lobular neoplasia, but not prior to age of 30 years. It's also recommended to consider annual breast MR with and without contrast or contrast-enhanced mammography, so as not to miss an invasive lobular cancer, which might be missed on mammographic alone. Contraindication. Anticoagulant is not contraindication anymore in the recent literature. Bleeding disorder, subcutaneous lesion, lesion immediately adjacent to implant or within a skin or nipple, a goal of excising malignancy. The equipment used, vacuum-assisted biopsy device. This is the machine, and we use 8 to 12 gauge. We have rotational cuts, we have section chambers, vacuum machines. The material is collected in each cycle by a suction through a reservoir. This is the needle, and this is the whole machine. And we have, this is the reservoir where we collect the blood. We have to have high resolution ultrasound unit, scalpel, 25% gauge needle. We have a local anesthesia. We are using simple lignocaine, 1% or combined with 1 to 1,000 epinephrine. And we have to be careful when we are using the epinephrine that we should not inject it into the skin because it causes skin necrosis. And the advantage of using lignocaine with epinephrine is to reduce the bleeding by vasoconstriction, prolong anesthesia to the approximately 6 hours to the patient, and reduces the systemic concentration, therefore making it rare to get a toxic effect. I used to use only lignocaine, but with the new recommendation of the not to stop the anticoagulant, I added epinephrine, which is really good, gives a good result. The attending physician is expected to understand the method as well as the indication. Patient should sign consent prior to the procedure. The valve needle should be from 8 to 14 gauge. The patient lies supine for the inner breast or supine oblique for the outer breast, and with ipsilateral arm and hand should be raised behind the head. We clean the head with disinfecting sterile probe cover. We define the sterile feed with fenestrated wrap or towels. We make a small incision with a scalpel. We introduce the probe under the lesion with aperture toward the lesion. We take a sample and we activate the vacuum and we make a tissue cut. And we have to move the probe from 3 to 9, traveling through 12 position. The vacuum excision technique stipulates that the aspiration be orthogonal than oblique to the lesion, and also stipulates a complete removal of the lesion and preferably to ensure greater diagnostic accuracy. When we are doing vacuum, we have to make sure that we move the probe ultrasound transverse and sagittal to make sure that we are within the lesion and we have moved the whole lesion. The needle used are larger in size, ranging from 7 gauge to 10 for a lesion less than 1. The capacity to obtain a larger and varied amount of tissue. The lesion must be removed as completely as possible to prevent regrowth. Careful ultrasound monitoring of the procedure is mandatory. Extra samples should be obtained in different directions to be sure that the lesion is completely removed. Making clip placed through the probe. Specimen radiograph for the calcification if there is any. A post-procedure mammogram in CC and 90% lateral, 90-degree lateral. This is the needle where we put it below the lesion and we put the vacuum and then we cut to remove the lesion. This is a handheld device for a vacuum. We have two tricks. One of them for the lesion, which is close to the chest wall, we put a spinal needle or a long needle to inject a saline between the lesion and the chest wall to elevate the lesion, but we have to be quick when we are doing the biopsy because the saline can disappear. Another trick to inject a saline between the skin and the lesion or the nipple and the lesion. Bernard sternum maneuver, this is a trick to increase safety and avoid skin laceration in case of masses located in subareolar area. We insert two parallel spinal needles a few millimeters apart just above the probe, and the probe inserted and advanced to just beneath the mass and to remove most superficial portion of the mass. And we turn the probe obliquely and laterally till the mass is completely removed as seen in the image. This is the spinal needle, and this is the vacuum. So if you can see, this is placed here to protect the skin or the nipple. Finding and reporting, then we have to report it. The procedure, you have to mention the approach, the gauge biopsy device, the number of samples, location and type of lesions, type of a clip marker used. We correlate the lesion biopsy with any mammographic finding. We retrieve the calcium if targeted. We mention if there is a hematoma or other complications. The complication will be given by another lecture. So I will go to the limitations. Histological underestimation. Despite the higher report accuracy rate, mammographic lesions that contain ADH during stereotactic VAP still have ADH underestimation rate sufficient to mandate a surgical excision for a diagnosis. Also, incomplete excision was seen at 6 months in 27% of patients, and this is due to effective local anesthesia and bleeding during the procedure. However, the rate of successful initial complete removal of the lesion varies widely from 22 to 100%, although most study report rate of 75 to 100. Follow-up rate without recurrence rate is 62 to 98%. The cost is for the vacuum is more, 5 to 10 times higher than 14-gauge automatic needle biopsy. I will give you a few cases. This is 61 years old female patient with history of operated left breast DCIS for checkup. She came for a checkup. This is a contrast and half mammography. We couldn't see anything in the low images, and in the subtracted images we saw a rounded, well-defined mass in the upper central and the mid-third depth. Ultrasound was done to the patient and showed hypercoic mass in the duct. Vacuum biopsy was done to the patient and showed sclerosis in the ductal papilloma with usual ductal hyperplasia. This is a 34 years old female patient with right breast lump. We can see a hyperdense mass with irregular outline and seen in the upper outer and the mid-third depth. Contrast enhanced mammography showed a peripheral or ring enhancement, nodular enhancement in the lesion. Ultrasound showed a complex mass with a thick wall and thick septation and vascularity within the septation. Vacuum biopsy done to the patient and showed invasive ductal carcinoma. 51 years old, this is case 3, 51 years old female patient with right breast mass showed a hyperdense mass seen in the right retroalar and in the lower inner. The mass has a calcification, and in post-contrast images, it showed peripheral ring enhancement with central solid enhancement of a lesion. Ultrasound showed a complex mass of cystic and solid mass with a vascularity in the solid part. Vacuum biopsy done and showed a papillary lesion with sclerosing adenosis and apocrine metaplasia. The fourth case is for a female patient with right breast lump. This patient showed a calcification in the lower outer and central. I'm not sure whether you can see the calcification, but you can notice here the abnormal enhancement in the lower and outer central anterior mid-third depth. An ultrasound showed and heterogeneous area with indistinct margin, vascularity in color flow Doppler, and calcification. Vacuum biopsy done to the patient and showed high-grade carcinoma with inside to comedo solid pattern. This is a fifth case for 34 years old female patient with right breast lump, showed a solitary duct with hyperechoic mass. Vacuum biopsy done and showed intraductal papilloma. I don't know whether you have a time to show you the video for the vacuum, but I'm trying. This is the video for removal of the lesion. Six case, 70 years old female patient with left breast group polymorphic microcalcification in mammogram. She has failed of stereotactic biopsy of the large vessel that's surrounding the lesion. And this is the calcification. And I thought there is a small area of mass within the lesion. Ultrasound was done. We detected the lesion. It's hypoechoic with calcification. And vacuum biopsy was done to the patient and showed fibrocystic change with intraluminal calcification, columnar cell change, and usual ductal hyperplasia. The seventh case is for 42 years old female patient presented with a bleeding bare nipple. And in the mammo, you can see here asymmetry in the upper outer quadrant. And the contrast image or subtracted images, we can see a subtle linear enhancement. Ultrasound was done and showed dilated duct with hyperechoic mass, which shows vascularity in color flow Doppler. Vacuum biopsy was done to the patient and showed intraductal papilloma. The 8 cases was for 40 years old female patient presented with a bleeding bare right nipple. And we can see a mass, isodense mass, seen in the upper outer quadrant, and we can see the outline, irregular outline for the lesion. That lesion showed in subtracted images peripheral enhancement with enhancement of the septation. There was non-enhancing area seen anterior to the mass. Ultrasound showed a mass of solid and cystic component, previously called complex, and complex is removed now from the lattice spirad. And there was vascularity in color flow Doppler. Vacuum was done to the patient and showed invasive ductal carcinoma grade 3. Case 9 is for 38 years old female patient presented with bleeding bare left nipple and showed a dilated duct with a hyperechoic intraductal mass, which showed vascularity in color flow Doppler. In vacuum biopsy, showed intraductal papilloma. So in conclusion, VAP is a very reliable sampling technique with very few complications. It's relatively easy to use, well tolerated by the patient, reducing the cost of repetitive follow-ups and more expensive additional examination, reduce the time between detection and diagnosis, which is very important for patient assurance. This also have a good prognostic impact because tumors can be diagnosed at early stage and avoid delayed diagnosis with a potential medical legal impact, minimizing overtreatment of high-risk lesion, sustained alternative to surgery. A future direction, maybe in the future, open surgical biopsy for a benign lesion will be eliminated. In case of malignancy, breast surgeon can replace open excision biopsy with VAP to initiate managed breast lesion. VAP and excision devices for therapeutic mini alternation or mini interventions, and a driven lesion may be targeted during VAP. Thank you very much. I came to the end of my lecture.
Thank you very much, Dr. Latifa, for the excellent, engaging lecture. Please join me to welcome Dr. Merit. She is a breast imaging consultant radiologist. She is the director of the Baksh Breast Cancer Center in Jeddah, and she is the chair of our sister society, the Egyptian Society of the Breast Imaging. She is fellowship trained in Toronto University and the Ottawa University in Canada. Welcome, Dr. Merit.
Hi, everyone. Thank you so much for having me. It's always a pleasure to be among the experts of Sudanese society and our extended family and sisters and brothers in Sudan. It's always enjoying the strong program you always provide. Thank you, Dr. Latifa, for paving the way for the vacuum biopsy so I can proceed from what you end at. You already explained a lot about the technique and the indication procedure and the very interesting cases. My talk will cover another aspect, the challenges and the complications we may face during this procedure and how to overcome and how to manage it. Let me share my screen. Okay. Okay. Procedures like vacuum-assisted biopsy and vacuum lesion excisional, which is coming future now for this procedure. We face some complication and challenges during the procedure. I'm gonna cover today, or I categorized it into regarding the challenges we face pre-procedure and during the procedure and post-procedure. And regarding the complication, I categorize it into immediate, early, delayed, but more accurate to categorize it as minor, moderate, which still doesn't need any hospitalization or other, and severe, which is very, very rare and needs some hospitalization. Let's start with the challenge before the procedure started. The main points is patient selection, how to select the appropriate procedure for the appropriate case, and the planning, and of course, dealing with patient anxiety before the procedure. Let's go with patient selection. For best outcome for your procedure, you have to optimize patient selection. It's very essential to have deep understanding of two aspects if you are practicing this procedure. The first aspect is to have a very deep understanding of the management of B3 lesion, specifically when the guidelines and the updates encourage you to do a vacuum and when encourage you not to leave it alone, a lesion. I recommend a very great article, this one from the European Society, from the European Journal, about the management of B3 lesion using vacuum procedures, vacuum assisted procedure. The second aspect in patient selection is patient assessment. Do you assess your patient before giving the patient an appointment? Meaning you need to look at the file of the patient for medical history, comorbidity, of course, the anticoagulation, and patient ability to cooperate with the needed position. Sometimes after you arrange everything and you find patient has shoulder stiffness that cannot perform a stereotactic or have her arm elevated a long time. Any surgery, any radiation, fibrosis, implant, is the patient breastfeeding? So all of these factors need to be assessed even before the appointment scheduled for the patient. Planning. How do we plan? As we said, days before the appointment. We don't plan at the day of the procedure. We plan before giving the appointment for the patient, and then review yourself all the studies. Even if it's studies done outside your facility, ask for any workup that has not been done. For example, this case was booked for suspicious microcalcifications, as was referred from other center where this microcalcification requested stereotactic biopsy. Remember this image. We will come to it later in the in our talk. So, for example, in this case, a magnification view should have been done. Now, for planning for optimum lesion approach, also, this should be done before scheduling the patient. I will choose which modality I should biopsy, as we know, or we all know that as long as we can do it under ultrasound, it's much easier for the patient and for the radiologist. We need to plan for the shortest distance. We need to check for the tissue density, because when it's very dense breast, I will go with larger gauge than fatty breast, and check the compression thickness. I can check the compressed thickness in the regular mammogram study, where you can find in the information about the thickness of the breast, so you can know if your procedure will be able to done, or if it's very less than 2 centimeter compression, you will not be able to do under stereotactic. So maybe I can arrange for a spacer at that day. So all of this information should be checked in preoperative. Now, dealing with patient anxiety, it's every day's problem. It has been documented that radiology patient communication it's an essential factor in a successful procedure and increase patient cooperation. How to deal with patient anxiety? I see the informed consent. It's a very important step. Do it yourself. Don't let your nurse or technologist speak to the patient. Go and speak with your patient. Give 3 minutes connected with the patient. What should we speak about? Speak about the procedure, why it's important for her, and speak about your experience in such a procedure. How did you do something like her cases before? How was beneficial? Speak about the anesthesia and how you are gonna give her anesthesia, and if it's needed, you can increase it. All of these factors serve as verbal anesthesia before even the local anesthesia start working. So your consent is your verbal anesthesia for the patient before you can start your procedure. This is some of the tips for pre-procedure challenges. During procedure, other challenges show up during the procedure while you are in the middle of the procedure. First, lesion approach, as we said, even when you are planning that you have this approach is suitable for your patient and it's short distance, but sometimes during positioning you encounter some challenges. Of course, if you are a lucky radiologist and you have in your facility a prone table, this will save a lot of position challenges. Even in this prone position, some challenges come from the very deep location. So one of the tip in the prone table that we have this technique called arm through hole. When you allow the arm of the patient to go through this opening, it gives you more space to go more deep close to the chest wall. This is the only challenge maybe for the positioning on the prone table. Otherwise, I think we can reach many difficult position. Now coming to the regular stereotactic without the prone table. This is a challenge in many of the cases, many of the lesion. I'm not, I don't see a lot of these well-centered or a lateral lesion. It's always either too deep lesion, too superficial deep lesion, too peripheral lesion. Very rare when you have the ideal lesion in the mammogram stereo. So I will speak about when we have a too deep lesion, when it's very superficial, and when it's very peripheral. Let's see. First, if you have a very deep lesion, what's mean a very deep lesion? Very deep, it carries the risk of colloiding the detector platform. If you injure the detector platform, it's a very serious issue, of course, with your facility and your department, and of course for the patient. So if it's deep, we know that our needle through up to 2 centimeter and anterior to the location. So you need to make sure that you have enough space. If you don't have enough space, it will injure the patient and colloid the platform. So what can we do? First, we can use what's called petite needle. Some vendor have it like petite needle. Some other vendor call it half notch. So it doesn't through the whole 2 centimeter, maybe 15 millimeter, 12 millimeter. And in addition to using a half notch, you can also target the lesion not in the middle of the notch. Here you can see we always targeted in the middle. You can target it in the periphery, not in the middle. So how can we do that? Target a couple of slices higher than the lesion. You have the lesion, then go a bit higher, two, 3 slices, and target this location. So when it's through, it's instead of getting the lesion very accurately in the center of the notch, it will come maybe a few millimeter. So you now you can have a good space, so you are relaxed, you are not worried about going to the other side. Another tip, if you have the lateral approach arm. Lateral approach arm is an arm that accessory that many vendors can provide you. It's like you can have the needle instead of going horizontal, it's going like lateral approach and it's perpendicular to the platform. This is the lateral approach accessory or arm. How about deep lesion? And this is also the positionary chair. Positionary chair is very helpful actually. Yeah, you are doing an left technique, but when she's sitting on the positionary chair, and you can switch the angle of the machine as much as you can have you can have her more relaxed and come from, for example, from the inferior approach while she is lying on the positioning chair. So positioning chair is also a very good tool. How about deep and posterior? Deep and posterior, sometimes it's very difficult and many times we couldn't reach it. I'm gonna just show one of the cases that we used on it, a freehand technique. It's difficult, need a lot of skills and a lot of training, but still doable and some can do it. For example, this case where she had a reconstructed muscle breast reconstructed with the tram muscle, and on her annual screening, this enhanced focus was noted on the chest wall. As you can see, it's very deep. You can see here the MRI paddle couldn't even reach up to this area, deep to this place. So what was done was a freehand technique, which means you position at start as if you are going horizontal, then calculation of how deep you still need to go like this, and then go angulate by yourself, not by the machine. So you are already here, and then you are not using the machine, you are using your hand, and with some angulation, you reach here. Of course, it's very risky. You take more images to make sure that you still away from the chest wall. And then, as you can see, this is the track of the needle, and it was here sampled by this angle, and it came as a recurrence. So the good news, it was diagnosed early, and it was saved. So this is the freehand technique, not common, but sometimes we see it. How about too superficial lesion? The too superficial lesion carries the risk that maybe is a notch can injure the skin, suck the skin, and we need to have to be safe. As we know, part of the needle will be above the pedal. So the same idea, How about first go some slice lower, opposite to the deep, the superficial. So if we target some slices lower, we can have the lesion instead of in the center to be in the proximal part of the notch. The other tip is to inject anesthesia. So you create this paddle of skin above the lesion. As you see, I here I inject a local anesthesia or saline, so you can create a space where the skin is situated above the notch. So you are sure that now you are in safe vacuum procedure. And as I said, we can have the lesion in the proximal notch instead of the center of the notch. So these were for the deep and superficial. How about the peripheral? This calcification, as you can see, it came very peripheral. And no matter how we could get the window, but it still was very superficial, very periphery. The needle would have been like it's even the machine will not be allow you to go. So there is a roll technique. Roll the breast. So if you roll the breast inner, you can have it more inner, and vice versa. If it's the inner side, you can roll it to the outer to outside, so you can have it a bit in the center of the lesion. So we could roll the breast and get it more deep, where we were able to sample it. Okay, now coming to the other challenge while we doing the procedure. So the first challenge was the approach, and we spoke about this periphery, deep, superficial lesion. Now, other challenge during the procedure. Patients and anxiety. Again, we spoke about the patient anxiety before the procedure, but now you are in the middle of the procedure and patients start to be anxious again. Use distraction. Distraction has a lot of techniques. Stress ball. I don't recommend the VR or something hide her eyes, because I like to have eye contact with the patient all the time. This is more assuring for the patient, I think, more than distract her vision. Of course, visual, audio distraction. When your assistant pat her in her leg or in her shoulders, this is also very good technique. Other challenge is the pain she feel during the procedure. So anesthesia, make sure you have all your 3 types of anesthesia, lidocaine as first anesthesia. Provicaine is a slow onset, long acting, and the one with epinephrine is very important as a vasoconstrictor, reduce the risk of hematoma. I'm recommending this article, very nice articles about pain management and how we induce the anesthesia in effective way for the patient. It's have a very nice tips and tricks for even breast biopsies anesthesia specifically. So let's go revise again what we been discussed. We discussed the pre-procedure preparation, how we speak with our patient, manage her anxiety, and give her education about us, about the procedure, and how we optimize the anesthesia, as we said, and how we improve the technique of the procedure, distraction of the patient, visual and audible, any distraction and assurance, and then after we did all these steps, I recommend to have feedback from your patient. When you have feedback from your patient, you can improve more and get continuous training for yourself and for your team. So these are the steps for improving your breast procedure with patient communication interaction. These were the challenges. Now, the last one is post-procedure. What's the challenges after I finish my procedure and everything is okay? After I finish my procedure, I need to check the specimen for integrity. Did I get the microcalcification? at least 3 microcalcification needed to be a successful vacuum sample. If you are lucky, you have a specific radiograph system in your department, or you have another mammogram machine. So when the patient is still on the machine positioned, you can send the specimen and make sure. But sometimes there is no availability for another radiograph system or another mammogram machine. So this will be carry some risk, yani. But what can you do? Do your best and do your post-procedure images while the patient is still positioned, and make sure you get some calcification before you can sample your specimen. One of the post-procedure challenges is the clip position. Either missed clip or migrated clip. How clip is missed? This case has done mass enhancement. It was very challenging case, and after we finished, I was checking my needle where I deployed my clip, but as you can see, unfortunately, I could have the clip still in the needle. It didn't deploy. And you see, I radiograph it. So the clip here, for some reason, didn't deploy. I'm not sure what was the problem, but when you remove your needle, make sure you already deployed the clip is not already in your needle. So sometimes there is a big hematoma, there is a big bleeding. Sometimes when you compress hardly, it's excluded from the incision. So whether is it the defective marker release, like the needle, there is a problem with the needle, or there is excluded from the place you compressed, what you're or you don't know what happened, and then you did the post biopsy mammogram and you didn't find the clip. Anyhow, don't panic. Get the patient on the ultrasound, see the cavity. If the cavity you can see it well, you can place another one, or even if you see there is a lot of bleeding and hematoma, you can wait for 2 days, 3 days, and get the patient back to put the clip under ultrasound guided by the vacuum cavity. You can see the vacuum cavity, put the clip. Even it's better when hematoma is reduced, and you can place the clip, so risk of migration is less. So this case came after 2 days or 3 days, and we place the clip in the cavity. We send her for MRI image, non-contrast, and we make sure that the clip is in the appropriate place. How about migrated clip? This very small, high-risk patient lesion was sampled, and post-biopsy clip was placed. However, in the excisional specimen, you can see the lesion with the microcalcification, but you don't see the clip. Where is the clip here? Can you guess? The clip wasn't even in the region of this lesion. Despite on ultrasound, you can see it was already in a very good place, but for some reason, I don't know, maybe also for the hematoma, the clip was migrated that far. Can you see? So in the day of the biopsy, when we put the clip, even if it's seen in a good position, but this is the benefit that you do a post-biopsy mammogram. So you can see here that the clip migrated. So you document this distance. It's 3 centimeter infralateral to the cavity. So here it was very good that it was documented. You can place another clip here, or if you are sure that you can have it at the day of surgery, so you are already can guide the surgeon that please, at the day of surgery, make sure that you excise at least 3.5 centimeter superior to the clip. So this is what happened here. The clip was 3.5 centimeter below the lesion, and the surgeon was able to excise the lesion correctly. So migrated clip, first tip is to very well documentation, inform the surgeon, and you may place another clip guided by the cavity of the biopsy. So documentation document the shape of the clip. Is the first clip is the circular, the second clip is ribbon, location even within the mass. Is it in the periphery of the mass? It's in the center of the mass. And if there is migration, the distance, the direction, and place another clip within 2 to 3 days, guided by the cavity. So these were the challenges. And let's go with the complication. What complication we are encountering while doing vacuum? Most of the studies document that the major or the highest percentage complication are the bleeding and hematoma specifically, not the major bleeding. And of course, with going with larger gauge like vacuum excisional, it's increased the severity or the percentage of complication. As you can see, hematoma is always the biggest one. Severe bleeding is very less percentages. Infection is very rare, and pain is the second maybe complication. Let's go with some of the common complication. First, this is it's not common, but it happened, and when it happened, it's very for us as a radiologist, we are somehow panicking. What should we do when the patient get a vasovagal reaction while she is already positioned, and even worse, while the needle is already inserted in the breast? So vasovagal reactions sometimes happen, especially when you are in the upright position. Try to avoid this position as much as you can. If you have this positioning a chair, try to have the patient on her side. This is much, much better. Try to make the patient not seeing the needle. While she, like her direction, her face in the other side. This patient, for example, she's on her side, and I'm doing the upright position. However, the patient is on her side, so she hardly seen or barely seen the needle. So what if happened? If happened, recognize the early sign. When you have the patient feel pale, seem pale, and the nausea, lightheads, start early to have her lying and her Trendelenburg position, her legs up, and try to give her oxygen. Of course, I always have the um, emergency cart during the vacuum nearby, even if you don't have in your department, but the crash cart need to be available or near you when you are doing a vacuum procedure. Have a good assistant. This is my Marianne assistant. She's very clever with patients, and when this situation specifically, she helped me a lot. Another complication is skin injury. It's very, very rare, but when it happens, it's very bad. Even with all these steps, sometimes it happened. This patient specifically, she had uncontrolled diabetes, which I didn't notice. This is what we were saying in the start of the talk, that we need to check the patient's file very meticulous. I didn't notice it's uncontrolled. The patient has no sensation. So during the procedure, I was checking with her any pain, anything. So she didn't feel any problem. So it wasn't until I discovered that there is a skin injury. She didn't feel it. So I didn't have any reaction from her that can pay my attention that there is skin sucking. It wasn't until I heard the sound myself when the vacuum started to suck the skin, you can hear it. So this what happened, but it was managed incision at once, instantly, and this is after a few months it come back. But this should not be happen from the start. As we said, always inject anesthesia and saline. Here, for example, this papilloma was proven to have foci of DCIS and need excision. This is the clip at the day of the procedure. We sampled it and place a clip. And I can show you here how I'm using the anesthesia to push the lesion away from the skin. Inject more, see? This is anesthesia, the lesion come deeper This is anesthesia, the lesion come deeper. So this is how I usually do before coming below and vacuum this. I was doing wire localization at the day of surgery after we already sampled and marked the papilloma. But I was showing you how the anesthesia can get the lesion deep to the skin. Okay, so hematoma and bleeding, as we said, make sure check your way if there is a big vessel. Don't use larger gauge unless you need very dense breast, for example, or very scattered calcification. And dense breast expected to have more bleeding. Try to make shorter pathway and anticoagulant. Check the anticoagulants. Do you remember this image from the start of the talk? This was the calcifications that were referred for our department to sample it as pleomorphic and very suspicious microcalcification, and no workup was done. It should have done a magnification view, because once you have done magnification, you can know at once that it was a vascular calcification. Unfortunately, this case the workup was not completed, and when was stereotactic, it lead to a very big hematoma, because we targeted large vessel. So this is one of the very important complications that you can avoid if you complete your workup. Make sure that you avoid any big vessel in your way during vacuum. The patient was treated conservatively, but of course it took like a few months, good few months. So this about hematoma and complication, and a very good article about the bleeding complication and how we can manage it. Infection is very rare as long as you follow the routine sterilization. Everything is trial gel. It should be fine. It doesn't need to be very super sterile procedure, but very careful handling of the tools. So this has come to the end of my talk, and one last item is auditing. For all what we have discussed, auditing is very important. Always audit how many complications you do have, which complication always encounter, how did you manage it, how your team aware about it, how you can reduce its percentages. So auditing is very important. Document all the complication. Don't be shy to document the mistakes. Mistakes is always what make us learn and make us perform better in the future. So always audit your complication and your management. This is outside from the talk, but it's very interesting case. I want to show it. This case came after a year from her lumpectomy for a malignancy. So after a year, this is surgical clip, this is the lumpectomy side, but oops, there's something strange here. There should not be a clip in the site of the lumpectomy. As you know, it should have been removed with the malignancy. But this came after a year, and this was a missed clip from the surgeon, because sometimes miscommunication with the radiologist, the specimen, or maybe he didn't send or she didn't send the specimen for radiograph, and the clip was there. What's the significance of having the clip? That you didn't prove that the whole malignancy was excised, because the clip where the initial malignancy was marked still there. So you have to get this clip back and make sure by the pathology that this area have zero or negative for any malignancy. The patient was very reluctant to do another surgery. So we suggested to make a try with vacuum. So in this case, we used the vacuum. We tried our best to locate the lesion, which was very subtle in the ultrasound. And when we were doing the vacuum and I was withdrawing the needle from the skin, something attached to the skin. Oops. And as you can see, this is the clip. This is the clip. Some of the clip in the periphery of the notch, where it's stuck in the needle and hooked in the skin. here we go, we get it. And as you can see, we could see it by our eyes. We didn't even need to send the specimen for the mammogram to check about the clip. We already get it visually. This was very nice. And the tissue, of course, was sent for the pathology, and thanks God it was negative for any residue for the malignancy. Thank you so much, and thank you always for having me. It's always a pleasure. Thank you.
Thank you very much, Dr. Merit, for the excellent lecture and very fruitful experience. By this, we came to the end of our morning session. On the behalf of the organizing committee, I would like to extend our sincere gratitude to our distinguished speaker for delivering exceptional and engaging lectures. The depth of the knowledge, clarity of the presentation, and valuable perspectives shared enhances our knowledge and experience. We greatly appreciate your time, effort, and contribution, which have provided our attendee with magnificent insights and truly enhance our experience. Thank you very much. And I would like all the audience to open their cameras and to take like صورة جماعية. If everybody can open their cameras, please.
Hi everyone. Hi Rabah. Hi Nan.
أهلا وسهلا.
Hi
سعيدين
دكتورة
نشوفك
نان.
اليوم دكتورة.
أنا
تسلم.
أسعد.
يعطيكم العافية جميعا.
دكتورة ولا.
Very nice lecture الصراحة أحبه وايد.
Thank you. Okay.
I just could not organize it like I'm so sorry. I'm just trying to do it. Yeah, got it. Yeah. يلا 1 2 3. And again.
Say hi.
Yeah, one more time.
Okay.
الأخيرة ما زبطت معلش دقيقة. Yeah? Yes, thank you. Yes, thank you. Nice images. Okay, so we will go for 20 minutes break and we'll reconvene at أنا معلش عشان التوقيت عندي مختلف تماما. خليني أشوف الساعة كم هنا عندكم. So it is 11:35. We can come back at 11:50, please.
Thank you.
Thank you.
أنا بتكلم والصوت كان مقفول ومستغربة إنه ما كان في رياكشن.
إن أي حاجة هسه يا دوب سمعناك.
ما كنت بتكلم وشكرتهم وقلت لهم amazing lectures وكلهم ورباب والبروف ومريت
يا عجين طيب.
ولطيفة وكلهم مبدعين، وقلت لطيفة ومريت دي فرصة للكوميونيكيشن، وده كله طلع إنه الصوت كان مقفول عندي.
تخيلي هم لسه في ما في زول في ولا مشوا ولا يا نقولها تاني إن شاء الله لما نرجع.
نصلي وبعدين الجروب الثاني ناخد. لقيتي دكتورة أمل؟
رسلت ليها حشوفها هسه لو ردت لي.
طيب.
break. Okay, welcome back everyone. I hope you had a enjoyable break. Let's resume our session. We start with Dr. Hiba.
Can you see the screen?
لا ما السكرين ظاهرة بس ما بدت. Okay, I will present Dr. Hiba Mohammed Usman, subspecialized breast, body and emergency radiology, associated professor, University of Calgary, staff radiologist at EFW, Fort Hills South Health Campus, and Richmond Road Hospital, Calgary, Canada. Breast and cross-sectional fellowship, University of McMaster, Canada as well. Body and emergency radiology fellowship, University of Ottawa. Former executive committee member, Sudan Doctor Union, Canada 2020-24. Dr. Hiba, the mic is yours.
Thank you very much for the introduction, and I'm very glad to be part of the Sudanese Society of Breast Imaging. Today, I will be talking about the advanced imaging and early breast cancer detection. My key point, key imaging modalities in detection in the early breast cancer is digital mammography, contrast-enhanced mammography, ultrasound innovation, including the automated breast ultrasound and contrast-enhanced ultrasound. Also, hear me? So I will be talking about MRI and emerging technologies like molecular breast imaging, and I will leave the AI-assisted analysis for Dr. Majduline. Also, I will talk briefly about thermography and dynamic angiography. Detect heat pattern linked to angiogenesis through still, though it is still under validation. The core modality in breast screening is mammogram and tomosynthesis. Mammogram is the primary modality for screening of breast cancer. Approximately 2 to 3 cancers are detected per 1,000 screening mammograms. Tomosynthesis reduces the tissue overlap, improving the detection rate by 30 to 40%. Sensitized to the images.
Hiba,
Yeah.
excuse me, we don't see your screen, or I don't see your screen. I see you.
Oh, okay.
ما ظاهر السكرين.
Yeah, thank you. Can you see it now?
Yes.
Okay, thank you.
Thank you.
Tomosynthesis sensitized to the images lower the radiation exposure while maintaining diagnostic accuracy. Mammogram have 85% sensitivity, while 15% of cancers are mammographically occult and may present with symptoms like palpable mass or nipple discharge. That's why we need to combine multiple modalities to improve the detection of breast cancer. Combined DBT and 2D mammograph and combined tomosynthesis and synthetic 2D mammography demonstrated a statistically significant higher CDR of 6.3 to 7.4 per thousand screened. Higher invasive cancer detection is 4 to 5 per 1,000 screens, compared to 2D mammography alone, which has 4.6 per 1,000 screened for invasive cancer and 3.4 per 1,000 screens, and predictive value of 7%. This is example of 42 years old female came for screening mammogram. In the 2D images, no specific abnormality was seen. And when we looked at the tomosynthesis images here, we can clearly see there is architecture distortion. And this is one of the aspects that the tomosynthesis is very superior to the 2D images, because it will show you the speculation and the pulling of the underlying tissue. This is the tomo compared to the 2D images. And this is the area of architecture distortion. We did targeted ultrasound of the area, and we can clearly see irregular shape hypoechoic mass traversing the tissue. It is taller than wider and suspicious for malignancy. This was biopsied under ultrasound guided biopsy and turned back to be invasive lobular carcinoma. This is another patient, and if you look at the 2D images, you will see there is a circumscribed nodule in the at 6 o'clock position, and we couldn't see any other lesions. And this is the same patient, and this is the current study, and this is the previous. There is no much of the difference, and that circumscribed nodules has been stable since previous, and it is probably benign. When we looked at the tomosynthesis images, this is a partially obscured lesion. It has bulging of the borders, and some of the margins are not clearly seen, but we can see that there is mass effect in that area. This is on the CC, and this is on the MLO. And when we did the ultrasound, we saw a hypoechoic mass that has some angular margin. We did biopsy under ultrasound, and this in here, I'm showing that the lesion is correlating with the mass seen on the tomosynthesis. This is the clip within the lesion, and here the clip is right here. The lesion is around this area, so the clip is slightly migrated posterior and lateral to the original lesion, and this came back as cancer as well. The next modality is contrast-enhanced mammogram. So this combines iodinated contrast with mammography to highlight tumor vascularization. It's offers similar accuracy to MRI for detecting invasive lobular carcinoma and occult lesions. Contrast-enhanced mammography is helpful resolving equivocal findings detected in conventional breast imaging examination. So if we see a lesion that it is equivocal on the mammogram and ultrasound, and it is enhancing on the contrast enhanced mammogram, that make the lesion more suspicious. And we can use the contrast enhanced mammogram also for preoperative staging of breast cancer to evaluate the extent of the disease. Screening contrast-enhanced mammogram could be performed as alternative to breast MRI in women who are at an increased risk of developing breast cancer. And it is also very useful in dense breast, as Dr. Rabab mentioned earlier. Contrast-enhanced mammogram can accurately monitor response to neoadjuvant chemotherapy in patients with breast cancer. This study from Cozy et al. Demonstrate meta-analysis of contrast-enhanced mammography, and that demonstrate that the area under the curve is 0.9. That has very high sensitivity for detection of lesions, and it is considered the overall sensitivity and specificity of contrast-enhanced mammogram is 95 to 81% respectively. This is an example of heterogeneously dense breast. This is density C or D, and the patient came with palpable lesion in the upper outer quadrant of the right breast, marked by a BB marker. Otherwise, if you look at the mammogram, you will not see significant difference between the two breasts. Maybe in the MLO, maybe in the CC, there is more tissue in the outer half, but there is no discrete lesion that can be seen. In the contrast-enhanced mammogram, there is heterogeneous enhancement and irregular shaped mass in the upper outer quadrant correspond to the palpable abnormality. And this came back as invasive carcinoma. This is another patient. She had annual MRI for high-risk Cheese-Codin syndrome, and we see a enhancing lesion in the posterior aspect of the breast. We biopsied that lesion and placed a marker. So this is the follow-up after the MRI and showing faintly enhancing lesion in the posterior aspect of the breast, and this is the marker clip. And this came as invasive cancer as well, with in situ carcinoma, and it is measuring 9 millimeters. The next modality is automated breast ultrasound, and here in Alberta, the gold standard, like the standard of care, we use automated breast ultrasound in conjunction with mammogram for every patient with a density of C or D, and that appeared to increase the sensitivity of the screening program. And the studies showed that combination of mammogram and automated breast ultrasound increased the cancer detection by 2.7 to 4.6 cancer per 1,000 women screened. Screening tool for women with dense breast parenchyma, that is C or D, as I mentioned, and the acquisition time is significantly lower than the handheld ultrasound. The automated breast ultrasound usually take 10 minutes to do the two breasts, and usually our patients are booked for 45 minutes for handheld ultrasound. This is one advantage, and the other advantage that the radiologist can be off-site and review the screening mammograms and ultrasound in a later date, rather than in the handheld ultrasound. You have to be on site and review the images with the technologist and see if you need additional images. That improves the productivity and identified mammographically occult and small cancer missed by mammography. This is a study comparing an automated breast ultrasound compared to handheld ultrasound. The latest study from 2019 done on 398 patients demonstrated that the automated breast ultrasound has more sensitivity of 9.2% compared to the handheld ultrasound, which has only 82.5%. That is related. That is because the handheld is operator dependent. So the technician can easily miss lesions. And then, although the specificity is more with the handheld ultrasound, because the technician is looking at the lesion in the real time, giving you more characteristic of the margins, and take cine images, and then so that make the difference is 80% for the handheld and 77.6% for the automated breast ultrasound. If we combine the ABIST with the tomosynthesis, that will increase the diagnostic accuracy to 90%. And that is very comparative to the MRI, which has 93% diagnostic accuracy. This is another patient with heterogeneously dense breast. She is 67 years old, came for screening, and on the breast mammogram, there is no apparent abnormality. We saw like small nodule in the medial aspect, probably in the lower aspect of the right breast. We did compression views. The lesion is partially dispersed. And when we did the ultrasound of that area, there was no abnormality. This is the automated breast ultrasound for the same patient. This is the right breast. Usually the nipple is in this location, and there is irregular shape hypoechoic mass in the lateral aspect of the right breast. The problem with the automated breast ultrasound, it does not give us a precise characteristic of the margin, so we need to bring the patient back for handheld ultrasound, just targeted to the area of abnormality seen on the automated breast ultrasound. So at 10 o'clock position, 8 centimeter from the nipple of the right breast, in the axillary tail, we see irregular shape hypoechoic mass with angular margin. It is suspicious for malignancy, which was proven to be invasive ductal carcinoma associated with ductal carcinoma in situ. And then we clip the lesion, and the lesion is very far in the axillary tail and partially obscured by the pectoralis muscle. You don't see the lesion very well, and only partially included in the conventional CC images. This just to compare the pre-biopsy with the post-biopsy images, and then still we don't see the lesion very well on the CC and MLO views. That enforces the importance of automated breast ultrasound, or combination of mammogram and ultrasound for the heterogeneously dense breast and extremely dense breast parenchyma. This is the specimen after the surgical specimen with the speculated lesion inside, and this is the magnetic seed. Another patient, mammogram, she came for screening. There is a little bit asymmetrical breast parenchyma in the upper half of the right breast. We don't see the abnormality in the CC view, so we can call it asymmetry. This is the automated ultrasound for the same patient, and there is irregular shape hypoechoic mass at 12 o'clock position. So this is the coronal image that is generated from the ABIS machine. Usually the technician will mark the nipple for you, and we will take 3 sets of images, lateral, AP, and medial images of the breast. And when you put the cursor in the lesion, it will cross-link it with the axial images. On the axial images, it will give you the exact clock, 12 o'clock, and the distance from the nipple, 6 centimeters, and the distance from the skin. So when we did handheld ultrasound for that patient, the lesion is hypoechoic, irregular shape, and the biopsy came back as B-cell lymphoma. This is the PET scan done for the patient for staging, and the lesion in the breast demonstrate mild FDG uptake. Follow-up after 1 year of treatment. This is the ABIS, and in the same location, the lesion is smaller in size after treatment. Still there, but it is smaller in size. So that will help us to reproduce the same lesion in the same pattern every time. Another modality is contrast-enhanced ultrasound. So this uses microbubbles to assess vascular pattern and helping reduce unnecessary biopsies. It showed a sensitivity of 0.9 and specificity of 0.8, which is more than the regular ultrasound. And when we combined the contrast enhanced ultrasound with the regular ultrasound, it just minimally increased the sensitivity of both. This is an example of contrast enhanced ultrasound. So this is irregular shape hypoechoic mass. It does have echogenic center or a coarse calcification in the center. And then there is heterogeneous enhancement of the mass. This is came back as a breast cancer as well. This is a lymph node, so we can see the thin homogeneous cortex of the lymph node. There is homogeneous fatty hilum, and in the contrast enhanced ultrasound, it demonstrates enhancement of the fatty hilum, and there is no enhancement in the cortex. This is abnormal rounded lymph node with loss of the fatty hilum, and it demonstrates no enhancement in the contrast enhanced ultrasound. Breast MRI has a very high sensitivity of 94% for dense breast in high-risk patient. New 3 Tesla systems and abbreviated protocols enhance resolution and reduce the scanning time. The annual screening MRI of the breast is recommended in high-risk patients. Those patients include the women with lifetime risk of 20 to 25% or greater, BRCA gene mutation, and untested first-degree relatives with BRCA carrier, history of chest irradiation between the age of 10 and 30 years. This is an example of a 65 years old woman initially presented with bloody nipple discharge and nipple discharge. So when we looked at the mammogram, we could not see much in that mammogram. There is small, tiny calcification in the retroareolar area. We did magnification views to check for those calcification. There is small linear calcification. The problem with the retroareolar area is really difficult to biopsy, and we cannot position. The position will be very challenging for vacuum assisted biopsy. And there is a smaller lesion in the lateral aspect of the breast for which we did ultrasound and biopsy, and the biopsy came back as fibroadenoma. This does not explain the patient's symptoms of bloody nipple discharge, so we need to do something. So they did a punch biopsy for the nipple, and the biopsy came back as Paget's disease. And then for the nipple discharge, and also the Paget's disease increased the risk of DCIS. We did MRI, and then on the MRI, there is large area of non-mass enhancement in the medial breast. Since we could not see it, this is the sagittal view of the breasts demonstrate the area of enhancement. So since we could not see anything on the mammogram and ultrasound, our only chance is to biopsy this under MRI. And this is the grid of the MRI biopsy. We injected the contrast, we looked for the area of abnormal enhancement, and we used a 9-gauge MRI compatible vacuum-assisted device. This came back as ductal carcinoma in situ grade 3 with focal comedonal necrosis. And always we put a marker after MRI biopsy. So we localize the lesion for the surgeon in regards to the previously placed clip. And the surgical biopsy, final surgical sample came back as DCIS span of at least 3 centimeters. Now I will come back to the molecular breast imaging, and that relies on the functional uptake of the radiotracer technetium-99 system EP. And that reveal cancer that are occult in mammogram to reveal the cancer that all occult on mammogram. The technetium-99 showed a sensitivity of 6.7 to 3.5 per 1,000 screening. And this is a big study done on almost more than 3,000 patients, and revealed that in the year 1 of the trial, 37% of cancer detection in the first year, that those cancers was not detected on a mammogram and ultrasound. In the second year, they detected additional 26 cases by the molecular studies. This is example from the literature. We don't use molecular studies in our institute. So this is a mammogram, and this is technetium-99 image, demonstrate uptake in the posterior nipple line. There is no area of abnormality in the mammogram. When we did the ultrasound in the view of the molecular study, we found a irregular shape hypoechoic mass, and this came back as invasive, grade 2 invasive ductal carcinoma. In conclusion, 95% of stage 0 to 1 breast cancer are curable with low mortality and morbidity, lower treatment costs compared to the advanced breast cancer. That's why we put all our effort to detect breast cancer in its early stage, just to save the patients the mortality and the morbidity associated with advanced cancer. Multiple advancing modalities increase the sensitivity and specificity of detecting of breast cancer. By integrating multiple modalities, taking in consideration the risk factors and the breast density, increase detection of the early breast cancer. Routine screening with mammography in average risk patient can reduce mortality associated with breast cancer which estimated of 28 to 36%. Thank you very much.
Thank you, Dr. Hiba, for this informative presentation. It's great. Thank you. Now it's Dr. Aziza's turn, but she has apologized and will not be able to present due to the floods in Oman. As well, Dr. Nauras has apologized from the session, in the first session. So we will turn to Dr. Majdouline. Can I show the presentation? Can you shift the screen, Dr. Hiba? Okay. Will present Dr. Majdouline Ahmed Mustafa Qureshi, MD, Sudan Medical Specialization Board, Head of the Radiology Department at Tamayuz Emergency Hospital, Khartoum Ministry of Health, Diagnostic Radiology Senior Specialist at Khartoum Breast Care Center and Royal Care International Hospital. Dr. Majdouline, the mic is yours. Dr. Majdouline, can you hear me?
Sorry, I will share the slide in 1 second, sorry.
Okay. Dr. Majdouline, do you facing any problem في presentation?
السلام عليكم دكتورة هبة. Unfortunately أنا مجدولين محمود. You want مجدولين قرشية. I think it is not in the meeting. Can you check with her?
Okay. One. I think Dr. Majdalin is not here. Dr. Aman, are you ready to start?
بس دقيقة مجدولين. قالت الكهرباء قطعت عندهم، حتدخل هسي بس دقيقة.
Okay, تمام.
معلش، بعتذر دكتورة مجدولين، برضو متأثرين بالفيضانات. الله يسهل ويلطف على الناس والعباد. لكن حتدخل هسي.
ربنا يسعدك.
السلام عليكم.
وعليكم السلام ورحمة الله. شكرا مجدنين، تفضلي. شايفة السكرين؟
أيوة.
مهم.
طيب بسم الله الحمد لله والصلاة والسلام على رسول الله. I'm so glad to be here with you today in spite of everything. يعني سبحان الله ربنا ييسر الأمور إن شاء الله. So today إن شاء الله we are talking about early detection of breast cancer using AI. Dr. Hiba إن شاء الله can help me to move on. I am Dr. Maitulin Ahmed Mustafa, graduated from Zaima Asar University and graduated from Sudan Medical Specialization Board 2018 with minimum experience in breast radiology. So today, inshallah, we are talking about early detection and the benefit of AI in this section. So let us start here. Breast cancer, as we know, is the most common cancer among women worldwide, with millions of new cases diagnosed each year. And 1 of 8 women will be diagnosed with breast cancer in their lifetime. So early detection is the single most important factor for survival. So the challenge is why we need the better detection. The answer is early detection, I mean in stage 1, associated with 5-year survival rate over 99% of cases. This percent drop significantly in later stages. So it is better to detect breast cancer earlier in the life. So what is the limitation of current method? As we know, we are starting screening and early detection worldwide. What is the limitation for this method using a radiologist eye? First of one is the human error. Radiologists can miss subtle sign of cancer, especially in يعني في الhard days with reading of 100 scans per day. So high workflow will burn out is by using a detector or reading of huge number of mammogram lead to fatigue and potential error. Also, false positive or inclusive result can lead to unnecessary biopsy, patient anxiety, and increase the cost for country. So the solution is by using the artificial intelligence as a partner. Next. As we know, the AI is nowadays is used as solution for most of human being problems. So the artificial intelligence used as a second pair of eye to provide powerful, tireless assistant for radiologist. Not replacing radiologist, but assistant هذه اللحظة يعني. Machine learning and deep learning AI models are trained on vast database of medical imaging, like mammogram, ultrasound, MRI, to recognize a complex pattern associated with breast cancer. So that means we train the AI to help us. And a recent study suggests that the AI may be able to spot the cancer in mammogram or other breast imaging that even a well-trained radiologist may miss it. As we know, AI used to highlight a suspicious area and providing quantitative risk assessment. Next. Also predicted people most likely to develop breast cancer between mammograms. Some patients, as we know, can develop breast cancer in between 2 episodes of scans or 2 episodes of screening. So AI can predict the patient as this risk, also potentially improving of outcome by catching cancer earlier and detecting interval cancer that can be missed by human eyes and supporting radiologists in their workflow. Also يعني lowering the workload and so on. So AI can significantly improve the early detection of breast cancer by analyzing medical images and patient data that with greater accuracy and consistency than traditional method اللي هو by using a radiologist only. So AI are used to assist the radiologist by spotting subtle abnormalities and identifying higher risk patients and reducing and misdetection. So how can it يعني how will AI improve the early detection? By which mechanism? The AI system trained to help to detect early breast cancer, interval cancer, and provide a valuable assistance to radiologists by what? By which mechanism? By enhancing the accuracy, by detecting a miss cancer, by personalized risk prediction, personalized medicines, and assisting in assessing في tissue density reducing a radiologist workload. As we know, third radiologist can miss some breast lesion, especially subtle changes اللي ممكن احنا نشوفها. وكلنا من البراكتس بنلاحظ انه الانتاجيه بتاعت الدكتورز في الايرلير drop significantly at the end of the day. So by reducing our workload, AI can help the radiologist to improve the early detection. So as a result, reducing the workload and improving overall screening, performance, and patient outcome. How it works? By better of recognition, by imaging analysis, by risk assessment. في ال recognition, the AI algorithm are trained in large database of mammogram to learn to identify subtle pattern of and feature indicative of breast cancer that may be missed by human eye, as we mentioned before. Also, في analysis, في image analysis, deep learning models process various breast imaging modalities such as mammography, ultrasound, and MRI to improve the accuracy of diagnosis and prognosis. Also, في plan and management, the risk assessment AI model like Mirai, developed by MIT, can analyze a patient mammogram to provide a personalized risk score, potentially predicting a cancer risk and up to 5 years in advance. يعني في some studies found that patient developed cancer and AI used to review her previous imaging and can be able to detect an area of cancer 5 years before developing a cancer. In breast cancer, next. In breast cancer, Deep Health AI board breast screening solution in providing to increase the detection rate by an impressive 21%. That by drawing radiologist attention quickly to suspicious lesion, and AI provide powerful diagnostic assistance, improving radiologist interpretation performance of digital breast tomosynthesis screening and mammogram. So by this two mechanisms, AI assists the radiologist to detect breast cancer earlier. طيب عندنا example لل AI اللي هو the algorithm called Mirai, which developed by Adam Yali. Next هبة. An MIT PhD student with objective facilities early detection. يعني الميراي دي الobjective بتاعته to facilitate the early detection. The standard 4 mammogram views are analyzed by the algorithm, following which is interfere patient information such as surgery history and hormone-related factor like menopause. Some comparison to statistical model Mirai provide to be more accurate. يعني ال statistics by Mirai كانت more accurate by comparing the historical data connecting a patient. It was shown that about 42% who developed cancer in 5 years were put in the high risk category by the algorithm. As we mentioned before, here 42% من البيشنت كان الالجوريزم detect انه هم كان develop breast cancer. The contrast in accuracy level become even more evident with the fact that the best existing model only identified 23 in comparison. فكده بنلاحظ إنه يعني إحنا ماشيين we are going fast in يعني more acceptable, more amazing result. In UK, more than 2 million women are screened for breast cancer each year. About 20% of women with breast cancer have tumors that are missed by mammogram screening, which is why many countries mandate that 2 radiologists should date every mammogram عشان to reduce the risk of missing cancer. The augmented AI workflow showed to decrease in woman recall unnecessary for further assessment and modeled a workload reduction by 30%. برضو دي حاجة من ال benefit of using AI اللي هي ال unnecessary recall. ال NHA next كده Caribbean, which is provide health and social care services to more than 500,000 people in northeast Scotland, conducted the first formal prospective evaluation لMIA AI solution اللي هو CE Mark plus 2A in UK as a part of the study with 10,000 with 10,889 patients. Through this evaluation, which may found by UK government AI in health and care aware, may help medical staff to detect more cancers in those patients. The evaluation also showed no increase in the number of women called back necessarily for further investigation because of false positive. برضو دي قلنا من البنفيت. As a part of a stimulated workflow with AI augmentation, a workload reduction up to 30% was modeled. Here we can show some examples. In this image, this CC of right breast. AI breast screening solution called MIA help doctor find an additional 2% more cancer than in routine practice, as announced by the Carrion Medical Technologies في NHS. As we see here, this breast of ACRC, no obvious suspicious lesion. Part of this is lower one in medial part of the breast. When we use MIA AI tools, show 2 suspicious areas. In the inner part, here we saw it by human eyes, and another area in outer part, which is obscured by glandular tissue. Yes, thank you. Next example. Here, the breast cancer can detect by AI algorithm on mammogram 1 year before it was diagnosed by radiologist. These 2 images, يعني this year 2, he almost خلاص develop breast cancer. By using AI, he suspected an area of suspicious. This by using AI في previous images by year 1. Another example. Okay, thank you, Hiba. Also here, there is small yellow boxes. AI system found cancer hiding inside the breast tissue. Previous radiologist missed it, يعني, unfortunately. Another example here for tomosynthesis in 58 years old African American female with the invasive ductal carcinoma and ductal carcinoma in situ. هي عندنا A and B. في ال A عندنا الكانسر located in white boxes which were defined by the ground truth processes. The artificial intelligence يعني here this is a patient with عندها cancer by radiologists white boxes when we use artificial intelligence shows that the same suspicious area يعني which is diagnosed by radiologist. So non-recall cancer exam 1 year prior to cancer diagnosis. Another patient here. Another example here. This is the patient PC. It's the same patient, the same previous patient PC. جاتنا الاريال suspicious اللي كان شفناها في previous image almost develop suspicious speculated dense area with surrounding artificial distortion by AI using here, as we see in image D, the AI make a suspicious area, which is the same area developed later, develop cancer. Another example here, patient, lower image, the lower image, next. The lower image في ال upper quadrant there is a suspicious dense area. By using AI في the previous imaging it detects the box here. Also this is a subtle density. In a heavy day you can miss it here. Another example here. As we see here, this suspicious area detecting by AI. Next, when a radiologist assists AI screening of breast cancer more successfully than they done when they work alone. So, as we see, the AI from these previous images, AI can detect a suspicious area even before إنها to develop a cancer. So, future prospects and challenges. Clinical trust, we should trust the further researches. We need further research and validation to build the clinical trust in AI and to ensure their fairness and traceability and substance in real world. Also, we need collaboration, a collaborative effort between a researcher, clinician, and regulatory bodies. It is critical to successful integrating AI in breast cancer screening program. Also, we need standardized guidelines to develop guidelines and trustworthy AI practice is essential for implementation of AI in healthcare. We need the data requirement to develop model require large, high quality, multimodal database and train an AI accordingly and consistent across institutional data processing protocols. Next. Next. Also, we need clinical validation, more large scale, prospective clinical trials is needed to establish clinical trust and demonstrate a real world effectiveness and impact of AI in breast cancer screening. Also, we need ethical consideration and to address the data privacy, ensuring that the AI algorithm adhere to ethical guidelines. It is important and for responsible implementation and crucial. Next, integrated. Next, Heba. Hello. Into existing screening workflow and training healthcare professionals is effectively used, these tools will be vital for its widespread adoption. In conclusion, AI is not a replacement of radiologists. يعني reassure till now يعني. It is a powerful tool to empower radiologists. By enhancing human expertise, AI enable earlier and more accurate and more accessible breast cancer detection. Also, ultimate goal to shift from treatment to prevention to improve patient outcomes and saving more life through intelligent prospective screening. As Dr. Yasok said, breast cancer is a cancer that has very high probability of being cured if found at an early stage. By using AI technology for cancer screening, we can maintain the accuracy of diagnosis and reduce the burden of radiologists, even if many people undergo medical checkup. Thank you. Last
Thank
slide.
you. Thank you, Dr. Majli, for
Thank you.
informative. Anyone have? Okay, طيب now we will shift to present Dr. Amal Hijazi. She's a consultant radiologist, the chairperson of the Public Radiation and Community Awareness Committee at the Egyptian Society of Breast Imaging, the founder of Lady Scan Radiology Center, the former head of Radiology Department at Ayad al-Mustaqbal Hospital. You can start, Dr. Amal.
انت جاهزة؟ الو انت جاهزة رباب؟ رباب انت جاهزة؟ الصوت متردد هنا. انت جاهزة؟ عمر ما في؟
Dr. Amal, are you ready to start? Dr. Amal?
Yeah. Dr. Amal, you can start.
Amal is not there. هبة.
هي قاعدة بس ما عارفة مالها.
يمكن الشبكة عندها فاصلة.
أيوة، أو المايك مقفول.
أو المايك مقفولة. يمكن بعيدة. خلاص، خير إن شاء الله.
تقريبا الشبكة، لأنه هي فتحت المايك بس صوتها ما واصل. دكتورة هبة، ممكن تتواصلي معاها واتساب أو أي حاجة ممكن.
دقائق بتحاول تظبط المايك.
أوكي.
السلام عليكم.
السلام عليكم. السلام عليكم. السلام عليكم. السلام عليكم. السلام عليكم. السلام عليكم.
عليكم السلام ورحمة الله. المايك معلق شكله بيرجع الصوت.
لا ما بتتكلمش. حد سامعني كده؟
أيوة يا دكتور،
لك انت
صوتك واصل بس بيتردد.
بيعمل صدى صح؟
أيوة
كده سامعيني كويس؟
كده
أيوة
احسن.
كده أحسن. أيوة
طيب عايزيني أبدأ دلوقتي؟
أيوة اتفضلي لو جاهزة.
جاهزة. ممكن نعمل شير سكرين؟
أيوة دكتور هبة هتعمل.
كده تمام؟ كده شايفين الشاشة؟
أيوة بدأت تظهر بس الشبكة لسه ما ظهرت. أيوة كده ظهر.
تمام شايفين.
طيب تمام. طيب أوكي. كده كده انتوا شايفين؟
ايوه شايفين.
أيوة
طب
ظهر.
تمام. السلام عليكم.
وعليكم السلام ورحمة الله. تفضلي دكتورة.
تمام. أولا بشكركم على الدعوة الجميلة دي، بشكركم جدا جدا. ومبسوطة جدا إن أنا معاكم، ويا رب يعني ما أكونش ضيفة تقيلة عليكم خلال النص ساعة الجاية دي، وتقدروا تكونوا مستفيدين من my career in cases. الكارير بتاعي بقاله سنين طويلة، فحاولت أجمع لكم الانترستنج كيس اللي قابلتها على قد ما قدرت. وإن شاء الله أحب جدا إن أنا في آخر المحاضرة أستقبل أي أسئلة منكم. سؤالي لكم في الأول، حابين إن إحنا نتكلم عربي وإنجليش ولا عايزينها كلها إنجليش؟
بناسبك كلنا بنتكلم الاثنين.
هايل. يعني مفيش حد فينا ما بيعرفش عربي عشان نقدر نعرف يبقى الموضوع ايزي واسهل. اوكي، لو حد فينا بيتكلمش لغة عربية بلغيني واحنا نخلي المحاضرة كلها انجلش.
مرحبا دكتورة أمل، شرفتينا.
اهلا اهلا اهلا. انا اللي سعيدة ان
كل
انا
سنة
ببقى
وانت
معاكم.
طيبة.
وانتوا بألف
كل سنة
صحة
وانت
وسلامة.
طيبة.
وانتوا بألف صحة وسلامة وخير يا رب، وسعيدة ان انا في وسطيكوا، وشكرا
واحنا
على الدعوة
سعيدين بك
الكريمة.
كمان. احنا كمان
شكرا
سعيدين بك والله. سعيدين
شكرا على
بك
الدعوة
ومنكم والله.
الكريمة.
الله
شكرا
يجزاكم
دكتورة
خير
أمل لمساعدتك والفلكسبيليتي
على
بتاعتك.
قبول
هاي
الدعوة. كتر
flexible.
خيركم
شكرا
على
كثير.
قبول الدعوة. نحن سعيدين والله، سعيدين جدا إنكم يعني وزعلانين إنه دكتور عزيزة لظروف المطر ما قدرت
اه
تشارك، ما
ان
رسلت
شاء
رسالة
الله
محزنة
تتكرر.
شديد.
اعملوا انتوا، احنا دايما معاكم، مفيش مشاكل خالص.
الله يكرمك يا رب، الله يكرمك يا رب. فما في مشكلة، ممكن تتكلمي يعني الأريح اللي أنت بتحسي إنك how to express أفضل. you can follow. ما
خلاص
في مشكلة، كلنا بنتكلم عربي وبنفهم عربي.
تمام، حلو جدا. يلا نبدأ.
you are welcome.
توكلنا على الله.
هتقدمي الآن half an hour وبعدين في الآخر half an hour صح؟
اوكي زي ما انتوا عايزين، انا معاكم على اي شاكليه انتوا عايزينها، انا موجوده معاكم. شوفوا انتوا حابين ايه، انا معاكم مفيش مشاكل.
ما
تمام.
المرة اللي فاتت كان الزمن قصير يعني، وحالاتي كانت جميلة، ما لحقنا يعني
ان
استمتعنا
شاء الله،
بيها.
وحتى النهارده
عشان
لو
كده
خلصنا وعندنا
عشان
حالات
كده
تانية
المرة دي
بتاعتنا
اديناك
كمان.
2 سلوتس، إذا حباهم ورا بعض نو بروبلم، إذا حابة إنهم يكونوا منفصلات it is up to you يعني.
خلاص احنا نبدأ، وحسب التايم هنشوف الدنيا ماشية ازاي. اوكي
طيب
انتوا كده السكرين واضحة بالنسبة لكم صح؟
أيوة واضحة.
طيب تمام. معلش ثانية واحدة عشان الشير سكرين بس وقف معايا بظبطه. ممكن ابقى اخرجه من هنا، مش هينفع. طيب تمام. فكرة المحاضرة النهاردة إن أنا جمعت لكم الحالات اللي بدأت بيها في الكارير ماي كارير. The objective of this presentation is to identify the most common misleading presentation of breast cancer وما أكثرهم. We will discuss together the solution to reduce the rate of the missed breast cancer. حابة جدا في البداية أبدأ لكم. أنا بدأت أشتغل ولقيت من خلال شغلي سيستم معين أحب أشارككم بيه في المركز بتاعي. أول حاجة وصلت لها إن it is very very important إن كل اللي شغال يكون عنده فورمة زي دي يحطها بالشكل اللي هو حبه. بمعنى إن أي patient will come to you, you had really to let him to answer this question. Very important الكلينيكال داتا، وهنشوف مع بعض ازاي it make difference when we are going in our cases. لازم I had to ask the patient if he come for annual screening or follow up, what is the cause he come to do. He have some lump, nipple discharge, pain, which side, and if he have another previous study. We had to go through all these questions. Give him this paper and let him to answer this all question and read it very good. من ضمن الحاجات اللي مهمة معانا جدا ان احنا نعرف هو عامل عمليات قبل كده، عامل عملية تصغير تكبير، اخد قبل كده عينة، هو positive family history، ايه انواع الامراض المزمنة اللي بيعاني منها. ومحدش يستغرب sometimes بيبقى وجود الديابيتس very important to know. رير ان العينه تيجي بديابيتك ماستوباثي، لكن فعلا مش عارفه اذا كنت عارضه الحاله دي ولا لا، بس لو ما شفناهاش المره دي ممكن اجيب لكم حاله كانت very interesting presented by diabetic mastopathy. وكان الكلو كله ان العينه تكون مجاوبه السؤال هل هي فعلا عندها ديابيتس ولا لا. فانا معاكم خلال النص ساعه دي هشرح لكم ازاي الاند بتاع الجورني بتاعتي انا وصلت لايه. انا اول ما بدات ما كنتش بعمل الشيت ده، كان بيجي لنا الريكوست من البيشنت then go is this she need mammogram okay go to mammogram she need ultrasound، من غير ما يبقى عندنا الباك جراوند ديت. وبعد كده لقيت ان كل سؤال من دول بيأفكت في الريبورت بتاعك والديسيجن اللي انت هتاخديه بعد كده. اي هوب ان كل واحد في المركز بتاعه او في شغله يعمل شيت للعينه تجاوب عليه قبل ما يبدا starting his work. الحاجه الثانيه كمان هو المنظر ده المنظر السنتر بتاعي. انتوا قادرين تتخيلوا كم الشيتس اللي موجوده عندي. العيان لازم يكون عندك له شيت، بالذات لو كان هيعمل سكريننج او فولو اب، لازم الداتا تكون محفوظه عندك. لو ما عندكيش باك سيستم يبقى اتليست عندك شيت موضح فيه الزيارات بتاعت البيشنت، البريفيوس ريبورت، لان العيانه الفولو اب بتاعها بيبقى في منتهى الاهميه. طيب in my center which type of patients انا بشوف عيانين referred to me 20% of my cases بيبقوا for diagnosis and 35 of my patient is for screening and 15 is for intervention and this is the most thing I want. مش عارفة دي واضحة عندكم ولا لأ. هو الdiagnostic non-referral. اوكي diagnostic run referral دول هم اهم حاجه انا وصلت لها. انا نفسي ان انتوا كدكاتره breast imaging توصلوا للمرحله ان البيشنت يستارت with you, not when he have a lump he will go where, when the lady have a lump she will go where, she will go to the oncologist or the surgeon or the gyna obstetrician اللي ولدتها. لا، احنا بنغير فكر السيده دلوقتي ان once she feel a lump she will go to you, the breast radiologist. هم دول اللي احنا مجموعتنا البريست ايميجينج، هم دول اللي had to be the start of the journey, not anybody else. عشان توصلي لكده لازم تبقي عامله clinical examination للبيشنت، عامله good history للبيشنت، وده اللي انا وصلت له by my journey by the end. ان انا البيشنت بيجي لي دايركت اول ما بتحس باي clinical presentation like a lump like a nipple discharge، بتيجي تقول انا عايزه اجي اكشف، عايزه اجي اعمل التراساوند، عايزه اجي اعمل ماموجرام. ودي اغلبيه البيشنت ده. طبعا انا ما وصلتش للكلام ده امبارح ولا اول، لا انا بقالي في الفيلد حوالي 20 سنه، وكان الام بتاعي ان انا اعمل حاجه اسمها بريست كلينيك. ان انا ام نوت فوتوغرافر، انا دكتور كلينيشن. فبالتالي مع مرور الوقت ووجودي في المكان وصلت لان انا most of my patient جاي لي من غير ريفيرر، لا من surgeon ولا من oncologist. So how could this have been missed؟ دايما بنزعج جدا لما بميس كيس. يعني اكتر حاجه تضايق اي راديولوجيست ان حاله تفلت منه، تمام؟ بس لازم كلنا نفتكر ان this is always human error، فمش عايزاكم تنزعجوا لان وارد ان احنا نخطأ. احنا بنحاول نقلل الاخطاء. why we miss lesions؟ ايه الاسباب اللي تخلينا نميس الليجنز بتاعتنا؟ many factors. factor related to the patient انه يكون البرست بتاعها dense، او factor related to the technician اللي معاكي، التكنيك بتاعك فيه مشكله. That's why the quality of the mammogram and the proper positioning is very important. او factor related to the radiologist, ours, we are the one، ان الايميجينج interpretation بتاعنا بيبقى فيه مشكله. So I will go through these three factors اللي تخلينا نمس الكانسر، و through the cases هنشوف كل مشكلة ازاي حليناها. This case is case number 1, 47 years old female with positive family history, come for screening in 2019 and reported as normal. Second annual screening in 2020, she felt query left upper lump. And this was her pictures. أنا بس عايزة أوضح لكم إن أنا when we start, I start with analog mammo, then I go for digital mammo. When I start my career, I have no packs. Then I understand how the importance to have a pack system. So this is the difference between the cases. Sometimes you will see cases I took by analog, then when I bring the machine digital, so the difference will be clear. Or it was taken by some viewer, I couldn't remember its name now, after I bring the packs. So you will find the difference of the films. Anyone can see anything in this high dense breast? Never. But the patient say, I have a lump. So by ultrasound, it was very clear I have this big lobulated, what you will call it, I will call it non-mass, I will call it definitely mass, very clear. But in mammo, you couldn't find this mass, yes? So the pathology revealed infiltrated ductal carcinoma, HER2 positive. We put a clip in the mass, and after that she made conservative, and this her follow-up in 2023, the patient is doing well. So what I can learn from this case, that dense breast is the most challenging case in screening. So it needs other modality, especially in positive family history. Then ultrasound is mandatory in each breast density. MRI is highly recommended in such dense breast. Okay, so I don't know how you make your screening in your country, but here, like the guideline, they make screening by only mammogram, and then they will call the patient after that. And such dense breast, this patient had to be recalled. It had to take 0 by rats, and we will ask for ultrasound definitely as a start, and sometimes we will go for MRI, sometimes no. Okay. Case number 2, 44 years old lady, second visit 2023, first time in 2021 for diagnostic mammogram, complaining of left breast focal hardness. And this is her mammogram. Anyone can find anything? For me, it's okay. I couldn't appreciate her clinical problem. This is her CC views, and this is her ultrasound. This ultrasound showed left breast, 6 o'clock, deeply seated, irregular mass, measuring 2 centi, 1.5 centi, 5 centimeter away from the nipple, and it's abutting the muscle, and saw some desmoplastic reaction by rats 4C. Agree? But where this mass in the mammo? Now I can see it clearly. It is here, and it is here. So what is the problem here? Technical problem. When I do the mammo and it was free, look at again, it was completely free. I couldn't see anything. Yes, but when I do the ultrasound, I can see the lesion. Then I go back to my technician. I ask her, no, there is something in 6 o'clock. Please take the breast good outside. I want to see where is this lesion. And then the technician make, what is this view? This is little bit exaggerated CC view. You see the difference between this and that? You see this? This is the nipple in the center. Agree? Okay. This is CC view, but you see the difference? Now, the nipple is little bit down, and she make the exaggerated view. At that time, I can see nicely the mass. Okay? Again, what can I learn from this case? Be aware about the forbidden zone, not to miss lesion due to unexpected location. Yes? Consider a wide image and consider a patient complaint. That's why I am telling you, if you are in screening program and this lady go and make her mammo and went home, no, there will be no recall. Yes, because you couldn't find anything. But if you have her sheet and she is written in it, I have a mass or I have a problem in my left breast, at that time you will ask her to go for ultrasound. That's why you will not stay in dark room and see your cases without communication with the patient, with her clinical data. So you will miss many cases if you do like that. Consider a patient complaint and the clinical data before radiological study. You had, before you go for reading the mammo or ultrasound, you have to have the sheet of the patient, know what is her complaint exactly, so you can easily detect the problem. Always keep communication between you and your radiographer. Case number 3. 49 years old lady come for screening with 12 years history of bilateral silicone augmentation, known case of follicular thyroid cancer. This is one of my nightmare cases, really. This lady come to me. I did, of course, you know, the silicone, we have 2 view, one with the silicone, one without, either CC or MLO. Okay, this lady coming, remember, for screening, nothing, and she make augmentation for the breast, but when I see this case, I found ultrasound simple cyst along 4 o'clock axis, completely aspirated by me with no suspicious mass, no node, and I would finish my report by annual screening by RAS2. Okay, this lady come to me, and thanks God she come again on 15/3/2023. She did PET CT because she is following for her thyroid cancer, but the PET show uptake at the left breast outer. There is uptake in left breast nodule, and at that time, when she come back, I see what's happened. What is this? I know she is free. Maybe I missed. No. I'm not missing. This is again a cyst. Let me to rescan again. Then I did ultrasound. After I know the target ultrasound, along 2 o'clock axis, I saw this terrible hypoechoic irregular mass. It is very small. It is less than 1 centimeter, but it is there. It is very clearly seen. And this mass was there from the beginning, but I missed. Sure, I missed it. Because the time is very short to develop such a mass. There was no suspicious axillary node. It is one word. It is a bias at 5, maybe 4C, but it is highly suspicious. Again, I did memo for this lady, but I couldn't appreciate anything. Maybe this architecture distortion, or maybe this one, I don't know. But by ultrasound, it is very clear. I took a biopsy and it coming as infiltrated lobular carcinoma, ER, PR positive, HER2 is negative, so she is candidate for in-front surgery. This lady refused to remove the silicone, and they asked for wire localization. I did wire localization for the lady. She went and she make excision conservative surgery, and she come for me for follow-up, and she is fine. So what can I learn from this case? Avoid formulating diagnosis before reviewing the clinical data. Okay, so what is my mistake in this case? When she come back to me, I say, no, it is a cyst, and this is wrong. Okay, avoid trying to ignore other findings. Rescan if your diagnosis is inconsistent with other modalities. If the modalities say take care, there is by PET, there is something active here, please rescan again, and be aware always with additional view in case of silicone. Very important to know that when you have a silicone, you have to make these 2 views. Case number 4, 59 years old female coming for screening for the first time with negative family history. And this was her memo. Nicely, I think you can appreciate this, what you call it, distortion. Yes, agree with me. This is the typical picture of distortion. And one of colleagues write it as query suspicious cyst by ultrasound. It was like this in ultrasound in the axilla, and it is just subdermal. And my colleague, she say it was within the accessory breast. You can appreciate this accessory breast, and within the accessory breast, she finds this by ultrasound. This is only a suspicious cyst. You agree with this? No. Second look, I don't like it, and I ask for biopsy. And the pathologist coming DCIS papillary type. Okay. Another case, 73 years old lady with positive family history come for screening, and this was her memo. I will leave you for 2 minutes just to try to find any abnormalities. I will give you also the CC. You can see anything here? I am quite sure ان في ناس هتقدر تلاقي الفايندينجز لو هي مشيت systematically وحاولت تاخد كل تلت لوحده. بمعنى هنبص كده وبعدين نرجع نبص على الناحيتين، وبعدين نرجع نبص على التلت التالت. لو مشينا بالسيستم ده I think you will appreciate the findings here. Yes? Okay. Again, this is the CC view, and if you do the same, you will go third by third by third. I think you will appreciate this. It is subtle, but it is clear. Focal linear asymmetry. So now when you are go for your ultrasound, I think you target this area, you will find these findings. What is this? There is minimal thickening here in the skin and distortion very clearly seen, and the pathology is coming again, infiltrating lobular carcinoma, classical variant. PR is positive and HER2 is negative, so this is good for in front surgery. We will put a wire, or if the surgeon palpated, he will go for conservative surgery. Case number 6, 65 years old female coming for screening, negative family history, and this was very difficult case for us. I want to tell you something. In my clinic, I never see cases alone. Never. Any case, we are seeing together, me and my team. That's why we are making always second reader. I see the case, my colleagues see the same case, and then we will discuss it and we will take the decision together. I like this way in working in mammo. Okay, so it is very difficult case because my colleagues say it is okay, this is free case, it's okay. By discussion, she went to ultrasound and I read the film again. And if you go make your schema for reading, لازم كل حد يبقى عنده his system way in reading the memo. What is the system? كل واحد يحط السيستم بتاعه بالطريقة اللي هو عايزه، بس دايما يبقى consistent انه يقراه بالطريقة دي. يا اما تقري من اول النبل، اوكي، وتمشي من بره لجوه، يا اما تاخديهم و this is my type تلت. بمعنى ان انت لما تيجي تقري تراي ان انت ما تبصيش خالص على بقيه البرست. keep going on this side. زد زي ما انا ماشيه كده، اوكي. واهتم بايه؟ الاريا اللي هنا جدا جدا، الريترو جلاندولار فات مهمه جدا، تمام، والنبل مهم جدا. فلو بصينا هنا، حد شايف حاجه؟ احنا شايفين هنا upper outer focal asymmetry. موافقيني؟ في الاول احنا او my colleague reported as negative study apart from left upper focal asymmetry mostly hamartoma. بس بصوا الالتراساوند جابها ازاي. تمام. طب تعالوا نرجع تاني لورا. ايه رأيكم هنا؟ how you feel this؟ بصوا معايا هنا، شايفين السكالوبينج ده، انك قادره تشوفي الجلاندز هنا. طب هنا ايه رأيكم في الحته دي؟ هل هي شبه دي؟ No.
Distorted.
Sorry?
I said distorted. Sorry, I didn't recognize the microphone is open. Sorry for that.
لا بالعكس والله، انا لو حد يتكلم هبقى مبسوطه جدا. الانتراكشن احلى، انتراكتيف بيبقى مهم، وانا مستنيه كلامكم في الاخر. So this is was by ultrasound. Okay, where is this in mammogram again? Oh, you can find it now. Okay, حكايه ان انا اعمل دروينج للجلانس، لازم شايفين زي ما انا بهتم بالريترو مامري ههتم بالانتيريور. الريليشن between my glands and the fat لازم تبقى دي الريليشن. هنا لما رسمنا كده اعتقد انه الدنيا واضحه معانا، صح ولا لا؟ التيك منك minutes اول ما تشوفي الحاله انك تكمبيرت وتشوفي العلاقات ما بين الحته اللي هي الفاتس اللي ورا واللي قدام، برضو علاقه الجلاندز بالفات اللي قدام. الانترومامري. تمام. لو عملنا الطريقه دي هنقدر ريكوجنايز الساتل ليجنز. موافقيني؟ تمام. الباثولوجي كان infiltrating again lobular carcinoma. اللوبيلر is very very difficult حقيقي، وكانت برضو candidate for in France surgery. Case number 7 diagnostic المرة دي مش screening. 33 years negative family history with small left breast lump. تمام. where is the lump again؟ برضو من الحالات اللي عذبتنا كتير. this case I missed. اللي فاتت ما كنتش I missed my، بس this case I missed nicely جدا وبسهولة جدا. I hope ان انتوا تعرفوا تلاقوا الليجن في ظل هذا الهيتروجينوس بريست اللي هو بنسميه ACRC، اصعب نوع من انواع البريست. تمام. هي الليجن الست جايه ده الشيت بتاعها بيقول انها have a left breast lesion. she feel it. okay and this is her mammogram.
lateral periolar on
فين يا
CC في
دكتوره؟
subtle changes في lateral periolar anterior.
برافو عليك، هي دي متخيله. هكبر الصوره، شايفه حضرتك دي؟ هنكبر شويه. لما دخلنا عملنا سونار لقينا ادي النبل، اوكي، وادي الليجن واضح جدا في الالتراساوند. رجعنا بصيت عليه تاني اهو، كبرنا الصوره. انتوا يعني مش عارفه الصوره واضحه عندكم، بس انا عامله لها ماجنيفيكيشن اهي. ايه رايكم؟ so easily to be missed so easily. لو انا مش ماشيه ببص بالترتيب هعملها. الحاله دي طلعت I think انها الهيرتو بتاعها كان بوزيتيف او تريبل نيجاتيف، so they ask for clipping for this small lesion عشان يبداوا نيو adjuvant chemotherapy. وادي الكليب حطيناه فيها اهو. تمام. وادي الكليب هنا بانت طبعا احلى في الام ال او اهي. اوكي. وده الكليب بتاعها وحطينا واير.
one of the commonest hidden areas.
برافو. So what I learned from these all cases: beware of the blind spots and the forbidden zones to avoid missing findings owing to their unexpected location or nature. Subtle changes in the contour along the posterior or anterior glandular fat interface or retroareolar area and midline can be easily overlooked. So every one of you had to make her schema in scanning. بمعنى كل حد فينا لازم يكون عنده سيستم وهو بيقرا الماموجرام. زي ما اتفقنا، يا اما يبداوا من عند النبل ويقارن التو نيبلز ببعض. الريترو اريولار نيبلز من الحاجات الخداعه اللي ممكن يجي فيها ساتل ليجن، ويمشي من جوه لبره. اوكي. الاول يبص ازاي، او انا بحب اعمل كده. كل واحد بقى يحط الطريقه اللي هو بيلاقي نفسه بيعرف يسكان بيها. انا بحط الاول القصه كلها على بعض، بقسم السكرينه بتاعتي ل4، بحط ال2 سي سي مع 2 ام ال او واروح واخده فيو كامل لهم عشان اشوف الديفرنس. وبعدين اخد السي سي لوحده، ال2 سي سي جنب بعض، وبعدين ال2 ام ال او جنب بعض، وابدا امشي تلت تلت تلت. عينيا تجيب من فوق بالتلت زي زجزاج، كاني بمشي زجزاج، واتفرج على comparing the two side each other. comparing ده هو اللي بيخلينا نديتكت الساتل ليجن. تمام. اهم حاجه ابقى بي شور ان انا بصيت على الهيدن اريا كويس جدا، واتاكدت ان التكنيك بتاعي مظبوط، ان البيشنت التكنيشن بتاعتي فرده البريست كويس، ان انا جابت لي لحد الماسلز. مش دايما بنقدر نشوف البكتوراليس ماسل، لكن we will try to see it. اوكي. كيس نمبر 8. دكاتره لو النص ساعه خلصت بلغوني وبعدين نتقابل تاني، انا ما عنديش مشكله. انا هبدا اعرض الحالات، وانتوا وقت التايم بتاعكم حسب السكيدجول قولوا لي نقف ونكمل تاني. اوكي.
May
Case
I just
number 8.
have a comment? I'm a histopathologist. This is exactly how I teach my registrars to have a system in reading the slides so that you don't miss anything in the section.
Yes. Yes,
you
thank you,
have
doctor.
to go systematically. You can develop your own system or follow the guidelines and make your own system. You have to make sure that you cover the whole section and don't miss any pinpoint microscopic part of it.
Yes, this is how the way we can avoid missing the subtles. If
Yeah,
you make your
exactly.
own system, of course, you will بنسبة 90% or maybe more, you will you have no missing. Still بيبقى عندنا no one can make all the
Of
cases.
course, to err
I
is
am
human.
sure
To err is human, definitely.
100% never. So
لا
don't
لا,
be panic when you miss case, but
it's not
you
a
make
problem.
this
Yeah,
case to learn you what you will do or how you will, why you miss.
yeah.
This is the most important, because
Uh,
always we miss, but why I miss it. So again, I will make restart.
investigate. Yes, you
Yes,
have to
yes,
investigate why you missed it, and that's the way you work. We always also work in teams. You said you never do any reporting
yes.
by yourself, and this is the same way we do in the lab. We always invite another person to see our slides, especially difficult cases, of course.
Yes, of course, difficult
Yeah,
cases.
yeah. Just
Frankly
you cannot do
speaking,
it, Baraki.
no. Frankly speaking, when we have a lot of cases, we are going, because always we are going two in the shaft. So
Yeah,
we are going rapidly, but the case which is have some problem, some heterogeneous breast, some complaint. That's why the clinical data, it will guide you which case or
definitely.
positive family history strong. One lady is coming to you with positive family history strong, her mom and her sister and her aunts. So this case is very important. And her had heterogeneous breast. Don't take the risk to scan it alone. You have to ask some
Yeah,
friends to come and see it. Okay. But fatty breast and there is nothing and come for follow up. It's okay. You okay?
ما
I will
مشكلة.
make it alone. But choose, because this is one. The other, how you know that you make a mistake? You will not know except you make a follow up for your cases. So
Yeah.
if you have case and she is going for another doctor, are going to do MRI study, she is going to do contrast mammo, and you haven't in your center, you had to take her phone. If you have a biopsy, you
Yeah.
have to take her phone. You have to ask the pathologist what is the result, and so on. So
Yes,
you
you have
know.
to encourage feedback.
Yes, without feedback you will not go one step. Okay. So
دكتور أمل، أنا عندي
نعم.
مقولة بحب دايما إني يعني النواب اللي شغالين معي دايما أخليهم هم يقروا، بعد ذاك يعني أنا أشوف بعدهم، فبقول لهم 4 eyes better than 2 eyes
Yes,
and
this
8
is my
eyes
word.
definitely better than less, and so
Yes.
forth. The more eyes seeing the mammogram, the better the result.
Definitely.
The better the
I
detection
totally
and the
agree.
better pick up abnormality.
Totally agree with you. So
Yeah.
case number 8, 55 years old female with negative family history, started screening since 2013 to age of 49 every year by mammogram. This is one of my cases. Okay, you had to know that I start work here in Egypt by 2010. Okay, up till now, يعني it is 15 years in Egypt. Okay, this is her oldest memo, and as I told you before, I don't have digital memo. I don't have good viewer, so you will find the cases are not that much good quality. And this is by 2019, and this is by 22. Okay, 2020. So I will make magnification so you can detect the problem. Now, every year she is making her screen, and by 2020 we find, sorry.
Now it is clear.
Yes, now it is clear.
Yeah, segmental, polymorphic, and linear calcifications.
Exactly.
Very high.
And her ultrasound, difficulty to find something. Yes. يكلم يا جماعه دكتور جمال يقول له انا في زوم، عشان كده هيقطع عليا. Okay. And mammographic guided biopsy was done. I am doing mammographic guided biopsy. However, I don't have stereotactic. Okay. I use my open grid, and I try to take the biopsy by it. I make a mark for the area, then I am trying to do it. Sometimes I succeed, sometimes no. If I want to know if I am targeting that or not, so I take a biopsy and take the core and make a specimen memo, and this was the result. I think it is very clear. Agree? So I am succeed. So I will be sure that the result of the pathology, I will be satisfied. This is the result of the pathology. It is coming as low-grade DCIS. This lady is go for mastectomy, and this is how she, after following by 2023, she is very good. Okay. Case number 9, 67-year-old female with history of right breast cancer managed by lumpectomy. On regular annual screening, you can see the difference. This is in 2017, 18, 19. And this was her group of microcalcification increasing. You can see here, then there, then here. Okay, agree that the microcalcification is very clear here. Agree. Okay, and again, so nicely we missed this group. In 2017, it was there. 2019, again, progressed. It is slowly progressed, but it was missed. Ultrasound clear with no definite lesion nor calcification. So guide wire localization was done, and the pathology is coming again as invasive lobular carcinoma with extensive high-grade comedo DCIS component and invasive component less than 2%. Sorry, Sharfa, I don't know. You can see this or no?
It was very subtle. Good pick up.
Yes, it was very subtle.
Excellent.
Yes, it was very subtle. And this lady, again, in her follow-up, after we did conservative and put surgery, this is the post-operative clip in surgery, and she is doing fine. Case number 10, 63-year-old female with negative family history come for screening. Previous mammography revealed left upper outer amorphous microcalcification. Again, very subtle. Okay? You can see, very clear. This is after 1 year, in the second year of her screening. And this is the way I am doing. I have no stereotactic, of course. It is not here in Alexandria, but it is in Cairo. And sometimes I am helping the patient not to go there, and I am trying to do it by this way. I know that this lesion will be here in this view. I put the patient. I start to put a needle in this area. If it is okay, it was the anesthesia needle, then I remove it and I put my true cut. I measure the distance and I fire. And sometimes it's working. Not every time, really. A stereotactic biopsy revealed DCIS with also, again, 3B form and solid patterns. Okay. Case number 11, 40 years old female with negative family history.
Dr.
come
Amer,
for screening. نعم حبيبتي.
do you like to complete the 1 hour, the second session, or you will do it again?
If you want, I want to finish them all. It will be better for me.
Okay, continue.
And
okay,
if you
no
feel okay.
No, for us,
Then
no problem. Just it is for you. If it is
no,
not,
because I have my clinic has to start, and for you, if you find it is too much, say okay.
We are enjoying. We are enjoying. We are enjoying.
Thank you very much.
Enjoying your cases and your discussion.
Thank you.
But just would like to give you the options. If you
No,
like,
I like
to
to
decide
finish it,
it, you are
finish it
welcome. If
all.
you like to continue,
I
more
like to
welcome.
finish it all, and I have a lot of session like this. If you need any time to show you all the cases, I most welcome. I will be with you anytime.
You
Okay,
are
now
welcome.
this case, you can see anything here again. My nightmare, microcalcification. Microcalcification really is very difficult, but in this case, we can see it nicely by ultrasound. Subtle lesion with microcalcification seen sometimes nicely, give them by ultrasound, okay? And this case, it is one of my colleague, unfortunately. And we put 3-wire because I will show it again to you. This lady, this microcalcification is going in this area exactly, and in this area. When we magnified, you can see it nicely from here to here. It was 4 o'clock axis, okay? You can see this is, it started from here up to here, and it was DCIS. The duct in 4 o'clock was like this, and this was our guidance when we take the biopsy with this microcalcification, but still the microcalcification is, this case we put the wire under mammo to be sure that we have all the area, okay? And this is her specimen mammography after surgery. Thanks God, all the microcalcification is taken with very good safety margin. So what can I learn from these cases? Always characterize morphology and distribution of your microcalcification. Very, very important. And the distribution in microcalcification is more important than the morphology. Okay? Imaging guided biopsy. If the group of microcalcification is new or increasing, you had to make a guide biopsy for them. But if you don't have the machine, if you don't have the practice or the authority or the what we call it, you practice well to take this microcalcification out by the pathology. So don't leave the patient, because microcalcification will maybe stay for long time, maybe stay with 3, 4, 5 years. You are following this microcalcification, it will not change. But this not means that if the microcalcification is not increasing, that not means that is a benign. So microcalcification, if it is with suspicious nature from virus 4A, had to be removed, to be investigated, either to take a biopsy. If you don't have stereotactic biopsy, you will try to localize it by ultrasound. If you couldn't, you had to take it by under guided mammo. If you couldn't, please go for wire localization and excision for this microcalcification. And always correlation with all previous study, it will allow detecting slow growing microcalcification. Okay? Early sign of non-palpable breast cancer may be only microcalcification. Not all microcalcification is DCIS, but it can also be infiltrated ductal carcinoma or infiltrating lobular carcinoma. Because before we was thinking that DCIS is only with microcalcification. But microcalcification, sometimes they are invasive, sometimes invasive ductal or lobular. Case number 12, 53 years old lady with positive family history start regular screening at age of 40, and now she is 53, so 13 years she is doing screening. And this was her mammo. If you put 17, 18, and 19 together, you can appreciate you can spot the changes. Yes, it is there. Nicely, there is focal asymmetry is increasing. Density is increasing. So TrueCut biopsy from 11 o'clock left breast lesion it is just 10 by 6 millimeter revealed this infiltrated ductal carcinoma ER/PR positive, and HER2 was negative. And this case is coming for follow-up in 2023, and she's doing fine. Case 13, again, this was in 2016 and 2019. And if you are a good mammographer, you can appreciate this to this, or you will miss nicely, and this is your right. The film is not that much good quality, and the difference is not that much. Okay? Now, if you compare it all from 16, 18, and 2020, now you will appreciate there is something is growing again here. Okay? This was clearly now. And this was her ultrasound. What is this? It is just focal irregular duct with irregular wall, and TrueCut biopsy revealed just carcinoma in situ. So, what can I learn from these cases? Review previously obtained mammogram, developing asymmetry in one view findings, and put a highlight on one view findings. Maybe you will not see it in MLO. Don't say because I am not saying in two view, so it may be normal. No. If the asymmetry seen only in one view, it is important even if the ultrasound is negative. Okay? At least you will put it as a biopsy. Very important. Okay? Case number 14, 59 years old female with positive family history with right breast cancer managed by lumpectomy in 2016. She is doing her follow-up by PET-CT, not mammogram, and her doctor advised her for that. Okay? In 2019, PET-CT show right upper inner highly suspicious lesion. Okay? After how many years? After 3 years by PET. And patient come for diagnostic mammogram. This was in 17. Again, sorry for the bad quality of the films, but this one is following, as if I told you, her right breast cancer. You can find clearly this. Okay. She didn't very clearly. You can see the lesion here in craniocaudal view. Yes. In the PET again is revealed that there is a avid vag lesion for FDG. Sorry, in 2023, PET-CT revealed left breast FDG lesion for diagnostic mammo, and they are the one who asked for mammogram. And you can see now it is in the left side. If you go back, I think it was there. But also it is not reported. And now this is the one. You remember they told it is in the right. You remember? No, say it is in the left. Sorry. They say it in the left, and it was like a distortion. Okay. So it was very clearly this was distortion, and seen distortion in the ultrasound. And that's why I want to mention this is very important that the PET-CT never replace the mammogram. Be aware of any area of parenchymal distortion, especially for heterogeneous breast. And if no tomo, spot film always solves the problem. I don't know, I put the spot film here or no? Yes, okay. So if you find you don't have memo, I recommend the spot film. You can see nicely the distortion always by the spot film. Case 15, 46-year lady with history of Hodgkin lymphoma. Again, history is very, very important. Presenting with recent left breast lump. Diagnostic memo is done, and this was her memo. You can see she feels this lump in the left, okay, craniocaudal at 11 o'clock axis. She come feeling this, but she's not feeling this one on the right. Okay, remember this case. This lady have Hodgkin lymphoma when she is young. So you find that right upper and left upper inner lesion. Right 11 o'clock there is a lesion, and left 11 o'clock there is a lesion. This is the one she felt. This is the one she is not felt. You think which one I will take a biopsy, the right or the left, or I had to take a biopsy from both given BI-RADS 3, but I don't like this BI-RADS 3. You agree? It is not a BI-RADS 3 lesion, because this is reported as fibroadenomas, a typical type, and they ask for follow-up, but I am not agree for this. TrueCut biopsy from the left breast revealed that is infiltrated ductal carcinoma, triple negative, and the oncologist sent the right lesion biopsy also, and it is revealed as fibroadenoma. Again, be sure that all the features of probably benign lesion are presented before giving BI-RADS 3, because I am not agree to give this lesion BI-RADS 3. Because of this cystic change, highly vascularity of the lesion, probably benign BI-RADS 3 lesion is indicated for a biopsy. Clinical data is very important. And when you know that lady have Hodgkin disease and she have history of radiation, this can be the reason to take a biopsy in the lesion. Whatever you feel it is probably benign 3. So 2 items here is very important. The clinical data of Hodgkin make your suspicion is high for any lesion you will find in the breast, because this is one of the cause, the breast radiation in the radiation for Hodgkin for the mediastinum. One of the possibility of increase the possibility of developing cancer breast in the future. Put this in your mind. And other thing is the abnormal picture of a well-defined lesion. Well-defined lesion, not always fibroadenoma. Especially in this case, when you see cystic changes, high vascularity, you will consider, like, I want to take a biopsy to exclude the triple negative, which is come with the same findings. 35 years old female with negative family history presenting with left lump. Diagnostic ultrasound was done, and it gives this picture again. So what is this? I would like to take a biopsy, because this one I give it as a 4A, because there is a cystic change and the peripheral vascularity and irregular fill in the wall. And I need also to do mammogram. Why I'm doing mammogram for young lady when I find something in the ultrasound? Because always I am looking for a microcalcification. It helped me in the diagnosis. At least I will take MLO view. And here it's not help because I couldn't find anything. So I took a biopsy from. I like to always documented my needle in the lesion, and this is very important. Pathology is coming as fibroadenoma with hyperplasia. So the surgeon is asking for rebiopsy, and MDT asking to review the pathology. After I sat with them, I told, I am sure that I am took the lesion nicely. I am in, and no need to take another biopsy. Why we are not going to ask the patient to review the pathology for another good pathologist we know, because the place she read the pathology, I am not familiar with this lab. So when we reviewing the pathology is come infiltrating ductal carcinoma, again triple negative. So not all the cases we had to do a biopsy again. Triple negative mucoid or mucinous in ultrasound often simulate a benign mass. However, cystic changes, posterior enhancement, very important to look for this. This is very important sign, posterior enhancement, and vascularity classified the lesion as a BI-RADS 4A. Documentation of the needle position is I advise to do it. And radiological pathological correlation analysis is essential. That's why I'm telling you, you had to know the pathologist who you send your sample to it. If you don't know the pathologist, please try to communicate with him. Say, I'm not agree for this. I have discrepancy between my findings and the pathology. And again, we need to ask the pathologist to review if you are sure that you are in, if you are sure that your lesion is suspicious. Okay. 43 years old lady with negative family history with right bloody nipple discharge. Diagnostic mammogram is requested, and this was her mammogram. Nicely, you can there see little asymmetry in this. Yes. And by ultrasound, what we see, what we call it now in recently as ductal abnormality. Okay. Ductal abnormality is a new entity in ultrasound now, like in the group of non-mass lesions. Within it is the new word we can use it in our report is ductal abnormalities. Ductal abnormalities here, this is a group of duct is dilated, irregular, and there is a content. So we say this is infective for cytology, and because this lady have nipple discharge, and we put it as biradisary and ask the lady to come after she finished the course of antibiotic and anti-inflammatory, and go for cytology for this discharge. The lady is not coming to us in short period. She came in March 2023 with this picture. You see the difference? Now we can see this nicely. Axillary lymph node, and you see how the ductal dilatation is become now, and the problem, and not a problem, and how is this lymph node? Yes, pathological node, and the ducts is now very, very diagnostic. There is a big problem in this lady. We take a biopsy, and it was for this picture, we put it as BIRADS 5, and the pathology is coming invasive ductal carcinoma with DCIS, ER positive, PR negative, HER2 negative, with metastatic axillary lymph node. So, what is next? Do you need any other radiological study? Of course, I had to go for another study, MRI. Now you see how is her MRI, how was the distance is of this can nicely be seen. It is very big sector. So it now you can imagine it is almost half of the breast, and her breast is small. Now the decision of the surgeon will be completely different. He will go for, of course, yes, mastectomy with nipple sparing mastectomy. So what I can learn from this clinical data is very important. Very important to know that the patient have bleeding per nipple. MDT also is very important. We had to discuss always together with the pathologist and the oncologist and the surgeon. Request other modalities and try to get feedback. Feedback is very important. Don't leave your patient. Keep following your patient until you solve health problem. You will call the HAR. You will call the other radiologist who did the MRI. You bring the picture of MRI. By the way, I don't have MRI in my center, but I keep the MRI. I took the CD. I put it on the file of the patient. I follow until I finish my homework. Case 18, 52 years of negative family history with left breast lump proved malignant by FNA. Come for intervention. We will take it a true cut because fine needle aspiration, everyone know it is not enough. We had to go for true cut to make her ER, PR, and HER2. We had to know it because this will make a difference in her management and the treatment. And mammogram and ultrasound was done outside. Just she came for us to take a biopsy from her left diagnosed infiltrating ductal carcinoma. This is the one who had to take a true cut biopsy. But look, it is very clear. But look here, when we did our mammo, because we don't like the film coming from outside. One thing I want to tell you, this patient is coming just to take a true cut biopsy, okay? But we are not doing that. We are not following the orders. We have to clearly see the patient again. And our film is not that much clear, so we repeat the films, and we see, unfortunately, this microcalcification on the right, okay? Now it is clear, left and right. This is the one they diagnosed outside and asked for biopsy, and this is the one we diagnosed in our center, and of course, it is... No, I am not finishing my work. We put a wire, and the result is coming to us. Always when the surgeon, he send it for me, the specimen, and I can tell him this, it's okay, you finished your job. All the microcalcification is out, and also it is with safety margin, okay? And pathology is coming DCIS low grade. Now I finish my work. So reading the report from prior radiological examination before reading the examination leading to miss the finding. ايه ده؟ ايه اللي انا بقوله ده؟ ما معنى ان انا ما بحبش اقرا التقرير اللي جاي لي من سنتر تاني. انا بستارت from the scratch، بقول له ما تورينيش التقرير، وابدا انا اخلص الحاله، بعدين ارجع اقرا التقرير. لان انا لو انا قريت التقرير غصب عني
You'll be
مخي
biased. You'll be biased.
برافو عليك.
This is my approach as well, دكتورة أمل.
Yes, you had to. كل اللي سامعيننا لازم يعملوا كده، يعملوا حاجتين. العينة جاية بتشتكي from right breast, so I will start with left. ليه؟ لأن أنا لو start بالرايت ولقيت المشكلة وبقيت فرحانة، غصب عني عشان إحنا بني آدمين هسكان الليفت شوية بإهمال. لكن لو أنا بدأت بحماس بالليفت وخدته حلو قوي، ممكن أديتكت الليجن اللي موجود في الليفت اللي العينة مش بتشتكي منه. فخدوها قاعدة، استورت بالناحيه اللي ما فيهاش المشكله، ولو حد جايب لي تقرير من بره ما اقراهوش. يعني العينه دي اللي فاتت كانت جايه لي بتقرير ان ليفت بريست فري والمشكله في الرايت. لا، انا ما بصيتش في التقرير، انا بدات فروم ذا ستارت، شفت الفيلم بتاعها، ما قريتش تقريره، ما عجبنيش، عملت الحاله. I save the patient، صح ولا لا؟ لان العينه دي هتجي لنا بعد شويه الرايت بريست في مشكله، بدل ما هو DCIS بقى invasive. not to do biopsy before rescan البوث سايد، مش الناحيه بس اللي انت جاي عشان تعملها. و always ask yourself did I finish my job? Okay. 50 years old lady with history of left breast cancer managed by neoadjuvant chemotherapy after insertion of 2 clip followed by lumpectomy after wire localization since 1 month. Come for diagnostic mammogram to check the clips which couldn't be detected in post-operative specimen. مصيبة. الحالة دي جاية لي من one of my friends surgeon. دخل عمل العملية للبيشنت. She put يعني a wire in another place and they try to find the clip مش لاقيينه. فالباثولوجيست تراي في العملية ما قدرش يطلع كليبسات. خد السبيسمن وقال له انا هشوفها في المعمل، ما قدرش يلاقي كليبس. فبعتها لي السيرجن قال لي we don't know, we couldn't find the clips اللي هي كانت حطاهم في النيو ادجuvant chemotherapy and this was the result. You can imagine. كليبس لسه موجودين، والافظع ان المايكرو كالسيفيكيشن لسه موجودين. So what he did, the surgeon, nothing, because the one who put the clip is not making a mammogram for him, just to put the wire and say I put the wire وادخل على الواير. So two mistakes here. ما حدش يحط واير من غير ما ياخد ماموجرام. اللي ما عندوش ماموجرام ما يحطش واير، لانه حطه على اي اساس؟ هو حط انه شايف الكليب بالالتراساوند ودخل وبعته للسيرجن. Also the mistakes from the surgeon. اي سيرجن بيشيل مايكرو كالسيفيكيشن لازم ياخد، يا اما ما عندوش الفاسيلتيز ان هو يبعتها للسنتر اللي حط، اتليست ياخد CR في العمليات ويتاكد ان المايكرو كالسيفيكيشن بتاعته طلعت. اوكي، احنا هنا رجعنا حطينا له الواير، وطبعا الواير لازم يبقى محطوط ومتصور in 2 views وبعتناهم وتأكدنا إن هم طلعوا زي ما أنتم شايفين كده المايكرو كالسيفيكيشن والكليب. So please my dear colleague always do mammogram after clip insertion or wire localization. Okay? How to
Question,
avoid.
Dr. Amar, in this case, before you
اتفضلي.
proceed, can you go back to mammogram? Is there any edema in this case, or this is
Yes.
post-surgery?
لا this is the edema is post operative لأن العينة كانت لسه بقالها شهرين
Post-operative.
عاملة العملية.
Okay.
كانت بقالها شهرين، يعني ما كملتش شهرين، هما بيدوروا بعد شهر لما ما لقاش الكليب السيرجن بعتها، فدي البوست اوبراتيف ايزيما اللي بعد الهير اوبريشن. How to avoid missing cancer. Obtain advanced training. Keep track for your case. Radiological pathological correlation is a routine. Double read when possible. Consult a colleague. Always finish the case by asking yourself, did I check my blind spot? Did I compare current imaging with the previous studies? And do I need second opinion? And this is my lovely team from Lady Skin.
حلوين.
Any question?
Lovely.
This is
ربي يحفظكم.
الإداريين بتوعنا والتكنيشن والناس اللي بيساعدونا، الأستاذ اللي بيعمل لنا الحسابات. احنا التيم بتاعنا زي ما انتم شايفين كلهم بنات، كل دول بناتي.
ما شاء الله.
دي بنتي الحقيقية. دي
ما
بنتي
شاء الله.
الحقيقية وهي في أمريكا
ربي
دلوقتي،
يحفظكم.
والتيم الحلو ده كله البنات اللي بيشتغلوا معايا.
ما شاء الله.
Thank you very much. I am
ما
ready
شاء
for
الله.
any
Really
question.
amazing lecture.
Thank you
We
حبايبي
enjoy
والله.
it.
الحمد لله أنا waiting for any question. Waiting for any
دكتورة
invitation to.
أمل،
نعم.
ممكن يعني هتقدر تكملي معانا السيشن في one more lecture ولا بس this is
عندي
difficult for
lectures
you؟
كتيرة. لا ما فيش مشكلة. لا ما عنديش مشكلة.
طيب
ثانية
بنهاية
واحدة.
السيشن هناخد صورة تاني. للصباح خدنا صورة مع دكتورة مريت ودكتورة لطيفة. الآن برضو هناخد
تمام.
معاكي صورة بعد ما نخلص السيشن.
طب احنا معانا وقت قد ايه قولوا لي، وانا اجيب لكم محاضرة تانية سريعة لو حابين. قولوا لي تايم معايا قد ايه.
الآن كملتي ال1 hour، لكن على نهاية السيشن بتاعك الثاني you are welcome if you have more يعني cases. نحن
حاضر
بصراحة we enjoy it.
حاضر يا سلام، بس كده انا هجيب لك حالا.
طوالي فخلاص. الآن في
صباح الفل.
one
اديني صباح.
lecture ناخد صورة مع بعض، ناخد البريك ونرجع تاني نكمل اليوم.
طب حابين اكمل معاكم امتى؟ ادوني تايم وقولوا لي وانا احضر لكم ليكتشر، بس مش هيبقى بقى فيه الباك جراوند للاسف بتاعتكم، عشان ممكن تبقى باك جراوند تانية، او احاول ان انا احط الباك جراوند بتاعت الجمعية بتاعتكم عليها حالا لو انتوا حابين.
ما عندك سيشن تاني في السيرد؟ عندك ليكشر في السيرد سيشن مش كده يا هبة؟
أيوة عندها
عايزين
ايوه. في موعدك. ايوه you are welcome. والله اذا في مواعيد الليكشر بتاعتك نفسها هتقدمي لنا تاني have an hour you are
حاضر يا
more than
حبيبتي.
welcome. you are more than welcome.
حاضر حبيبتي. حابين الساعة كام؟
هي الساعة كم يا هبة؟
في شوية تغيرت المواعيد، هرسل لك الوقت في الواتساب.
اوكي خلاص تمام.
لكن هتكوني معانا موجودة صح؟ لأنه أصلا الكويشنز كلها هتكون بنهاية السيشنز. يعني
طب
حتى المورنينج
بس
سيشنز
هقول لك
ما الأسئلة بتاعتها كلها اتأجلت.
خلاص انا ما عنديش مشكلة، انا اي ام ويلكم ان انا ارد على كل اسئلتكم. بس يعني شوفوا لي، قولي لي السكيدول اللي همشي عليه عشان ممكن ابدا اروح الكلينيك بتاعي اخلص كام حيله وارجع في التايم اللي انتوا عايزينه، او لو انتوا عايزيني اكمل معاكم مثلا ربع ساعه كمان دلوقتي واستنى، يعني كل الحاجه حسب جدولكم انا معاكم. شوفوا حابين ايه.
شكرا لك والله. الآن إذا صعب إنك تنتظري المحاضرة الجاية ممكن ناخد صورة الآن، أو بناخد صورة بعدين إذا أكيد إنك حترجعي لنا تاني.
هرجع لكم طبعا حبايبي.
خلاص
افتحوا
خلاص،
لنا
إذا
الكاميرا.
هترجعي لنا ما نطول على ديل لأنه المفروض يطلعوا بريك. وفي تاني باقي جيرني بتاعت الDCIS بديناه الصباح، دقلت عليهم وحتقل عليهم لسه.
طب
it is
حابين
difficult
ناخد الصورة؟
to يعني to present after your amazing session يا دكتورة أمل،
لا والله
لكن حظي
انتوا بس،
كده.
انتوا اللي من جمال وحلوين، وربنا يحفظكم يا رب، ويا رب اكون
الله
اضفت اي
يكرمك،
حاجة.
الله يكرمك، الله يكرمك يا رب.
طب تحبوا ناخد الصورة دلوقتي حبايبي؟
ناخد الصورة يا هبة.
يلا بينا.
الموجودين يا جماعة كلكم اتفضلوا. ها، ولا موجودة. مجدولين، دكتورة لطيفة، دكتورة نادية، مجدولين. هم؟ مرحبا دكتورة نادية، كيفك؟ دكتورة لطيفة are you there؟ عشان تتصوري معانا مع دكتورة أمل كمان.
ايه موجودة.
رباب الحسن you are welcome. ولا الزبير، كل الموجودين you are welcome. صورة جماعية كلنا مع بعض. وين دكتورة أمل اللي اختفت؟
انا تمام، انا معاكم حبيبتي.
زهرة. طيب
ما ظهر صورتك دكتورة أمل.
مجدولين، دكتورة
نعم
رباب،
حبيبتي.
مجدولين، ولا الزبير. طيب
دكتورة
شايفاهم
أمل
يا
كاميرتك
هبة؟
مقفولة.
اهي كده تمام. ثانية كده تمام.
أيوه
الآن
كده
فتحت.
تمام.
أيوه
يلا 1 2 3. بروف كنت شايفاك لكن راحت صورتك.
خدي. منورين.
منورين،
تسلمي يا
شكرا
حبيبتي،
لكم.
تسلمي.
شكرا لكم،
ابعت.
شكرا لكم.
تسلموا جميعا، تسلموا. ابعتي لي بقى حضرتك التايم بتاعك ووقت الأسئلة وأيم ريدي.
اوكي،
يلا اشوفكم على خير.
ما هتحضري معانا المحاضرة بتاعت الDCIS دي يا دكتور أمل؟
والله يا حبيبتي فعلا انا نفسي، بس للاسف الكلينيك بتاعتي بدأت، فهبدأ
لا
اشتغل
لا لا
وارجع
خلاص،
لكم تاني.
لا
تسلمي
ما
لي
في
حبيبتي،
مشكلة، ما
تسلمي
في
لي.
مشكلة. يلا.
تسلمي. مع السلامة، مع السلامة.
دكتورة أمل رباب، نبدأ present.
طيب let me make
ولا
sure.
بعد البريك ولا شنو؟
انتوا رايكم شنو؟ تخلوها بعد البريك؟
والله ما أعرف على كيف.
بعد البريك حيكون فيه 4 محاضرات.
طيب نواصل. طيب it's okay.
طيب let me present دكتور رباب. Okay, I'm going to present Dr. Rabab Mohammed Ahmed, the consultant radiologist, MBBS Khartoum University, and MD Radiology, Khartoum University, FRCR holder and consultant radiologist and head of Women Image Unit at Ssbiwh University Hospital, and the founder of the Ssbiwh. Dr.
Thank you very much for a nice introduction. We are going to continue the journey of advancement in the management and detection of DCIS, completing our objectives. So going through the evolution of modalities past to current or to recent, and with improving detections and characterization of DCIS, mammography has rapidly replaced analog mammography, and electronic magnifying glass has replaced holding magnified glass, and the evolution of the tomosynthesis improves the detection and characterization of DCIS, especially the non-calcified one with a sensitivity of 84% compared to 64% of 2D mammography. And as we have seen in these two examples here, subtle asymmetry
دكتورة رباب
improve.
sorry for interruption. السكرين ما قاعد يتحرك لو ولا عندي براي.
ما متحرك؟ ما ظاهر؟
لا هو ظاهر بس يعني ما presented يعني فاتح سايب.
Yes, the same with me.
Okay,
Yes.
it is moving with me here.
And it's not full screen.
عمليه presentation mode. هو هسه معمول كأنه مفتوح تاني.
لا هو presentation. I start by presentation mode. Now you can see it.
Yes, but
هو
not
ظاهر
in
بس ما
not
presentation
moving.
mode. ما بتحرك لا.
So that is not the one. Maybe might not be shared.
The screen أيوة السكرين حقتك. اوكي كده هو تحرك لكن ستيل انه ما presentation mode. ما معمول في full screen.
1 minute. Let me share it. That is the one. Can you see it?
بيحمل.
Can you
أيوة
see
ظاهر.
ما presentation ما presentation mode.
It is presentation mode. What's the problem?
كده ضغطيها تاني يمكن. اضغطيها تاني يمكن ما لأنه ما ظاهر كأنه يعني فاتح سايب.
This is DCIS 2. Can you see it?
Yes.
DCIS 2. Okay.
أيوة لكن ما presentation mode.
I put it in presentation mode. Here it is presentation mode. It is presentation mode for me. But why it doesn't appear as present? Still, it is still not presentation mode.
No.
So this is technical issue.
طيب إذا قفلتي السايد اليمين ده ممكن تكبر لنا الشاشة شوية أحسن.
The problem I had make it يعني كده
أحسن.
to me but why it doesn't appear for you as full? For me it is a presentation mode. I have seen it as full. It's supposed to be full for you. It is not?
No.
لا حاليا لا.
طيب share وانشير ولا انشير
هو
وشير
شكله
تاني؟
كده شكله إنه لا شكله حعمل انشير وارجع تاني.
Okay.
اصلا احنا متاخرين ف I don't know. طيب I stop sharing. Can you see it?
لا لسه. We can see it but not presentation mode.
Why?
انت فاتحاها من الباوربوينت ولا من الدرايف ولا من وين؟
طيب انا قبل عملتها بنفس الطريقة. نفس الصورة. إذا خلينا نطلع البريك ونصلي العصر ونرجع تاني. اسمه شنو ده؟ في أعمل ريستارت نشوف يمكن تصلح.
طيب حاولي تعمليها presentation mode من البوتوم رايت سايد في presentation
عملتها
mode.
من البوتوم، عملتها من هاي اب، الاثنين جربتهم.
الاثنين اوكي،
الاثنين جربتهم، وعندي هنا بتظهر presentation mode. مشكلة انه بس عندكم ما بتظهر. هي shared.
هسه shared يس.
طيب كده كيف؟
ايوه جات يا رباب.
جات؟
اي
اوكي.
أيوة كده ظهر.
Okay, sorry for the interruption. Okay, we said the evolution of three digital mammography or tomosynthesis improve the specificity and sensitivity of 2D mammography in detection of non-calcified DCIS, representing 84 compared to 64%, especially for non-calcified lesions, as we have seen in this example here, DCIS presenting with asymmetry, okay, much more obvious on tomosynthesis rather than on 2D. And in this example here, this is also a DCIS. Both the 2 and 3D demonstrate the calcification equally, but the tomosynthesis add an underlying speculated mass which was not seen on 2D mammography. Although the studies suggest tomosynthesis is not inherently superior to 2D mammography in detection of calcification, it often provides better details, as we have seen in these two examples here. This is a DCIS with linear distributed suspicious polymorphic calcification, well appreciated on tomosynthesis than on this heterogeneous 2D mammogram. And here in this example, it demonstrates the extent of the calcification much better than on 2D dense mammogram, and it is down to the base of the nipple that exclude the patient from nipple sparing mastectomy. Regarding emerging advanced technology include contrast enhanced mammography, and all of you you have discussed it very well, and no need to go more in that. And obviously it is superior in performance to the standard mammography because it adds functional information along with morphological information of the standard mammography. So it can detect both calcified and uncalcified DCIS, and it has comparable sensitivity to MRI. And as we have seen in this example here, this is the low energy image demonstrate suspicious calcifications in this region highlighted by the box, and the same area here in the recombined image demonstrate non-mass-like enhancement. Ultrasound it is not usually recommended for evaluation of DCIS, but can be used to evaluate mammographic abnormality and can further characterize the lesion here. Only suspicious area of focal distortion on ultrasound demonstrate this suspicious speculated mass proven to be DCIS, and so also can be used in high dense mammogram to screen the woman with high density mammography, as we have seen in this example. Demonstrate this small, well-defined oval lesions, but because of high vascularity, despite disproportionate with the size of the lesion, biopsy was taken and proven to be triple negative intermediate grade DCIS. And in this case here, this is our patients. We can see here This mammogram demonstrates suspicious mass calcification, probably extend to the nipple, but ultrasound demonstrate the DCIS component of this invasive cancer very well with this irregular duct down to the nipple with this dilated ductal orifice proven to be involved. It's also used for the second look evaluation after MRI, and in such cases we have to lower our threshold, especially in high risk patients or suspecting malignancies, a patient having other malignancy proven or feature suggesting malignancy, and we have seen a focus of enhancement or a small area of enhancement, mass or non-mass. So any ultrasound abnormality, we have to raise a suspicion for that, and these tiny faint abnormalities on ultrasound proven to be DCIS. Regarding automated ultrasound, also all of you discuss it very well, but for evaluation of DCIS can help in improve as supplementary to mammography, improve its sensitivity in detection of DCIS, as we have seen in these two examples here. This is corresponding to mammographic calcification, this lesion, but also demonstrate another two suspicious DCIS lesion proven to be even with foci of invasions. And in the other example here, demonstrate the area of mammographic calcification corresponding to this abnormality, but also demonstrate a small oval lesion here was not seen on mammography, proven to be intraductal papillary carcinoma. MRI, as we know, it is very important and highly sensitive, the most sensitive modality for detection of DCIS. Its sensitivity reaching 96%, and that is why it's recommended for high-risk patient evaluations, as we have seen in this example. Those are usually young ladies with dense mammogram. Here it is negative, but demonstrate 4 centimeter DCIS in her left breast, while this also it's also mammographic occult cancer detected in screening a moderate risk patients, which is recently recommended in the literature. It's also important modality and the highest sensitive modality, an accurate one for the detection of the disease extent, and is recommended by National Comprehensive Cancer Network guidelines, preoperative MRI for DCIS staging. And though there is no sufficient data about the impact on achieving negative margin, but still it is recommended. And as we have seen here, this is invasive cancer, but definitely this was not seen on mammography because it was not calcified, seen as a comet tail from the lesion at the back down to the nipple, representing DCIS. And in this case here, we have seen a calcification. Corresponding to this calcification here, we can see the clump segmental enhancement, but again, there is a non-calcified component anteriorly. This area not corresponding to mammographic abnormality, so the extent of the disease here is more than seen on mammography. And it's also helpful as problem solving. And we have here two examples of the left one is palpable abnormality, while the right image for a patient having a nipple discharge. Both have negative mammosonogram, but their MRI demonstrate suspicious segmental heterogeneous enhancement and clump enhancement proven to be DCIS. Even with more emerging advanced technology like ultra-fast dynamic contrast MRI and diffusion weighted. This not only improves the detection and characterizations of the DCIS, but also can be used to upstage to predict the invasive component of DCIS, as well as the MRI perfusion. As we have seen in this example here, we can see a focus of washout kinetic in this mixture of enhancements, and proven to be DCIS with invasive component. Emerging advances technology also include FDG PET, or what is called BIM. And as we have seen here, this is a patient presented for just proven cancer, a palpable abnormality that proven to be cancer in her right breast. On BIM, we can see this linear uptake anterior and posterior to the invasive cancer, proven to be DCIS, and furthermore demonstrate another linear uptake on the contralateral breast, also proven to be grade 2 or intermediate grade DCIS. And here, this is the same patient, the MRI of the same patient demonstrate this is corresponding to the mass, and this is the linear enhancement corresponding to the left linear uptake. Magdalene, she discussed the artificial intelligence very well, and cannot add a lot of any more for that. But here in my example, it helped in the upgrade and upstage of this mammographic abnormality, abnormal classifications, suspicious segmental, suspicious polymorphic calcifications, which was reported by the radiologist as by RAD4B, but the AI increased the score to 92 and proven to be DCIS with invasive component. And so the artificial intelligence can predict the minimally invasive cancer in up to 93%. So at the end, what we can say, each imaging mode techniques contribute to the comprehensive evaluation of DCIS and highlights the importance of a multimodality imaging approach for accurately diagnosing DCIS. And here we can see example of multimodality visibility in DCIS in this patient, elderly lady, incidentally discovered focus of enhancement in her right breast. Mammogram demonstrates subtle asymmetry at corresponding locations, but ultrasound here obviously demonstrate an oval indistinct suspicious heterogeneous mass, and MRI even demonstrate more suspicious feature and upgrade the stage of the lesion and proven to be DCIS. Okay, let us go for the biomarkers. We start already discussing in the first sessions about calcified and non-calcified and certain type of calcifications, giving a hint that this DCIS is a high grade or low grade and something like that. Let us continue this journey and look beyond saying that just this is suspicious or non-suspicious abnormality, and using the imaging biomarker for further characterization of DCIS and correlate it with the grade of DCIS, expected pure versus DCIS with microinvasion or even invasive cancer. And we might also expect the site of origin, the new classification of AABs and DABs, DCIS or CIS and DCIS. And as we mentioned earlier, non-calcified DCIS on mammography present commonly as a mass or asymmetry and architectural distortion, less likely, and almost all architectural distortion. DCIS presented as architectural distortion expected to be low grade, as seen in this example, proven to be low grade DCIS. If we have seen this example here, this is polymorphic calcification, but associated with underlying asymmetry. So we expect upgrading and probability of microinvasions, which was proven. And in the other example here, we have seen mixture of polymorphic and linear calcification in segmental distributions. So here we upgrade the BIRAD and expect it to have at least high-grade DCIS, and so was proven that it is high-grade Comido DCIS, and with microinvasions. So from imaging, we can expect is it of DCIS, and is it low or high grade, and if we expect microinvasion or even invasions, and other factors that can affect the risk of invasion if the lesion is greater than 2 centimeters, younger age group, and as we mentioned, the type of calcification. These my patients, 3 patients of mine, both all of them proven to be DCIS associated with invasive cancer, and it's obviously from the image here we can see high grade types of calcifications, okay, either linear, which represent ductal linear calcifications, or the pleomorphic in segmental distribution, also suggesting ductal calcification. As we mentioned earlier, ductal calcification usually high grade DCIS, and the presence of underlying suspicious high density speculated and irregular mass from this appearance, definitely we expect there is an underlying invasive cancer as well. It is there is another features from which we expect there is invasive cancer or high probability of invasive cancer, which we call it new ductogenesis. This new ductogenesis, as we have seen here, simulate this tree with numerous branches. But if we look for the branches, it is more than expected for the normal ductal system. It is not just a normal ductal system, and as we can see here in the pathology image, there are more branches, more ducted than expected, and it are haphazardly distributed. 2 numerous small ducts, okay? This is what's called new ductogenesis. It is similar to the new angiogenesis, the new vascularity. Also, some types of cancer, the aggressive type of cancer, demonstrate this type of new ductogenesis, and it seems we suspected when we look for this appearance of ugly type of linear calcification, and we expect this is a DAP or DABs, ductal type of cancer, and as we know, it is aggressive type of cancer, and most likely or most probably there is underlying invasive cancer, even if there is no associated masses or asymmetry. While the AABs, as we mentioned earlier, usually unifocal, as we have seen here, affecting terminal duct lobular unit or this lobule, and presenting with this type of calcifications or this lobular ultrasound mass, and this is corresponding histopathology, demonstrate the acini, distended acini with the cancer, and usually this is either grade 1 or grade 2. But as we can see here, it can retrograde, spread into the ductal system, and going into the other terminal duct lobular unit, result in multifocal, and usually in such it will be a little bit higher grades, grade 2, rather than just grade 1 cancer. And similar changes here, we can see it in ultrasound. This is the terminal duct lobular unit starting in one lobule, giving us a unifocal CIS. As we mentioned, we call it CIS, not DCIS, and it can result in just this clomos type or lobulated small focal cancer without posterior enhancement, as we have seen here. But this lesion might retrograde, is spread into the ductal system, either spread into the smaller ductal system or distally, as we have seen here. It can go distally, giving like this appearance, multiple masses, lobulated masses along with some ducts with or without calcification, or it can progress toward the major duct, toward the nipple. Here, as we have seen, this is my patients, and this is lobule, and the extent going toward the nipple. And here, this is the major duct, obviously. We have seen it distended, and this is, they call it coral type, and this is called it as a pipe type. Okay. Here we can see examples of both, while this is AABs, and generally not seen on mammogram, detected in ultrasound as a focal mass. Okay, and this is a corresponding histology image, and it is important to look for this image here. We might easily report it as fibroadenoma, but since we haven't seen the pseudocapsule, I used not to give it BIRA 3. I used to upgrade it to at least 4A. Despite that, it is oval parallel, but there is missing one characters to call it BIRA 3. Since there is no pseudocapsule, the echogenic pseudocapsule missing, that means we should not call it fibroadenoma. We have to upgrade it. Regarding this DABs, here this is the ductal. You see extensions. Here the pathology, distended with the tumor inside with some calcification, not necessarily, but can be associated with, or most of the time associated with calcific ductal type of calcification, and usually seen on mammography as well as on ultrasound. Regarding the Doppler, does the Doppler having prediction for aggressiveness of DCIS? Yes, despite here, I can see this example, intermediate, low grade, high grade, all demonstrate vascularity or vascular echoes, but still the literature mentioned, there is literature describe that Doppler can be predictors for the aggressiveness and can be biomarker for the grading of DCIS, especially the vascular index. The higher the vascular index, the more probability of higher grading and micro invasion or even invasion. The more aggressive type of reflecting new vascularity, like penetrating vessels, small vessel penetrating capsules, and there are many other features. We cannot mention it now, but regarding these are suspicious. When we have seen this suspicious pattern of vascularity, we suspect that lesions, DCIS, at least high-grade DCIS, and might be more associated with some invasive component, and usually it is associated with aggressive type of cancer like HER2 and triple negative. Also, elastography has the same capability for predictions of high-grade DCIS and the invasive component, and they found that the Emax or elasticity, the maximum elasticity greater than 75, having independent risk for high-grade DCIS. And here we have these examples of mid-grade DCIS with Emax 64, while this higher Emax 144 kilopascal, okay, and proven to be high ductal carcinoma with comedo types. High grade DCIS, even also the ultrasound appearance, the non-mass like enhancement are associated with higher grade than the mass like DCIS presenting on ultrasound, as we have seen earlier. Okay, and usually aggressive type and they found that's also associated with aggressive type of cancer like HER2 positive and with comedo necrosis. Okay. Okay. And as we mentioned that the ER negative DCIS, ER hormonal negative, estrogen negatives, that DCIS the most common DCIS are hormonal positive, but the hormonal negative are the aggressive type, and these mostly seen or mostly visible on ultrasound. And here we can see the example of non-mass like lesions on ultrasound corresponding to non-mass segmental heterogeneous heterogeneous enhancement on ultrasound of high-grade DCIS, another high-grade DCIS presenting as segmental distorted hypoechoic parenchyma, non-mass ultrasound lesions here without calcification and this with calcification. And here we can see the calcification as segmental linear and polymorphic on mammography, and the corresponding here segmental clustering, highly suspicious MRI findings. Okay, let us see this example and what we can learn from it. In this example here, again, we can see multiple suspicious polymorphic calcifications. When MRI performed, demonstrate larger area of suspicious enhancement. Going to pathology, they found that this suspicious calcification, as you look at it, it is what? It is crushed stone types, at least corresponding to grade 2 DCIS. They found it which corresponding to acinar type. And they found that this represent acinar type, but in between, they found multiple ducts filled with ductal carcinoma in situ, high grade. And as we mentioned earlier, these high-grade ductal carcinoma arising from the main ducts represent DAP or DABs, which is aggressive and killer type of cancer associated with 30% fertility rate. And here you can see the normal, and you can imagine the major ducts going in between the lobules that you can apply it here to just imagine the DCIS having, these are lobules, and here these are represent major ducts. But on the other hand, we might see DCIS, while this here, this is segmental intermediate grade presenting with extensive microcalcifications. And here, this is non-mass like enhancement clusters representing intermediate grade DCIS. This is here a low grade DCIS, demonstrate lack of enhancement on ultrasound. And we have to remember that 12 to 20% of DCIS might not enhance on MRI, and we can discuss it more in the next lectures of pitfalls on MRI. Going to contrast enhanced mammography. Okay, this is the typical pure DCIS presenting as pure ground glass non-mass like enhancement. Here we can see linear ground glass linear enhancement. But if we look here, we can see more dense contrast enhancement. We call this solid ground glass or unpurified ground glass, and it might be heterogeneous. Can you see it here? Heterogeneous ground glass. And this is when we see this, this is not a low grade DCIS. Definitely, this is high grade, and even we can expect micro invasions or even invasive component. So it can predict the grade of DCIS and can predict upstaging or upgrading of the lesions. Okay, and on the other hand, though this is a high grade lesion, but also present with lack of contrast enhancement on mammography. And according to the literature, studies reported that non-enhanced DCIS on contrast enhanced mammography can range from 5 to 54. So almost 50% might not enhance on mammography, and we have to be cautious when there is absence of enhancement, not confidently say there is no lesion, especially if we have suspicious calcification on mammography. So we have to go and take a biopsy. I don't know if you have time to go through case examples. This is my first case. It is my first case and my first experience to be reported as DCIS. Okay, 47-year-old presented with left breast pain. Here we can see dense breast, but with distortion and suspicious type of calcification. It was pleomorphic segmental calcifications. On ultrasound, demonstrate complex segmental ductectasia, and we can see the ductal calcification, which is highly suspicious. And this is her ductogram I had done at that time. I demonstrate suspicious beaded appearance with some tiny filling defects within the ductal system. Here, this is a zoom for that. And here, MRI demonstrate heterogeneous segmental enhancement corresponding in the outer central quadrant and proven to be pure DCIS without invasive component, but it was extensive, ended by mastectomy. This was my neighbor. Came to me seeking advice. She said she has left breast pain. I had done for her mammography, and I could appreciate segmental area of architectural distortion in the left breast and subtle distortion on ultrasound, which was not so impressive. Proceed for MRI on T2. Here we can see this segmental area of architectural distortions and edematous parenchyma corresponding to this heterogeneous and clump non-mass segmental enhancement proven to be DCIS, but we raise suspicion on contralateral breast outer. While this is medial, the other breast is outer, only seen on mammography, on MRI, has no any corresponding. We raise a suspicion, and the patient followed and ended by contralateral mastectomy after 3 years for the same disease. While these patients, 56-year-old female, asthmatic, incidentally we incidentally found this oval obesity in her right breast on CT. And here we can see the mammography, very complex parenchyma, nodular parenchyma, difficult to appreciate, but we can say there is something here corresponding to that area. And with magnification view, we can see some lucency within this indistinct mass, and there is suspicious calcification extending from within the mass outside the mass. So this is a corresponding ultrasound appearance. Here it is also suspicious one, but it seems to be as if it is presence of lucency make probability of might be hamartomas with ultrasound appearance. I raise a probability of DCIS arising in hamartoma, and we proceed for further characterization of MRI, and we found just peripheral lucency, but the central is homogeneously enhanced with irregular outline. Sorry for this white chems. Okay, and here we can see the surprise is that not the suspicious lesion, MRI demonstrate focal of enhancement in the contralateral breast for about 7 millimeter focal enhancement, but it was suspicious. It was avid with type. It was avid type. I think type 3 with washout curve. So we recommend biopsy of both. And this is a second look ultrasound we had done for this lesion. We found an unmasked like lesions at the same locations, and the biopsy demonstrate this one was grade 2 DCIS, and this small lesion was invasive ductal carcinoma. This patient presented with pain and lump in her left breast for 1 year, reported as fibrocystic. But if we can see here, there is subtle distortion with nodularity, and there is asymmetry in large lymph node compared to the contralateral side. And here we can see, this is the same patient I have shown in earliest, demonstrate the ductal enlargement. This is anterior, and this definitely suspicious lesions, the enlarged terminal duct lobular unit or lobule with distortion and ill-defined. And here the extent of the disease on MRI demonstrate the lesion extending down to the nipple and the back of the breast in segmental distribution, along with lymph node, and proven to be extensive DCIS with invasive papillary component. This is a male presented with with history of recurrent third ventricular tumor and left bloody nipple discharge. Here we can see bilateral ductectasia, more complex. Time.
لا الصور ما قاعد تمشي. أنا ما شايفة الميل بريست تحت وانتي لسه في الام ار اي طالع عليه.
ثاني بقى رجع بقى ما
دي الام ار اي. ها this is the male breast. Can you see it now?
لا ما فاتح
لسه.
strange.
زي قبل علق. لا.
Can you see it?
لا
ما قلب. لسه ما presenting mode.
أيوة هسي جا لكن الميل بريست
انت
قاعد توريني في الميل بريست. yes.
Okay. This is the male breast, a 49-year-old male with history of recurrent third ventricle brain tumor, presented with left nipple blood discharge. Okay, left. And if we look here, bilateral ductectasia, but on the left side, it is complex type of ductectasia. We can see soft tissue and calcification within the ducts, dilated ducts on the left side. And this is the mammogram, demonstrate just bilateral gynecomastia. It doesn't add, we couldn't appreciate, we couldn't see the calcification well in this mammogram, but this is the MRI, demonstrate the bilateral ductectasia with T1, with high T1, low T2 intraductal component, raising the possibility of proteinaceous or blood component. Okay, but the both contrast, if you can see it here, demonstrate clump
شايفين الالتراساوند. نحن لسه
نعم
احنا لسه شايفين الالتراساوند.
الالتراساوند
انت بتورينا في الام ار اي ازت.
طيب الماموجرافي
ما شفناه. لا
سترينج.
اوكي هسه شايفين الماما.
طيب this is a mammography and this is MRI. Have you seen it?
يا دكتورة هو عشان معمول هنا يموت ما معمول.
Have you seen the MRI now?
Yes. أيوة ظاهر.
Okay. So the MRI as we mentioned that demonstrate the bilateral ductictasia with high T1, low T2 intraductal component and clump ductal enhancement. Can you see it here? This is a clump ductal enhancement, which is suspicious for DCIS.
Rabab, it is again not in presentation mode. كده جربي اعمليه presentation mode.
And this one?
دكتورة إذا هنا الزمن أخذنا 10 دقائق إكسترا.
خلاص it's okay. كده شايفينه؟ اوكي كده شايفين؟ كده شايفين؟
ايوه
خلاص ما في مشكلة. هنا ممكن I can show that this is obviously ugly left breast cancer, and this is the right mammogram. Okay, the highly dense parenchyma, but the MRI demonstrate this segmental enhancement proven to be DCIS in the contralateral breast, and this is extensive enhancement in the right breast. Okay, with extending to the nipple with abnormal nipple enhancement proven to be DCIS with budgets. And we can leave the rest. Here, this another patient. This all my patients proven to be DCIS. This is a patient here having they extend. This is the invasive cancer, and this anterior and posterior segmental clump enhancement was DCIS, and this is cancer, invasive cancer on the right breast, and the focus, enhancing focus contralateral was DCIS. And this patient post represent post-therapy changes. Can you see the clump linear enhancement? It was recurrent DCIS. So no need to go through the summary since the time is over. And here, this is my reference, and thank you for your patience and for attention. And sorry, Yani, for taking you long.
Thank you very much.
Dr.
Very
Rabab,
interesting.
it was very interesting and we enjoy it.
Thank you very much. Thank you.
Thank you.
Thank you.
So now مفروض نطلع للبريك تقريبا
أيوة.
تلت ساعة تاني صح؟ ولا نبدأ ونص؟
أيوة. أيوة مفروض ناخد بريك نصلي.
أيوة نبدأ ونص إن شاء الله.
ونبدأ بعد البريك.
إن شاء الله هنبدأ الساعة 3:30 بتوقيت الخرطوم.
تمام إن شاء الله.
الآن 3:12 دقيقة.
أيوة 3:30 بإذن الله.
أيوة الآن 12 دقيقة.
أوكي
طيب enjoy your break ونجي بعد.
هنبدأ كم؟
3:30.
3:30
اللي هي 17 دقيقة.
مرحبا دكتور غسان. أهو ناس السيرجري يا داب ظهر منهم زول. جاملتنا دكتورة نادية الضوي غايته. كتر خيرها دايما مجاملانا.
سلامات ازيكم؟
أهلا بك.
لا معاكم إن شاء الله.
لا يا داب ظهرت صح؟ ما معنا من الصباح.
لا لي زي كده 10 دقائق بكون.
في نهاية المحاضرة كمان يعني. أوكي.
لا انتوا لكن يعني بعدين 8 صباحا توقيت الخرطوم، دي هنا 6 صباحا يعني شوية أثرتوا علينا.
طيب وكيف
السبت الجاي؟ كانت 12 صباحا عندنا في كندا. انا لازم
هبه دي مواصله ما نامت يا دكتور غسان. هبه دي مواصله ما نامت.
12 مع انت هبه والله يعني مجتهده معاكي شديد.
ايوه
يعني
ده جميل يعني نشيله لا في راسنا. الجمعيه خدمت اكثر كده، اكثر نمبر 1 في خدمت الجمعيه.
الله يديكم العافيه.
ما في كلام
لا يعلى عليها بعد ده.
لا احنا على خفيف يعني. اي عطرة نزول طوال.
You are welcome. still عندنا سيشن تاني بعد يو are welcome. باقي الجراحين ما في حد عبرنا، ما فيهم زول ظهر. انا ما
ما
عارفه
يظن
عملنا يوم السبت ده، قلنا يوم السبت، لكن شكله انه يوم السبت في ناس كمان شغالين، حتى السبيكر فيهم ناس شغالين، فشكلنا كده تاني حنرجع للجمعه ولا شنو ما عارفه. قلنا الجمعه صلاه الجمعه بتضايق الوقت، لكن الماجوريتي من الاتندينز شغالين في الخليج، شغالين يوم السبت،
هو في الخليج
اغلبهم شغالين برايفت، فشغالين يوم
اي،
السبت.
لكن هو في السبت ما بيشتغلوا في الخليج الظاهر، صح؟
لا، اغلبهم شغالين برايفت، عشان كده
اي، ما
شغالين
خلاص حيكونوا شغالين طول الوقت
الشغالين جفرمنتال يوم السبت ما شغالين، لكن الشغالين برايفت، الشغالين برايفت يوم السبت عندهم دوام، والماجوريتي شغاله برايفت، يعني قليلين الشغالين في البتاع، في فديل الاودينس. والسبيكر شايفه هسه كلهم ماشيين العياده، دكتوره مريت شغاله، دكتوره امل شغاله، ف
لكن يوم الجمعة معظم اليوروب وهناك كندا وأمريكا كلهم حيكونوا شغالين.
بس
أو
نحن في
12.
الراديولوجي عندنا انت ولا بس؟
كل الناس في الخليج؟ أوكي.
كل الناس في الخليج
آه.
في الراديولوجي. نناقشها ليتر لانه انا لاحظت الان الاتندنس، قارنت الاتندنس الان واتندنس زمان، في يعني بعض الناس كانوا حريصين بيحضروا ما موجودين، فعرفت انهم شغالين، ما قدروا يحضروا لانهم شغالين.
التي بعديه عادة ذاتها، يعني ممكن الناس تكون ما يعني حضرتها قبل
حضرت
كده.
في الأول. يس ترو.
ممكن، اي ممكن، لكن والله احنا كانه ما حضرناها، حضرنا الثاني ولا كانه ما حضرناها. العلم ده دكتور غسان ما له حدود.
لا ما في كلام طبعا، لكن يعني الواحد ذاته ذاكرته بقت على قدره، يعني حضرتها ولا ما حضرتها ما بيفرق كثير.
والله صدقت. أنا لسه قاعدة أشوف في كيسز أم لايك دي بالله أول مرة أشوفهم.
يعني
الحالات اللي قدمتهم ديل.
لا ان جنرال يعني الواحد لما يحضر you feel good about yourself يعني، لكن بعد يومين كده خلاص الموضوع ده بيكون كله طار.
لا، لكن انتوا في الدiscussions، في الام دي تي ديسكشنز، المسألة اختلفت من اول ام دي تي بديناه والام دي تيز الاخيره.
صحيح
ثقافتنا نحن في الجراحه والباثولوجي والأونكولوجي ارتفعت، والعكس صحيح.
لا تمام صح فعلا، يعني
ايوه،
استفدنا ما شاء الله، استفدنا تماما ما في كلام. يديكم العافية.
يعطيكم العافيه جميعا. برضو انتم ما بخلتوا علينا، يلا يديكم العافيه، نصلي ونرجع.
أيوة تمام.
اوكي.
Hello, everyone. We will resume our symposium in 2 minutes. Be ready.
أنا ready. صليت وجيت.
تمام دكتور.
هسي 3:33.
السلام عليكم.
وعليكم السلام والرحمة. ولا
أهلا.
كيفك؟
الحمد لله.
طمنينا على الولاية إن شاء الله. طيب
والله الحمد لله متحسن، بس لسه ايدي متص الرجل.
ربي يتم شفاه إن شاء الله يا رب.
اللهم
ما
آمين
يشوف
يا رب.
شر. مفتقدينك بشدة.
أنا برضو
والصورة
والله.
الجبال دي شايفة اسمك موجود، وكل مرة بنادي عليكي للصورة. أنا
بكون موجودة، لكن يا إما برا سايقة لكن موجودة يعني في الميتين. حضرتها يعني. حضرت واحدة من الصور، أنا كنت موجودة أول الصور تقريبا في البداية.
اتصورتي؟
أيوة هاي.
طب كويس. ما غريبة إنه هنا في الرصة ما شايفاكي، بس كنت.
غاية أول الصور فتحت الكاميرا، كنت
طب
موجودة قاعدة يعني
كويس.
تيبل.
هنا ما بتظهر كل الناس، تظهر
أيوة أيوة.
عدد بس. ما هنا أنا ما مشيت بالسهم كده. أيوه
ممكن نبتدي هسي الساعة 31 دقيقة.
Okay. Welcome back, everyone. I hope you had a refreshing break, and we will now resume our symposium and continue with our next speaker, Dr. Wala Ssbiwh. Dr. Wala, MD and FRCR, is a consultant radiologist and breast imaging specialist at University Hospital of North Midland Trust, UK. Dr. Wala, mic is yours. Welcome.
Thank you very much. Are you seeing my screen?
No, not a bit yet.
Okay, so let me change the sharing.
Okay, now it's appear.
Yeah, but I want you to see the other screen. Just let me. I will stop sharing and share again. Okay, so number 3 تقريبا. You can see the screen?
Yes, it's beginning University Hospital of North Midland. Yes, page.
Symposium, not symposium?
Not symposium, not symposium.
Okay, so I think there is
It's
issue
return
here.
to Dr. Wala Ssbiwh.
Okay, so is it presentation mode if I present it like that? Yeah? So
yes.
if I present it, is it presentation mode? No?
لا
Dr. Hiba?
أنا حقيقة شايفة حقت رباب الظاهر.
أيوة دي السكرين حق دكتور رباب.
طيب معناها أنا محتاجة أطلب شيرين. خلينا أعمل أشير تاني. Okay, so Windows. So what you can see now?
NHS Hospital.
And now? Symposium?
لا
لا ما
السكرين
شاء
معلق كلنا.
You can't see anything?
Still NHS.
أنت عندك multiple screens ولا شنو؟
أيوة
أي حقت ال NHS هسي شايفينها. You have to تختاري تاني.
طيب خليني stop sharing again. And it so when I choose it, then I will open also share system audio. I think again we have problem. Okay, so I can do. So what you can see now, but I can't hear anybody.
ايوه احنا
Yes.
شايفين
Now it's a bit
لكن
clear.
I'm not presentation mode.
طيب. Although I did that before, but I don't know what is it. Change now. Stop sharing and share again. So let me try. Not presentation mode.
هسه ما شايفين الناس الشاشة كلها. هسه بدت شو no that's not you. اوكي هسه شايفين ال NHS.
طب حضرتك تقدري توديه على الشاشة اللي فيها ال NHS؟
ايوه هو انا عندي لما افتح بيكون ظاهر في الشاشة
ال
فيها
NHS ذاته؟
ايوه. فما عارفة خليني. طيب خليني احاول اعمل.
هو قبل شوية ظهر لكن ما كان presentation mode لكن كان شفنا ال presentation.
والآن لا ما في.
لا هسه شايفين بس ال NHS.
It's I will try screen number 2. Can you see that?
أيوة ممتاز. Yes.
Okay.
And it is present.
You can see it now?
Yes.
Okay, very good. So before I begin, I would like to sincerely thank all our speakers for their valuable contributions today. Your presentations have enriched this session and strengthened our shared learning. I also warmly welcome everyone, including international speakers, to continue participating in Sudanese Society of Breast Imaging and Women Health activities and future collaboration work. Your engagement is what drives our progress in breast imaging and women health. Thank you. You can see? So let us begin.
Yes, we can see.
Yes, clear.
Thank you. Let us begin by looking how auxiliary imaging is evolving and what that means for our practice. So today I will present the avoid audit, but before that I will go through what is the background of this shift. So for any questions, you can reach, the study is still ongoing. You can message Dr. Nisha Sharma, and her email is in this presentation. I can share it after the symposium end. This is a national audit, and the steering committee featuring radiologists, surgeons, oncologists, statistician, pathologist, and trainee representative. Their expertise guide this work. Let us move to the background. So this slide explains the alignment between ethnic trial and avoid audit. So highlight that ethnic is a major UK phase 3 randomized trials, examining whether patients who convert to N0 after neoadjuvant chemotherapy can safely avoid further auxiliary treatment from the beginning, explaining that avoid support this by improving pre-operative assessment, standardizing cortical thickness measurement and abnormal node identification to ensure more accurate staging. Mention that international trials like Z0011, Amaros, and IBCSG 23 also support de-escalation, making the case that UK practice is moving toward less invasive auxiliary management. And surgeons in this symposium can let us know more about that. So this talk focuses on how auxiliary imaging links directly with current UK surgical guidelines, radiology and surgery are now fully interconnected in decision making from the beginning, either avoiding axillary surgery or go into selected cases of minor surgeries. So why we are auditing? We are auditing because the rationale behind this audit explains the variation existing in axillary ultrasound thresholds. So we have units in UK have variable threshold for biopsy from the beginning from 2 to 4, and reporting and impacting MDT decisions. So emphasis that auditing allow us to move toward consistent evidence-based de-escalated practice, stressing that the purpose is not criticism, but improvement and alignment with modern axillary management. So Association of Breast Surgeons audience reflect a clear shift toward minimizing axillary surgery, participating in low volume nodal disease with increased interest in targeted approaches rather than blanket clearance. So focus is standardization, as we said, what constitutes an abnormal node from imaging features and cortical thickening, better alignment between radiology and surgical decision making. Key imaging principles: ultrasound remain the first line axillary staging tool. Documentation should include cortical thickness, hilum status, number of abnormal nodes, and perihilar tissue. Suspicious nodes, image-guided biopsy. This is reinforced nationally. Axillary ultrasound is expected in all invasive cancers at diagnosis. Real implications. Our report directly determine sentinel lymph node biopsy versus axillary node clearance versus no surgery. Poorly defined ultrasound criteria equal inconsistent MDT decisions, sometimes unnecessary repeat of axillary ultrasound. So what to say? There is increased emphasis on standardization of ultrasound reporting of the axilla, as imaging finding now directly influence surgical de-escalation pathways. While NICE guidelines still support axillary clearance in node-positive disease, current practice is evolving toward selective de-escalation, creating a gap between guideline and real-world MDT decision-making. So we are still in dilemma. Modern axillary management is no longer protocol-driven; it is MDT-driven, which is honestly is a practice here. So if we say normal axillary ultrasound and then MDT see advanced disease, they could ask for CT scan, and then if CT scan show abnormal node, they will ask for repeat ultrasound and biopsy. So Association of Breast Surgeons 2025, there is direction of travel. Avoid routine axillary clearance in low volume disease, increase into sentinel lymph node and targeted axillary dissection. So take home message is less surgery, more selection. So role of ultrasound, UK practice is currently in transition. So first line staging tool is ultrasound as beginning. So we need to define the number of abnormal nodes in our report and the morphology of them and determine surgical pathway in the report. Standardization challenges in UK, variable reporting styles, no universal cortical thickness threshold, inconsistent MDT interpretation. Question, are we all using the same criteria? We can have answer this question after the presentation. And what is the challenges in your practice about this topic? MDT-led decision-making, no single pathway fit all patients, depend on imaging, tumor biology, neoadjuvant chemotherapy response. So variation in axillary ultrasound reporting, overcalling versus undercalling nodes, impact on surgery. So those are the gaps in the practice today. Pre-audit questions. How many abnormal nodes trigger biopsy? Do we document cortical thickness consistently? Are we imaging, our imaging findings clearly guiding MDT decisions? And could we safely reduce axillary surgery? So why we did this audit? To assess the current practice, which has gap already. So we have the answer from the beginning. to identify the variation and to align with evolving guidance. What we aim to improve standardization of reporting, better MDT communication, and safe de-escalation of surgery. I will go to the, so now we have this year, we have published work from multiple areas through the involving this topic. So the Association of Oncology, American Association of Oncology 2025 guidelines. So this is new published, recommend reducing surgical intervention in selected low-risk breast cancer patients to improve outcomes. So the American Society of Clinical Oncology, sentinel lymph node biopsy guidance. So routine sentinel lymph node biopsy guidance, and Dr. Ghassan can talk to us about this after this presentation because it is now changed. It is not recommended for postmenopausal women with small hormone receptor positive HER2 negative tumors and clinically node negative axilla. Omission of axillary lymph node clearance in the early stage cancer. Patient with 1 or 2 positive sentinel lymph nodes undergoing breast conservative surgery and radiotherapy may omit axillary lymph node dissection to reduce morbidity. Multidisciplinary personalized care, integration of imaging, tumor biology, radiotherapy planning, ensure personalized axillary management and better patient outcomes. So we have a new thing which is not yet in practice, but it is in researches, intraoperative ultrasound innovations. We don't have this in our practice in UK. If you have this in Canada or any other practice, please tell us more about that. So UK axillary guidelines, so Association of Breast Surgeons are nice. What is new in 2025? De-escalation by Association of Breast Surgeons, move away from routine clearance, imaging-driven decisions, standardization of axillary ultrasound and biopsy. This is by NICE guidelines. So NICE guidelines is still stressing on biopsy and axillary clearance, but not yet we have clear de-escalation yet. MDT tailored management, bridging gap between guidelines and evolving practice. So that is why we are doing this audit, and there will be change in the practice after publishment of the final results. So finally, I come to the audit because previously when I present this last time, everybody asked me, what are you talking about? That is why I give all this information before. So our audit is to refine axillary ultrasound to quantify disease burden and guide sentinel lymph node biopsy, axillary lymph node dissection, and TAD decisions. This is the objective. Methodology, the audit and re-audit in our unit, audit and re-audit of cortical thickness and count of abnormal nodes on ultrasound across UK breast units and specifically our unit. So I'm now presenting only our unit. Evaluate 2 to 4 millimeter cortical thickness cutoff to standardize practice and reduce over treatment. Clinical impact, so harmonize criteria, improve oncology safely, minimize morbidity, and strengthen multidisciplinary planning. So the update, I will go to the update. So we are not yet, I have a slide missing, sorry for that. So we didn't yet publish any data. It is undergoing, but there are other data which is published 2026 and end of 2025. So by RATS 2025, ultrasound first, position ultrasound as a preliminary auxiliary tool focusing on cortical morphology and image-guided sampling, advocates structured scanning across levels 1 to 3 to standardize reporting and reduce inter-operator variability. So American Society of Oncology 2025. Also, they said surgical de-escalation for axillary surgery. Support omission of sentinel lymph node biopsy. I don't think it is yet in UK. In selected postmenopausal patients with a small HR positive, HER2 negative tumors, and clinically node-negative axilla when results will not alter adjuvant therapy decisions. In UK, Association of Breast Surgeons and NICE so agreed on personalized pathways, reinforce MDT-driven decisions, integrating tumor biology, imaging findings, and radiotherapy planning to balance minimal invasiveness with oncologic safety. Practice impact. Context to avoid. These updates align UK practice toward minimally invasive axillary management and provide the standards need to interpret and apply avoid study outcomes consistently across units. So the current landscape of auxiliary ultrasound practice across UK units marked by considerable variation in cortical thickness thresholds, which I already mentioned, ranging from 2 to 4 millimeter. This heterogeneity affect biopsy decision and lead to inconsistent identification of low volume nodal disease. Such variation bears clinical consequences, particularly as contemporary evidence suggests that many patients with isolated tumor cells, micrometastases, or even 1 to 2 macrometastases may not routinely need axillary lymph node dissection. UK audit data indicate that approximately 40% of axillary lymph node dissection specimens reveal only low nodal burden. This is very big data. 2 or fewer macrometastases, suggesting a potential pattern of overtreatment. This raised concern about avoidable morbidity, including lymphedema, shoulder dysfunction, and neuropathic pain. The rationale behind the avoided study therefore grounded in the need of national standardization, improved diagnostic decision precision, and the integration of imaging biomarkers that more rapidly predict metastatic burden. By analyzing cortical thickness alongside node count and correlating these with histologic outcomes, the study aimed to refine criteria that better reflect true disease burden. This approach could ultimately reduce unnecessary axillary lymph node dissection procedures while still ensuring accurate staging for safe oncologic management. So the aim I already mentioned before, I will not repeat. So study design, it is a prospective multi-center audit across multiple breast imaging units in England, Wales, Scotland, and Ireland, focusing on patients undergoing axillary imaging and biopsy within the avoid audit framework. Data collection and governance, data captured via secure RedCap with standardized entry, audit governance, and anonymized for publication. Each center obtained local audit approval to ensure ethical and institutional compliance. So the eligibility criteria of this audit inclusion newly diagnosed primary invasive breast cancer with axillary imaging and biopsy. Exclusion criteria, recurrent or metastatic disease to maintain a homogeneous cohort. So sometimes we start putting on the imaging and the data, and then in the middle we find the patient has metastases, for example in CT scan or MRIs. So we will exclude that in our study. It is only non-metastatic breast cancer. Data fields and thresholds, so ultrasound findings. So we document cortical thickness, the number of abnormal nodes, the biopsy results, the treatment modality, primary surgery versus neoadjuvant therapy, and definitive histology. So UHNM applied a consistent 2.5. So our unit in UHNM is 2.5. So across both phases until now, to enable direct comparison and link imaging parameters with histologic nodal burden. So measurements, it is measured at the maximal point on high resolution axillary ultrasound. So this is the measurement of all our cases. Clinical criteria of abnormal nodes. It is defined by loss of fatty hilum. We know that all of us, I think nobody have any missing information in that. But just to repeat, defined by loss of fatty hilum, rounded morphology, or focal cortical lobulation, and addition to cortical thickness. So if I find a lymph node with, like the example, for example, less than 2.5, 2 for example, but there is lobulation, focal cortical lobulation, then I will go for biopsy. Then biopsy outcome categories: result classified as benign LB2 or malignant LB5. Axillary lymph node dissection specimen analysis. So we enumerate total metastatic nodes, extracapsular spread, nodal burden as low, less than 2 macrometastases, or high, more than 2, because you will find this in the next slides, like low nodal burden or high nodal burden, just to know. Uniform definitions enable correlation between preoperative imaging and postoperative pathology, support longitudinal comparisons, and test the 2.5 threshold while noting limits of cortical thickness as a standalone predictor. The initial audit phase includes 35 cases, so we just repeated to increase the number, not to add anything else. So audit is to 35, 32 of which had complete data. The because some of the patients they are not here, they are outside of the country. Like one of the cases moved to India. We don't know what happened next. And one of the ladies not yet confirmed as metastatic. So the median patient age was 59, because all are cancer patients. So we think that it is probability of incidence, with most presenting symptomatic. So most patients came in symptomatic category. Ultrasound guided biopsy result indicate that 70% of sampled nodes were malignant. That means 2.5 is accurate or more than accurate. 72% of patients proceed to axillary lymph node dissection, which is not good. That means high burden of disease. Of these undergoing dissection, 56% were found to have low nodal burden, 2 or fewer macrometastases. The mean number of metastatic nodes per axillary lymph node dissection specimen was 4.8, although this figure was skewed by a subset of high burden cases. These findings support concerns that a significant proportion of patients undergoing axillary lymph node dissection may not have required extensive axillary surgery, but because we are following guidelines, not because of overtreatment. So particularly in the context of evolving guidelines favoring de-escalation, the data highlight the need for improved predictive markers to better stratify patients preoperatively and reduce unnecessary axillary lymph node dissection procedures. The audit also underscored the importance of consistent imaging criteria, as a variability in cortical measurements may impact biopsy rates and disease detection. Of the 32, this is in our audit phase. So over the 32 complete cases, 23 of 32 underwent axillary lymph node dissection, which is 72%. Among these, so this is, I think this repetition, I will go to the next. So this is just repetition of the previous, which is like 56% low burden of the disease, which is already discussed in previous slide. The re-audit phase expand the data set. There is nothing new in that, the same. So re-audit phase, 36 cases with 34 complete. The threshold remained 2.5, unchanged from the audit phase. Treatment was 56% primary surgery and 44% new adjuvant chemotherapy. Our focus here was to increase the data set for stronger evidence. This shows an abnormal node. So the re-audit phase include nothing new here. I will just jump. So the same, I think the same results. So we have 66% low burden. So 63% of the cases underwent axillary lymph node dissection with low burden disease. Comparing the two phases, so axillary lymph node dissection cases were 23 in audit, 24 re-audit. Low burden improved from 56 to 63, just lower improvement. And mean metastatic nodes dropped from 4.8 to 4.2. Neoadjuvant use rose from 40 to 44%. This table shows how expanded data strengthen our findings. This supports the hypothesis of potential overtreatment, particularly in neoadjuvant cases where fibrosis may indicate response yet still lead to axillary lymph node dissection. The slight increase in low burden from 56 to 63 may reflect increased neoadjuvant use or improved case selection or just coincidental. So this bar chart show distribution with peaks in 2 to 6 millimeter range for both phases, indicating most abnormal nodes are mildly thickened. The re-audit phase show a slightly flatter distribution, which is, I don't think there is a bigger difference in those phases. So the blue one is the audit phase, and the light blue is re-audit phase. I think they are similar bars. So this Pearson correlation. So just to give overview of that we just want to know if the cortical thickening correlates with a nodal burden. So this scatter give us a clear answer of no. So this one is not sufficient to, for example, if you find one node, the cortical thickening 5 millimeter, for example, does that mean the axilla will have more of those nodes or the disease burden is higher? No, because we can find a node with 5 millimeter, single node, no other nodes. And a lot of cases we have like that, like single 1 or 2 nodes with complete hilar effacement. And only those nodes are metastatic, rest of the nodes are normal. So in our unit, we have like 70% of cases are malignant. So that is correlate well with our unit cortical threshold, which is 2.5. But 11 node or 30% of them are benign. So at least this is not treatment, not neoadjuvant chemotherapy. If it is a biopsy and it is a benign, no problem in that. Re-audit is the same as audit, so 69% of cases are malignant. So what is the recommendations from this audit? Maintain 2.5 threshold nationally. We don't know what will happen, but what I can see in the audit rationale that they want to standardize it toward 3, because I think multiple institutions across the world have threshold of 3. So use ultrasound to correlate the thickening node count for TAD over ALND. Expand that dataset for robust evidence. I don't think there is any new thing in this slide. So this is just some selected cases. So this is example of a normal node with normal cortical thickening. So this is the cortex, and this is the fatty hilum. And I think this is no one can disagree with that. This is a normal node. So this lady is 88-year-old lady, non-left breast cancer, T3, M0. So imaging reviewed for repeat left axillary ultrasound after CT. So the CT showed, I didn't bring the CT because it wasn't significant. CT show left lower axillary enlarged node. So they bring the patient back for a biopsy, and we biopsy that node, and it is LB2. We know that it is normal. So this is, though, another example of a normal cortical thickening, but this is the cancer, and it is even, I think, extending to the skin. It is from here, I would say T4, but they give it T3 because on MRI there is no clear extension to the skin. But I mean, it is high grade. So lymph node was hypoechoic, and there is little bit of like peri-lymph node reaction. So this lymph node biopsied, and it was LB5. So we can say here, even 2.5 alone or cortical thickening alone is not enough to select a node for biopsy. And that was macrometastatic with extracapsular spread. So this is another example of a thickened node, small. The size is small, but very thickened cortex, and that was LB5 as well. So clinical implications, 2.5 millimeter threshold detect over 50% of axillary lymph node dissection cases in both phases and had low nodal burden, aligning with UK audit data, 40%. This supports the hypothesis of potential overtreatment, particularly in neoadjuvant cases, where fibrosis may indicate response, yet still lead to axillary lymph node dissection. Slight increase in low burden, 56 in the audit phase to 63 in re-audit phase. I don't think it is significant in our, because this is just selection of cases. Weak correlation between thickness and METs, number of METs or volume of disease in the axilla. Future directions enable stronger modeling and subgroups analysis to increase confidence in findings. Automated cortical thickness measurement, I don't think this is will be soon or near future because of financial issues. Align thresholds and outcomes internationally to improve comparability and care. Combine imaging biomarkers with tumor biology to personalize axillary management. So thank you for avoid steering committee, UHNM team and patients. Data collectors, Alan Musalihi was in the re-audit phase, my colleague, and Sudanese Society of Breast Imaging Women Health for giving this opportunity for presentation. Thank you.
Thank you, Dr. Wala. It's really very informative study. Thank you.
Thank you.
And now it is my pleasure to introduce Dr. Amal Hijazi, a consultant radiologist, chairperson of Public Radiation and Community Awareness Committee at the Egyptian Society of Breast Imaging, and founder of Lady Scan Radiology Center and former head of Radiology Department at Ayad Al Mustaqbal Hospital. Dr. Amal, mic is you. Dr. Wala, you want to add something?
سوري حتكون دكتور رباب هسي.
Dr. Rabab apologize to be the last.
Okay.
No, I'm not. I feel hypotensive. Sorry for that. I'm not well.
طيب
I
دكتورة
don't know if I can present it or not.
سلامتك يا رباب. Too much tension.
الله يسلمك يا نادي. الله يسلمك.
سلامات أجر وعافية إن شاء الله.
سلمك الله من كل
سلامتك يا رباب. دكتورة أمل عارفة إنها حتدخل؟
ما شايفها ظهرت. ما أنتي اديتيها الوقت متى؟
It is not in participant.
لا أنا لأني قلت لها 4:30.
أيوة أنا كنت ready والله، لكن حاسة بنفسي decline. حاسة نفسي هايبوتنسيف. شربت وبتاع ما حاسة في فايدة.
ألف سلام عليك دكتورة.
It's difficult. الله يسلمك. ما حاسة it's difficult to present يعني، حتى ما قادرة أرفع صوتي شوية زيادة.
طيب do you think إنه نعمل البانل هسي لحد ما دكتورة أمل تدخل؟
I think so.
Yeah.
Yes.
Yeah. Sure.
Okay, Sayyib. Now we will open the floor for discussion and question. Everyone feel free to ask.
لأي من المتحدثين لو في عنده سؤال.
Dr. Wala in her presentation say Dr. Ghassan if it for sentinel biopsy or something.
Yes, omission of sentinel lymph node biopsy in certain cases. I don't think it is yet in UK, but just I want to have overview.
Yeah, I agree. Yeah, it's not yet part of the guidelines.
صوتك ما واضح يا دكتور غسان. مستر غسان.
لحظة كده أحسن.
سامعينه بس خفيف يعني.
غريبة. دقيقة. ما أعرف. لسه كده الصوت ما كويس؟
أنا غايته سامعاه كويس.
والله بعدين لا كورك.
أتكلم بسماعة ولا بدون سماعة؟
لا لا، بدون.
أي عشان كده، لكن سامعاك.
It's
بس
okay.
لو قلت لك بسماعة هتقولي عشان كده والله. بس قلت لك يعني I agree in I still not part of the guidelines yet in the UK like outside trials. ال دي escalation اللي هو طبعا من الاكسيلري نوت كليرنس، وفي كتير من السيرجنز بيجوا حتى في الكليرنس بيعملوا ليفل 2 بس، ما
أيوة.
بيمشوا ليفل 3 اللي هو عشان كده مسمينه اكسيلري نوت دايسكشن زي الامريكان. وبعد ذاك حاليا اكتر دي اسكليشن حاصل اللي هو بوست نيو ادجوفنت، اللي هو الناس بقت بتمشي على التارجت اكسيلري دايسكشن اللي هو التاد. لكن طبعا الكيسز سelection ده هو اللي بيكون
البريك.
فيه شويه ايوه في ديفرنس بين السنترز. يعني currently احنا عندنا we select the patients لو البيردن اصلا low يعني up to 3 lymph nodes initially و only on triple negative or HER2 positive patients واللي هم ال end of treatment MRI ولا الكونتراست enhanced mammogram ولا complete radiological response. هم ديل we select them for التات.
إحنا برضو في
لكن
اليونت كده.
اوكي في يونتس طبعا اللي هو اي patient في الاند اوف تريتمنت كونتراست انهانس ايميجينج او ام ار اي ورا كومبليت راديولوجيكال ريسبونس ديل بيعملوا لهم تاد بغض النظر هل هم يعني البيولوجي بتاع الكانسر.
مم.
وهو دي الديفرنس. الحاجه الثانيه طبعا اللي هو السلكشن بتاع البيشنتس اللي بيمشوا ل البوست سنتينل نود بايوبسي اللي بيمشوا لراديو ثيرابي انستيد اوف دايسكشن radiotherapy of the axilla اللي هو ده again اللو بيردن 1 to 3
اللي هي دي
وبعدين
الأتنك، صح؟ أتنك ترايل.
ايوه ايوه. ف لكن طبعا لازم يكون في جود سامبلينج، وبعدين في سنترز بيقوموا لما يكون في اكسترا كابسولار سبريد they prefer انه البيشنت to go for axillary node clearance. وبرضه اليونج patients لانه at the end of the day هم بيكونوا الانكولوجيست عايزين يعرفوا البيردن عشان to decide والكلام ده، وبدي برضه البروجنوستيك انفورميشن بالنسبه الاكزيلي نوت كليرنس. في النهايه طبعا الناس لازم يكونوا عارفين انه هو ما ثيرابيوتيك، هو staging بروسيجر اكتر من انها ثيرابيوتيك بروسيجر. يعني الايم بتاع الاكزيلي نوت كليرنس از نوت تو كلير الاكزيلا. طبعا هي it does clear it يعني زي الدي بالكينج للكانسر لوكالي او increase the local control، لكن ده ما الايم. الايم هو staging really يعني to know how many lymph nodes وده will help guiding the adjuvant treatment و also will give the prognostic information. فعشان كده انت لما تعمل sentinel node biopsy وتوري انه في involvement in young patients the oncologists أحيانا they do want to know how many lymph nodes are involved especially if the patient went for adjuvant treatment لأنه حيكونوا برضو they want to know الريسبونس للتريتمنت. البيشنت عمل له sentinel node biopsy ولقوا عندهم 2 or 3 lymph nodes involved and decision to go for adjuvant treatment. الأونكولوجيست بيكون عايز يعرف الريسبونس to this adjuvant treatment and the only way to know is by doing axillary node clearance post adjuvant treatment.
Thank you.
Thanks.
رباب كانت رافعة يدها.
لا سوري بالغلط معلش.
اوكي.
أظن المتحدثين هبة ولا رباب الحسن دكتور لطيفة رباب بلة موجودين. إذا أي حد عنده سؤال لأي واحد من المتحدثين you are welcome لحد أمل ما تسهر. ولو حتى واحد من المتحدثين عايز يضيف على الكلام اللي قدمه بيكون برضو you are welcome. رباب الحسن قدمت كلام حلو شديد.
شكرا دكتورة.
آه،
شكرا
لو
جزيلا.
عايزة تضيفي لنا لو عايزة تضيفي زيادة.
والله
دكتورة لطيفة لو عايزة تضيف برضو حاجة عن الفاكيوم. هبة you are welcome every one of you.
والله
اتفضلي.
الإضافة الوحيدة اللي أنا عايزة أضيفها يعني لأنه زي ما قلت أنا في البرزنتيشن إنه الدنس بريست is problematic في السكرينينج. ف وكثير من السكرينينج بروجرامز are not addressing الحكاية دي. لكن أنا من تجربتي هنا في السعودية so far we found the value من إنه to recommend يعني supplementary screening with ultrasound في الناس اللي عندهم very dense breast خصوصا إذا بقى عندهم increased risk of breast cancer. I think إنه الحكاية دي ممكن في السودان يعني تكون helpful خصوصا الالتراساوند متوفرة يعني ما فيها مشكلة كبيرة في
بس unfortunately الماموجرام ما متوفر أساسا.
ف
يعني أساسا السكرينينج موداليتي والديagnostic modalities ultrasound.
يس 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 ف يعني يعني نعاين للجانب الفول بارت اوف ذا كاب يعني انه الناس خبرتهم في الالتراساوند بقت كبيره. ف
You
we
are right.
yeah we should use what we have يعني. ف I think إنه يعني in the absence of إنه ما في MRI وما في ماموجرام زي ما قلتي. فالناس اللي عندهم سكرين يعني increased risk لأنه أنا قابلت كيسز كثيرة صراحة من السودان يعني الناس بيبعتوا لي في الواتساب وكده. ففي ناس كثيرين عندهم at high risk of getting breast cancer يعني at least
You are right.
the
You
ultrasound
are right. You are
we are doing
right.
something يعني.
We have young age affection and we have familial type of breast cancers. Okay. Increased risk. Yeah, you are right.
I think إنه إذا ما في حاجة ما في if there is nothing to do for them at least to do something with ultrasound يكونوا بس عارفين aware of clinicians well patients alike يعني يكونوا aware إنه ال ultrasound can still miss the lesions لكن still is better than doing nothing يعني.
والله يعني expert hand يعني I think can help a lot. It needs the radiologist to be patient and to gain experience, to be aware about the sonographic anatomy, and then to build experience. He can solve a lot of problem.
والله حتى يا دكتورة حتى السونوجرافرز نفسهم I think إنه if utilized properly ممكن يساعدوا في الحكاية دي خصوصا في السكرينينج setting يعني. ف يعني I think إنه we don't يعني we shouldn't be following ال practice في other countries blindly يعني. المفروض
Definitely,
نعمل
you're right.
الحاجة اللي بتناسبنا وتناسب وضعنا وإمكانياتنا
Definitely.
بالنسبة لنا.
You are right. You are right. بس هدول المشكلة إنه التكنولوجيست يعني they are not under control.
Of course.
This is the problem. ما الشغلة دي يعني البريس ultrasound ده يعني البريس dedicated organ يعني والimaging بتاعه are specialized. It's not just a general imaging. It needs experience. It needs dedication. But they need to be يعني under guidance. They cannot work يعني without guidance. They will create problems. And we have seen a lot of missing cancer reported by technologists.
Yes. A general problem عندنا.
هبة عثمان ولا دكتورة نادية دكتورة لطيفة are you there? Would you like to add any comment?
هي موجودة. لا والله ما قصرتوا وقلتوا كل النقاط almost يعني، فأنا قاعدة أستمع وأستفيد. الله يعطيكم العافية.
الله يكرمك. If you want to
سلامتك.
add any information,
سلامتك.
الله يسلمك يا دكتورة. If you want to add any information regarding your topic even, if you want to add something, this is chance.
Well, I put all my experience in the lecture actually. I tried to mention all the points in the lecture.
ما قصرتي والله ما قصرتي. كانت لكشر رائعة وممتعة جدا، استفدنا منها كثير. ما قصرتوا، لكن بس يعني it is chance if you want to add any points.
سلامتك دكتورة رباب، يعطيك العافية.
الله يعافيك يا دكتورة، الله يسلمك يا رب. المفترض كان أقدم في الزمن ده المحاضرة، لكن هبطت والله معلش.
إن شاء الله مرة ثانية ما في مشكلة.
إن شاء الله نعمل ويبينار. نخلي التوبيك يكون ميست بريست كانسر، كل واحد فينا يقدم الاكسبيرينس بتاعته.
حلوة فعلا مو توبيك حلو والله.
ايوه ميست بريست كانسر في كل الموداليتيز، وتكون فرصة لانه كل واحد يجمع الحالات بتاعته يجي يعمل لها برزنتيشن، فبتبقى حاجة الناس كلها بتستفيد منها. فدي النيجاتيف الفولس نيجاتيف MRI اللي هي ميس بريست كانسر ممكن نقدمها في الويبينار ليتر ان شاء الله لو ربنا احيانا. عندي محاضرة جاهزة التراساوند وماموجرافي في 3 موداليتيز، ممكن كلها نقدمها في الويبينار ان شاء الله لو ربنا احيانا، بس الله ما اراد. أمل لأنها في العيادة على أساس إنه كنت أنا حقدم، هي قالوا لا بعد ساعة، فكتر خيرها يعني إنها هي willing إنها تزيدنا من الإكسبيرينس بتاعتها. دي فرصة ما نضيعها. مستر غسان ما مشكلة، حتى ممكن سيرجري يعني يعني ما إلا راديولوجي بوينت you can comment حتى لو حاجة سيرجري. نادية باثولوجي، ما شفتيني يا نادية جدعت في السلايد بتاعتكم، ما أكون عملت قلت لي حاجة ما في محلها.
لا ما في لا correlation تمام. No, it is what you are saying radiology applies. أنا حاسة بتكلم من ناحية السيستم والavailability. It applies so much in pathology. We are also led by systems, by guidelines, by society setting rules, and the problem in Sudan is very similar. We also have this problem with the technologists, although in histopathology in the lab is the least area of problem, because they realize very well that they cannot function without histopathologists. But we have the problem is becoming more and more, and now the war has accentuated it, of course, in the other branches, micro and especially hematology and chemistry. So it is a big problem. We have our own issues in Sudan, and I agree with Rabab Hassan that we need to make our own set of rules. Of course, we are guided by the international guidelines, but we have to adapt them and try to fit them into our system and what is available. In the end, we have to upgrade. الكان حاصل لغاية حسي ما ينفع يستمر.
You are right.
بالنسبة للreporting عندنا a good thing because the international reporting system is being sort of initiated all over, and it also guides how we grow specimens. But once it is an international, it's not the choice between using the cap or the Royal College. This was our issue in Sudan. So now if we try to adopt the international and join the world, it would be very good. Inshallah khair. I hope it continues to improve. We have always to hope for the best. Inshallah.
Inshallah. Inshallah. Hiba Usman, would you like to add anything for your nice presentation? Nice topic.
معلش يا رباب، ما قدرت أفكر في حاجة لأكتر من 24 ساعة صاحية، خلاص مخي قفل.
انت
Well,
انت
I was
انت بس
wondering if I
انت
was wondering
بالذات ما عندنا كلام يعني غير انه نسلم لك في راسك يا هبة. انت انجحتي عادة السيمبوزيوم ده يعني.
والله الله يديكم العافية بجد. سبحان الله، يعني علم تقيل يعني بجد. الحمد لله إنه توفقنا وقدرنا نعمل له ريكوردينج عشان يفضل، عشان نقدر نسمعه تاني، عشان نستفيد من
ايوه
خبرات الناس كلها ومن الكيسز الجميلة ومن وعشان نتطور وما نقع في نفس الأخطاء ونمشي لقدام إن شاء الله بإذن الله.
والله أي محاضرة كانت أغير من الثانية. بعدين الناس كلها ما قصرت. دكتور عزيزة والله تعتذر شديد، يعني ظرفهم قالت أمطارهم حاجة صعبة شديد ومؤثرة على الشبكة، يعني حتى ردت متأخر إنه ما كان عندها شبكة. الغريب إنه قبل يومين كان شبكتهم شوية أفضل في العيد. ردت لي المسج بتاعت المعايدة يعني، لكن بعدها شكلهم انقطعوا. دكتور خالد قال لي كده، فرسلت متأخر إنها بتعتذر إنه فات، يعني إنها كان بودها إنها تكون مع الناس وتحضر وتقدم، لكن إن شاء الله وعدت إنه في جولاي، سيمبوزيوم جولاي إن شاء الله تشارك. يا جماعة إن شاء الله جولاي حيكون عن advanced breast cancer إن شاء الله. فكله حد يفكر له في topic related with advanced breast cancer. رأيكم شنو نعمل الجمعة والسبت زي زمان؟ أخلي الراديولوجي يوم الجمعة زي أول، لأنه شايفة حتى في السبيكر في واحدين شغالين لأنهم شغالين برايفت، يعني دكتورة أمل الدكتورة مريت الاثنين برايفت سيكتور، فعندهم شغل يوم السبت وكثير من الحضور شغالين برايفت.
هو عموما بس يومين شوية صعبة، يعني أنا why not one day، ما أسهل.
نعم.
هو يومين دي شوية صعبة عموما in general يعني.
نعمل الجمعة والجمعة، يعني نعمل الجمعة والجمعة البعدية نفس الموضوع. يعني مثلا الراديولوجي يكون يوم الجمعة، والجمعة البعدية تكون الأذر disciplines. زي السبت الجاي هيكون الأذر disciplines، الإعادة بتاعنا السيرجري والأونكولوجي. كويس إنه ناس المحاضرات الباثولوجي يعني تسجلت الحمد لله في أكتوبر، لكن الجراحة الجراحة والأونكولوجي ما سجلوا، فهيكونوا السبت الجاي. حتى نفكر فيها إن ننزل في الجروبات مقترحات ونشوف يعني بيصوتوا عليه والناس نمشي عليه إن شاء الله. انتي قلت لها الساعة كم أمل يا هبة؟
قلت لها
كان في
4:30.
حاليا ها؟
قلت لها 4:30.
يعني مواعيد جات
يعني هسه 4:30 exactly.
بتسهر بعد ده،
آي.
بتسهر لا
أنا
تكون
ما
شغالة بيها، بتسهر
آي.
ما دام انتي قلتي لها 4:30 خلاص.
آي. رسلت لها كم مسج. مم. يعني من الساعة 4:10 ما كانت بتشوف المسجز.
اوكي نديها شوية كمان، لأن هي كانت يعني جزاها الله خير متحمسة إنها
أيوة
تزيد.
بس ممكن تكون مشغولة مع بيشنت وحترجع إن شاء الله.
exactly لأنه هي قاعدة في العيادة.
مم. أو شوفي إذا أنت عايز تديها رنة يا رباب نتأكد إنها حتدخل ولا لا.
لا ما هي وعدت مازن هنا، يعني في الحالة دي حترجع هي تقول تعتذر. أنا رنيت لها لكن ما ردت، فشكلها زي ما أنت تفضلت يكون بعيدة من التلفون مع بيشنت. نديها شوية كمان معلش. بالنسبة للبريست كانسر، يعني أنا بس كان نفسي إنها أكون أحسن شوية. كان ممكن أعلق على النيو كلاسيفيكيشنز بالسايت اوف اوريجين ده. this is a new trend والآن اللي هم مركزين عليهم، وده emphasize the role of radiology and biomarkers to يعني to guide في الaggressiveness أو غير الباثولوجي from radiology to suggest which disease is aggressive and expected to upstage and which one is not. starting من الماموجرافي الالتراساوند and MRI. إن شاء الله نحاول نحضر فيه dedicated lecture بس في النيو classification. دكتورة ولا موجودة ولا الزبير؟
أيوة موجودة، بتفتش في
هاي
الأنميوت ما
كده
لاقية.
كده كلمينا أكتر أنت عن الأوديت بتاعك ده والكونكلوجن والبتاع والهنا وصلتوا في النهاية. كلمينا يعني شوية in depth عن
هو
الحاجات اللي
لسه
وصلتوا ليها.
منتظرين إنه يعمل ببلشمنت، لكن
نعم.
عموما هو لسه ما published، يعني ما finished. ما كل البريس يونس طلعت نتائجها وعملوا له publish وعملوا أي change in criteria ولا change in practice.
طيب انتوا بالنسبة للديبارتمنت بتاعتكم.
so في الديبارتمنت احنا ما اصلا السايز كرايتيريا بتاعتنا من اقل يعني الكرايتيريا اللي هي 2.5 الكورتيكال ثيكنينج، فما غيرناها. لكن سيرجيكال وايز نازل اصلا عندهم ترايلز على ضوءها هم حاليا. البراكتس اصلا اتغير لتارجتد اكسيلري دايسكشن حسب لسلكت كيسز، زي ما الدكتور غسان قال لك هم عندهم بيختاروا من الام دي تي اللي هي الحالات اللي فيها تيومر بيولوجي معين وابنورمال لينف نودز معينه اللي هي اقل من 3 up to 2، فديل بيختاروهم لتارجت اكسيلري دايسكشن. هم عموما في السيرجري غيروا براكتس قبل الاوديت يعني.
مهم.
فالاوديت ده لو طلعت ببلش الداتا بتاعته على ضوءها هيتغير الراديولوجيكال اسسمنت ل ستاندرد بتاع كورتيكال سيكانين اللي هو 3. هم الان يعني proposing انه يكون 3 all over UK.
يكون
3
كم؟
ملم 3 ملم
3.
تقريبا ناشونالي انترناشونالي السايز ده الناس معتمدينه اللي هو 3
ده
ملم.
أصلا معتمدين الثري. أيوه
ايوه فهم هسه هنا في يوكي تخيلي اليونتس، في يونت الستاندرد بتاعته وفي
احنا كنا
يونت.
كده، احنا كان ستاندرد بتاعنا 2
ايوه شفتي انت في ليستر صح يا رباب؟
في تشيستر.
يستر ايوه. ف... فاليونتس مختلفة يعني كل يونت
ما هي
عندها
الفكرة مع الكورتيكال سيكنينج انت بتشوفي معاه الاذر فيتشرز، يعني ما
ايوه.
الكورتيكال
لكن في
سيكنينج
ناس بس
الون.
الكورتيكال سيكن 2 ده يلا على طول بايوبسي. تخيلي يعني تخيلي الكم الهاي بتاع البايوبسي اللي هم بيعملوه.
لا كده بتبقى ما طبعا
ايوه
ممكن
ما
يكون تو لكن تكون مثلا فوكال او asymmetric
abnormal. ايوه
او
abnormal
deeply
focal. ايوه
hypoechoic او
ايوه
indistinct او perinodal edema او focal peripheral vascularity. يعني a lot of features it can be يعني raising our upstage lymph nodes مع الكورتيكال سيكنينج. بس 2 مليمتر كورتيكال سيكنينج and biopsy معناها فعلا دي biopsy ده lot of lymph nodes. لكن حتى أنا شفت
ايوه
كيسز الليمف نود بياخدوا البيوبسي خلاص they are not targeting الساينس أو البرينكيمال الانفولved يعني. بس الليمف نود suspicious اتاخد منها FNAC وما يكون targeting يعني the area which is suspicious. فالليمف نود ممكن تكون reactive، كلها تكون reactive وفيها just يا ده starting الميتاستاتيك ديبوزيت في حتة معينة وباقي الليمف نود ما فيها ميتاستاسيس.
هو الاكسلري، الاتجاه
can give
الاكسلري.
false negative. ها
هو
ايوه يا
الاتجاه
رب.
الاتجاه الاكسلري دي escalation actually increase الورك بتاع الراديولوجيست وليس العكس يعني.
ايوه صح.
يعني we are more careful assessing the axillary lymph nodes one by one. we felt at least in our unit previously we felt انه يعني حسينا انه البريشر بتاعنا علينا بقى اكتر، يعني اذا كان في indeterminate lymph node واذا كورتكس 2 to 3 ملم فاحنا بناخد بايوبسي ومضطرين ناخد ماركر عشان بعدين اذا طلعت بوزيتيف هنجي تو ماركت اجين اذا ما كسيت. فالشغل بقى اكتر على الراديولوجيست اي ثينك ما اقل يعني.
صح I agree. بس على الأقل أنت لو يعني ما عملتي بايوبسي أو ما عملتي further action في الأكزيلا في patient وانت حاسة انه الاكزيلا نورمال، ما بيكون عندك تساؤلات انه انت عرضتي العيال مثلا like local staging problem، لأنه already العيان لو up to 2 nodes abnormal ما not for axillary dissection. على الأقل أنت safety wise عارفة إنك
Of
أنت
course, yes, of
أيوه.
course, yeah, of course.
لكن البروبلم هي يعني عندنا هنا إنه ما كل اللي بيعملوا السكانين هم radiologist.
Yes.
فعشان كده لازم يكون في ستاندرد عشان هم بيمشوا بس بال 1 2 3.
Yes. Yeah. لكن طبعا هو I agree، لكن هو يعني البريست ورك بالذات هو فيه جزء كبير experience based. ف we tend أحيانا from experience كده you tend to ignore يعني
أيوه.
أشياء مثلا في الجايدنس. you put yourself at risk of إنه to be argued في ال MDT. Yes, of course, definitely. لكن we did biopsy a lot of stuff based just on experience of يعني you know that sense of I just don't like this and you put a needle in and وتطلع لك في الآخر breast cancer. ففي حاجات
معلش يا رباب قلت شنو؟
بقول لك إنه في حاجات بتعتمد على الاكسبيرينس أكتر من يعني الجايدنس as such.
Yeah, you are right. I agree with you. Totally agree with you. Yeah.
أحيانا كتير بتعملي أنت you take the decision to take a biopsy based on your experience, on your that feeling of yeah I just don't like this and you
Yes.
biopsy and you get يعني all sorts of stuff. ف فيس الجايدنس important مهم طبعا definitely أكيد يعني وبيديك الجاستيفيكيشن إنك أنت if you don't for example in this case you don't biopsy the axilla and you say to say that well the recommendation is to biopsy above this certain limit. لكن أحيانا كثيرة أنت you just do it because you feel it is the right thing to do at the time, especially في fast track clinic where you have like few minutes to take a decision. فدايما we tend to take the decision which زي ما المنتورز بتاعنا بيقولوا makes you sleep at night. فما بتكوني عايزة انك انت يعني تقولي للبيشنت it's fine وبعدين تبتدي تفكري في الموضوع و to consider it further وكده. ف
كلامك صح والله. You're right.
أتذكر مرة جاتني عيانة ذكرا يعني للفيلينج بتاعك والقلب بتاعتك،
فعلا
فجات
الحاجة بتخلي الضمير مرتاح، الإنسان يقدر ينام مرتاح، ما في أحسن منه. طيب what do you think يا جماعة؟ دكتورة أمل دي ما ردت، لكنها she promised إنها تقدم another يعني more cases. لكن شكلها إشارات. فرأيكم شنو؟ تدوها more 10 minutes ولا نختم
ممكن تقدم في الأذى يعني الكامين activities.
أنا personally reply I have to leave now. I'm so sorry. It was nice talking to you all. وإن شاء الله نلتقي في
أيوة هنعمل ويبينار عن الميست بريس كانسر يا دكتورة رباب. حضر الكيسز بتاعتك
إن شاء
your
الله.
missed cases يعني
رب
عشان الناس تتبادل الاكسبيرينس.
إن شاء الله ربنا يسهل.
لا قلت شنو؟ ضحكتي؟ قلتي حاجة ضحكتي؟
ربنا والله طبعا صعب يعني لانه انا طبعا جديده لسه في البلد فما عندي a lot of cases يعني ما بنيت الستوك بتاعي من الميست
لا
بريس.
من زمان ما حصل جمعتي
not,
هنا
not,
cases.
not really not
أنا
really.
أنا the first breast cancer I have missed in my experience محتفظة بها وقاعدة في الليكشر بتاعت الميست ماموجرافي بريست كانسر والماموجرافي. ما ناسيها، مذكرة الآن بعاين فيها كده قدام عيني. أول واحدة I have missed in my experience.
ف
It's unfortunate يعني to miss breast cancer لكن it's reality of life isn't it؟
نحن هسه قاعدين نشوف ميست بريست كانسر كتير خالص خالص مع الإيبس، لأنه لسه يعني في generation نحن بدأ عندنا من 2006 ولا 10.
tiny.
Yeah, it is. This is the problem يعني حقيقي. وبعدينك لأنه الإيبس إذا ما ركزت فيه it can wash out the lesions، بتحس بها إنها could be cystic very hypoechoic and then you think it is a cyst and then بتلقاها إنها لا كانت true lesions. it's really يعني في الأول أنا أول ما بديت أشتغل الإيبس حسيت إنه like a waves، لأنها هي like a scene images many scene images بتتفرج عليها. it's hard في البداية، لكن بعد ذاك you build your experience and then you know يعني how to call. and then عندنا برضو في الإيبس المشكلة إنه dense tissue is like a dense breast is a disaster everywhere. like you see tissue that is very dense and shadowy and then it might hide a cancer also in the ibis, so it is challenging. and بعد شوية كده مثلا هي جات لي
Despite that, they said it is helpful in dense breast.
It is very helpful. يعني يعني أنا ما بديت طولت في الإيه بس لي 3 سنين يا دوب، لكن يعني I detected small lesions small as 3 millimeters lesions في الإيه بس. It's very helpful صراحة. and never ever يعني حتى لما بشوف مثلا الليجن في 10 o'clock في الالتراساوند and then I go back to the mammogram أحاول أطلعه في نفس المكان يعني عشان just to build my experience وكده. it's impossible إنك كان تشوفه حتى نحن كل البيشنت every single patient بنعمله تومو، ما بنعمل 2D anymore. فحتى في التومو sometimes you cannot see it. يعني if it is mammographically أقل حتى الماما ممكن يساعد، التومو ممكن يساعد، لكن برضو still there is يعني 15% of the cases are
sensitivity. It has very high sensitivity. It has very high sensitivity.
It is
definitely like any imaging, it needs experience.
Yes,
it needs experience. breast imaging in general needs experience يعني من غير experience is tough and difficult يعني very tough and difficult and the most challenging for radiology is the most challenging area.
Yeah, agree with you.
Yeah, I think
we can conclude with that. Yeah,
you can conclude it وأرسلي لها مسج واعتذار يعني إنه نحن قدرنا ظرفها إنها هي انشغلت وانتظرنا 40 دقيقة وبعد ذاك طبعا الأودينس ليفت وكده. فالمهم نتوقع في السيمينار الجاي إن شاء الله، في أول سيمينار جاي
إن شاء الله.
we can conclude، نخلي الناس تريح. أسمعي وأولهم أنا مهبطة وبقاوم إني أكمل معاكم لآخر لحظة.
الله يديك العافية، تسلم يا رب.
آمين يا رب، آمين جميعا.
If you want to close, yeah.
Yes, okay. As we're coming to end of this symposium, I just wanted to say how truly grateful I feel to be part of this moment, and I would like to express my sincere appreciation to all speaker, organizer, and participant who made this event successful. Your time, effort, and dedication in preparing and delivering such insightful presentation and are truly appreciated. Each contribution add great value in this symposium. Thank you once again, and we look forward to seeing you all in future event.
Thank you for all of you.
Thank you very much.
We enjoy it. رغم إنه it is a repetition but كأنه ما يعني ما repetition والله. We enjoy it too much. شكرا لكم يا جماعة على السبورت. شكرا لكم
شكرا
جميعا.
جزيلا، الله يديكم العافية يا رب.
الله يديكم العافية، كتر خيركم. نستودعكم الله، نلتقيكم قريب إن شاء الله.
يعطيكم العافية، مع السلامة.
الله يسلمك يا دكتورة،
شكرا
الله
لك،
يكرمك.
تسلم، في أمان الله.
في أمان الله.